Good morning, everyone. Happy St. Patrick's Day to everyone who celebrates and to all of you. It's wonderful to see you here this morning. We have a nice long list of people we were looking forward to hearing from today during our hearing. And before we begin, I'll turn it over to you, Mr. Co-Chair, Senator Elmore.
Thank you so much, Madam Chair. Welcome, everyone. And I hear that the people who are wearing green today will get extra 10 seconds to speak. Welcome, everyone. Thank you.
Thank you, Senator. Representative Claridis Detria.
Thank you, Madam Chair. Welcome, everybody. I'm not Irish, but happy St. Patrick's Day. Let's have a fruitful discussion. We have a lot of things to discuss. Thank you, Madam Chair.
Thank you very much, Representative. And as we often say, members are in multiple places at multiple hearings and committee meetings. And so we will see people in and out, but rest assured that we all pay close attention to what you share with us here in testimony and in written testimony. So with that, we'll begin with Commissioner Nancy Navarrete from our Department of Mental Health and Addiction Services. And Commissioner, as you're getting seated, I will note that there are a number of folks from your agency here today, I know, who have signed up and are available, I think, for backup questions. Is that correct?
Just for backup, yep.
Wonderful.
They won't be testifying separately.
Okay, thank you. Welcome.
Thank you. Good morning, honorable members of the Public Health Committee. I'm Nancy Navarrete, Commissioner of the Department of Mental Health and Addiction Services. Thank you for the opportunity to provide testimony before you today. You have my written testimony on 4 bills before you. So I'd like to summarize briefly and then would welcome any questions. First, I'd like to speak on SB 1509, an act concerning patient protections and standards of care at Connecticut Valley Hospital. Connecticut Valley Hospital is a DMHAS operated facility. It has over 360 beds, is Joint Commission accredited, and provides behavioral health inpatient care in both general psych and addiction services. As the bill is written, it proposes mandatory separation of individuals at CVH undergoing psychiatric evaluation based on biological sex. In current practice, individuals sharing rooms are placed with the same sex. Other therapeutic activities and living areas are not specified by sex. We go into more detail in our testimony, but our most significant concern with this proposal is our ability to operationalize it within current resources and our actual physical plant. We do not have the staff, space, or funding to provide completely separate services based on biological sex, and do not have concerns, or we have not heard any concerns from our patients either, about the way services are currently provided. For these reasons, we do not support the language as written. We invite further discussions on the impetus of the bill so we can address any underlying concerns. Next, I will move on to SB 1507, where our specific concerns are in Section 2. This appears to try to limit healthcare facilities and licensed entities from directing actions of certain healthcare providers. Again, as written, the bill identifies DMHAS as a regulatory agency that licenses facilities. In fact, we are a healthcare agency providing direct services to patients. We operate 2 hospitals and 6 behavioral health facilities, 3 of which provide inpatient treatment, among many other funded services. In order to understand the true impact of this bill on our agency, we would need to understand if DMHAS is included as an entity that would be subject to these new restrictions. If so, we would also need more context if this were meant to apply to any clinician employed by DMHAS. We look forward to more conversations on the underlying intent so we can provide feedback on the operational implications for our agency. The third bill I'd like to speak on is HB 7215, an act concerning problem gaming. This bill proposes that DMHAS establish a treatment program for internet gaming disorder. While this is an emerging issue of concern, especially for our youth or children under 18, this diagnosis is not yet recognized by the DSM-5, that is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. So it would be a bit premature to develop such a program. In addition, this would have a significant unbudgeted fiscal impact to our agency. While we respectfully request no further action is taken on this bill, we want to show our appreciation to the committee in trying to proactively address this issue, and will continue to closely monitor the research conducted by the American Psychiatric.
Excuse me, Commissioner, but you've reached your 3 minutes. Thank you.
I do have green.
Yes, sir.
We That's so wonderful. We would really love for you to continue, especially since I think there are 10 different folks who have signed up to testify.
Okay,
So please continue and share the rest of your remarks with us.
sure. Finally, I would like to conclude with HB 7214, an act concerning maternal health. DMHAS applauds and supports the bill's focus on the behavioral health of individuals during the perinatal period. At DMHAS, we have dedicated significant resources to advancing improvements in this area and are acutely aware of the challenges faced by those who experience behavioral health struggles during pregnancy and the postpartum period, as well as the long-term effects that untreated conditions can have on both parents and children. We are excited for the opportunity for collaboration and partnership in this area and would be happy to participate or provide subject matter expertise on the proposed task force if it does move forward. Thank you.
Thank you very much. I know there are a number of questions. I have a number. I'll start out with a few and then turn it over to my good co-chair. And I will start with the issue 7215, so gaming and gambling. And you certainly raise a very important point in terms of the diagnosis. Can you talk to us a little bit about what DMHAS is doing currently when it comes to problem gambling or it's just precursors, which I think this is one of the things that we've talked about, and how you're working in conjunction with some of the other agencies to do some of that prevention work?
So we do have an entire unit that focuses on problem gambling. We do prevention and treatment and recovery support services for this population. We contract with providers in the community. We take an integrated approach, so integrating problem gambling assessment and inquiry, as well as intervention into our mental health and substance use clinics throughout the state. We actually do have one inpatient bed to treat the disorder and do a lot of work in prevention in this area as well.
Commissioner, thank you for that answer. Will the proposed cuts in the appropriations budget impact that unit with the prevention?
Actually, no, these particular positions are in the gambling, problem gambling unit itself.
Okay, so thank you. Thank you for clarifying that. I appreciate it. Going on to talk a little about maternal health, and again, I know you were going to have questions from other members. We appreciate your willingness to participate and be a part of that conversation. Can you talk a little bit about any of the other groups or work that you all have been engaging in related to maternal health that might complement this?
Sure. So we do a lot of collaboration with our partners at DPH and DCF around this population. One of the initiatives that we're very front and center on is a substance exposed pregnancy initiatives. SEPI is the acronym for that. There is a 5-year strategic plan that is co-led with Department of Children and Families. We have peer navigators in the community for this population. So every region of the state has access to 3 peer navigators. We do specialized treatment programming for pregnant and parenting women, where women can actually bring their children with them for substance use treatment. We brought up recently an access mental health for moms, which is a near real-time consultation for any provider that is working in the community, whether they're in behavioral health, OBGYN, a PCP, for example. They have a question about this population. They can get real-time consultation from our colleagues at Yale. We're also involved with many other task forces around maternal mental health and the maternal mortality review committees as well.
Thank you for that. I think one of the things that we've talked about here in this committee and in many other places is making sure that we are building upon work that is happening already, and interested in having your input about how we can best do that, while also making sure that we are particularly focused on those who are most at risk. And we know we've got real disparities in outcomes for our Black moms, for moms of color, and particularly with some of that work, which of those are most primarily focused on helping to address those disparities?
And we would certainly be willing to meet with anyone who's interested in hearing the full array of task forces that were involved in strategic plans, along with our partners at DCF and DPH. We are involved in all of those initiatives, and we can either send that to you in writing or we can meet with folks if they're interested.
That's wonderful. Thank you for that. I will turn it over now to Senator Omar.
Thank you. Good morning, Commissioner. Thank you for your testimony and the work that your department does. Commissioner, your written testimony, later we need to know which bill did you submit it under. I'm trying to look at the written format. I could not find it yet.
Separate for each one. I think 2 had just gotten approved, so they may be on their way.
Okay, so they're not hit the site yet. So we'll look for and read for that as well. I wanted to ask you about the gaming bill. So you said it's not yet classified as a disorder. Which classification you're looking at?
At the DSM. So in the DSM, it's under further review. So the APA will continue to look at that and gather more information, but it's not yet a diagnostic category.
So it's likely to be part of DSM soon, from the sense of it.
It could be in the future. Yes.
This is a epidemic that's looming. And unfortunately, what we are seeing is that our next generation of young boys and girls are heavily involved in internet gaming, and their behavior pattern is very classic with, unfortunately, with gambling, kind of an addiction. This is something that DMHAS is far better equipped to do than DCF or any other agency. So when we are waiting for the classification to be there, it's because of the financial reimbursement from the federal government. Is that the reason, or?
Well, we don't have the expertise yet in this because there isn't a lot published on it. There isn't any evidence-based practice on it. And certainly DMHAS would lead in the future any prevention efforts, since that is our statutory responsibility. We do prevention across the lifespan. If it were to include treatment per se, that piece of it would fall under DCF, since they do treatment for 17 and younger.
So initial features are suggestive that it's treated like gambling disorder. And obviously this is an emerging issue, and unfortunately the pattern right now suggests that we will be having conversation on this topic for the next many years. But we are hoping to get ahead of it if we can, and we will need your help, because your DMHAS has been far effective and a resource for gambling, and because if you're drawing the parallels and similar patterns, we feel that's going to be an opportunity for us to use this. So we probably want to continue conversation on this, because we know it's a problem. Just because it's not classified because of the technicalities from the various experts in the country, we don't want to create a disadvantage for our young boys and girls who are getting addicted to gaming right now, to the level that it's impacting their abilities to perform. I mean, that's the actual issue. So we will need your help, and just my opinion, I don't want to let this go and then have something this session so we are better prepared, so that otherwise we will be catching up. And I'd rather not have to catch up and change the trajectory of some of our citizens' lives and move them in the right direction. So Would love to engage with you if that's okay
Sure.
with you. The other part, I think 1507, your point is well taken. I think that's an error. That's the part that we had you as one of the licensing agencies. So that was not the intent at all. I want to talk a little bit about the hospital beds. You said we're licensed for 360 beds at CVH.
We're not licensed or Joint Commission accredited, but yes.
So how many are active right now? Do we know?
We're usually 90%, 100% full.
Okay, and I think one of my colleagues will probably speak to this because there was an incident where in the same floor, a woman who was abused by a male individual were in the same floor. And that caused a bit of a concern. And then here the person was going through a significant negative impact from the abuse that she had undergone. And there was a very uncomfortable situation that, at least from what I've heard, became an issue. And that's why we wanted to have a conversation around this particular bill.
So I can't speak to any particular case, but we do, everyone in terms of roommates would have a roommate of the same sex. We also have many single rooms. Certainly, we are trauma informed, and so we would work with any individual that felt uncomfortable in a particular unit or room assignment. Most of, we have about at any one time at Whiting, for example, 22% females. So Whiting has a smaller percentage of females. And same thing at CVH. Operationally, we just couldn't duplicate the space to completely separate folks. We have a portion of our units which are co-ed, portion of our units which are male only, and then we do have one female only unit in our addiction services.
Do you think it's reasonable if somebody is a victim of domestic abuse, to see if they could be separated in a manner where the theoretical risk would decrease significantly so that it does not negatively impact their well-being and then make them worse?
Absolutely. That would all be a part of an individual's treatment plan or assessment. Our clinicians are very adept at being trauma informed and making sure that people feel, male or female, feel safe in the place where they're getting treatment.
Thank you, Commissioner. And Commissioner, there was a recent report from disability rights groups about DMHAS and some of the challenges that are around that. How is the DMHAS responding to that?
So we did respond to that and we refuted all of the allegations that were made. In addition to that, we've made several enhancements to that unit. As you know, we've had a change in leadership there. We put an additional manager on the unit that is making sure that all protocols are followed, in addition to our baseline Joint Commission accreditation standards and just our standard of care, which is quite high.
So, Commissioner, I'll just make a comment. I think in 2025 and beyond, your department has huge responsibilities. And I'm concerned because the budget has reduced the support that you have. You may not be able to comment too much about it, but at least I can. That at a critical time like this, when the needs are so high, to take the resources away from the agency that is the best equipped and in some aspects of your care is leading the country, is unfair and it's wrong. So I just wanted to make that comment. And I feel we have a responsibility as a legislative body to provide you all the tools, including the financial support, to be able to continue to do the good work that you're doing, but also enhance some of the areas of concern that at least the disability rights groups have identified. And then sometimes we don't want the lack of resources to cause more problems for our vulnerable people. So.
Thank you for that. And certainly we do put safety first. And when it is a matter of patient safety, whether it's part of the physical plant like elevators or something with staffing, we make sure that that's in place.
Thank you. And then because there's so many bills that have your agency in it, can I ask you, for the maternal mental health, we as a state can do far better. Is there a vision? Is there a plan? Is there a group that you're looking at? Because status quo is not good enough. How do you feel we can do better?
I agree. And there are several strategic plans out there, some led by DPH where DMHAS is a part of, and some led by DMHAS where our other sister agencies are a part of. So there is a strategic plan in place right now. I believe it goes through 27. And we'd be happy to share some of that with you. That's under the Substance Exposed Pregnancy Initiative that I mentioned earlier in my testimony.
And if there were 3 areas that you had to look at as the lowest hanging fruit, if the budget was not the issue, what would you think they would be?
Around maternal?
Yes, maternal health.
Making sure folks have access, making sure people know about the resources that are out there, and working with folks to eliminate stigma. I think a lot of times folks don't reach out for help, especially around mental health and substance use, because fear that this would be something viewed negatively rather than being proactive. So I think we have some of the core pieces in place, like the Mental Health for Moms program, where we partner with Yale. That's the beginning, and I think we could develop more programs like that, or make sure that the media campaigns are louder and in front of people so that people know about the resources that we have in place.
So awareness, and then
Access.
you want to improve the access, and then there are not enough clinicians that are out there. So that remains a challenge. That when we increase that awareness, if we don't have enough clinicians, then that awareness leads to no connection that can be made. So that may be an area of opportunity for us too.
And we focused a lot on substance use, and we could probably focus even more on mental health.
Yes. Well, we appreciate your work and look forward to working with you. Thank you so much, Madam Co-Chair.
Thank you very much, Senator Summers.
Yes, and thank you for being here today, Commissioner. I have a question for you. I just have a comment. One of the reasons why I had put in the bill concerning keeping males and females separated, and I know that the way the bill was written was a little overarching. It wasn't for the entire CVH hospital, but it was particularly when individuals are sent to Whiting for a competency evaluation. And this came directly from our Department of Corrections, where they are continuing to monitor women. They do pregnancy tests frequently, all the time. A person left from their facility, went to Whiting for a competency evaluation, was mixed with men, and actually came back to their facility pregnant. And that's where this comes from, because the concern is how, if you are there for competency, can you consent to something if you're not competent to stand trial? And there was, from what I understand, an investigation from DMHAS as to how this happened, et cetera. But my concern is going forward, when we're having people be evaluated for competency, I think it's important that we keep them segregated by sex or gender. So that's where this is coming from.
So I can't, again, speak to any one case because of PHI. But generally speaking, again, we have 4 restoration units. 2 of them are all male, 2 of them are co-ed. We certainly do not condone sexual activity. We have cameras in our building. We have 15-minute walk around the units, checking in on folks, census checks. Anyone, as in my previous answer to Senator Anwar, who may have a history of sexual abuse, is assessed to see what additional supports they may need to have put in place. And competency restoration is a lot shorter than some of the other units at CVH or Whiting. So a person could be there 2 months, could be there 3 months. and then move back to DOC.
I'm concerned this did happen. I saw the report. And there was concerns on the other end too, as far as the Department of Corrections. So I would like to know what we can do to prevent this from happening in the past. And if you want, I can follow in the future, sorry. I can follow you up with all the details. I mean, I do know that DMHAS looked into it and there wasn't really a good explanation as to how it happened, but it did. And that's concerning. And that's why I have put this bill in.
Yes, certainly you can follow up with us. Again, I can't speak to any individual case, but we do monitor the units. Being on a co-ed unit is part of rehabilitation. And again, we wouldn't be able to duplicate all of the units that we do have. Certainly, if we had female-only units, there would be a lot of empty beds, and we can't have empty beds because then that would create wait lists. Other states have had litigation due to wait lists and competency restoration, but I do feel strongly that we do have the right safety measures in place at the hospitals. Like I said, cameras in all common areas, the ability.
But we didn't in this case because this person went there, intermingled, and came back to the facility in a different state than she left. So it didn't work in this case. And I do have the information that we can share with you, but that I'm not confident we do if this is happening. And this was just not long ago. So I would like to see what kind of corrective action, when you follow up on this case, we can install so we make sure that we do not have this kind of situation happen again, especially when somebody's there for competency.
I would like to introduce Joe Crego. He is the CEO of Wedding Forensic Hospital.
Thank you, Commissioner. I am Jose Crego. I'm the CEO of Wedding Forensic Hospital. Honorable members of the board, Commissioner, Senator Summers, good morning. To respond to the question, we do, as the Commissioner mentioned, have quite a few safety precautions in place. As the Commissioner mentioned, we do have cameras on the facility, and they were in place during that period of time. Those cameras are monitored on a shift-by-shift basis. So every shift has random monitoring, all the cameras and everything that's going on within the common spaces on the units. There are also, as the Commissioner mentioned, there are 15-minute checks. After we learned of this incident, we actually went back, took a look at it, investigated it, looked at a pretty significant period of time to see if we saw the individuals that any compromising position or any situation would have led to that, and did not find it. As the Commissioner mentioned earlier, while we certainly don't condone sex, it's part of the, it's not prohibited either. We don't separate folks for that reason. Separation of individuals when only male and only female units, as the Commissioner had mentioned, would put a significant strain on the hospital itself and the resources that are available. Connecticut is one of the only states that has no waiting list for individuals coming to us for competency restoration. Other states see folks waiting in the Department of Corrections, in jails, before they even get to any treatment whatsoever for competency restoration. It's a status that we're very proud of as a hospital and as an agency, and we will continue to monitor these precautions that we have in place and continue to enhance them as needed as we move forward.
Thank you for being here with us. Senator Summers, did you have anything further? Okay. I think I'll.
You know what I do, but unfortunately where I am, they're doing construction. It's very loud. So I will just follow up. I hear what they're saying, but this is a situation that did happen. I do have the report from DMHAS. And so that to me does not make it confidence that these safety measures are actually working. So, I'm just going to continue to push this because I don't think it's right that we send somebody from our facility for a competency hearing to find out if they're able to stand trial and then come back to the facility pregnant. I just think that is the wrong message and something needs to be done. So I'll just continue on this until we can get it rectified. Thank you.
Thank you, Senator Summers and Mr. Craigo. Thank you for being here with us today. There may be another question for you, so if you don't mind staying here. But I think I would just underscore that the theme here, I think that all of us share, is that we want to assure that the safety of all residents is paramount at all times. And how we get there may be further conversation that, again, as Senator Summers indicated, is offline. But I'm going to go back to Senator Almar for now.
Thank you so much. Thank you, Mr. Craigo, for your testimony and additional information. I want to gently push back on something. So the cameras are just looking at the physical interaction or physical safety, but a trauma victim is not going to be affected by the physical as much as by the emotional feeling of not being safe in the place that is traditionally been considered safe. So therefore, having a preemptive, thorough assessment in advance to prevent something like this from happening. We learn from ourselves every day. Every day is a better day because we try to learn. So I think it's better to have a prevention strategy. I know there's a physical trauma strategy in place, and thankfully we have that. But I do feel that if people who are impacted by trauma and then they know that the perpetrator of that trauma are close by, I can't even imagine what they would experience and how that would impact them. So I just wanted to put that on the record and say that we need to have a prevention strategy for that going forward. And I think the commissioner was in agreement with that too. So I just wanted to put that. Thank you.
Thank you. And we're always looking at continued improvement. Thank you so much.
Thank you. And before we have Mr. Craigo or go back to the commissioner, I should say, are there any other members who have questions for Mr. Craigo? Because we do have more questions for you, Commissioner.
Okay.
No, I'm going to go then to Representative Belton. Thank you, sir.
Hello, Commissioner. Thank you for being here. I'm so happy to hear about all of the things that you all are doing around maternal health. Can you tell us more about the Access Mental Health for Moms and possibly how many, if you could speak to how many people are accessing this and demographic breakdowns? I know you may not have that, but if you could just let us know, where, if it's available and how we could find it.
So Dr. Kim Kuranda is our content expert, and she is responsible for having brought this to Connecticut. So I'm going to defer to her.
Good morning. Thank you for that question. So we currently work with Yale. It's a number of physicians, and they provide coverage for 40 hours a week between 5 physicians. It's a rotating schedule, so Monday through Friday, 9 to 5. The physicians are able to call into the line about any type of question related to maternal health for women who are pregnant or up to 1 year postpartum, because we know that that 1 year postpartum is a really critically important time, and there have been maternal deaths, especially during that 1 year postpartum. So that consultation is available for that time period. These are physicians who have expertise in perinatal psychiatry and consultation. Part of the program also offers monthly training sessions that are done virtually. Those training sessions are recorded and posted on the Access Mental Health for Moms website for access at a later time. And those topics include topics related to mental health, substance use, stigma. The commissioner, very rightly identified one of the major issues that we confront, which is women who are pregnant, who may have a substance use disorder or a co-occurring disorder, who are just really fearful or uncomfortable accessing help because of fears around what might happen to them as a result. So that service is, really critical, the training component. We also have a toolkit that was developed for the perinatal psychiatrists or anybody who's prescribing. So there is a comprehensive toolkit that's located on the website. It has screening tools. It has recommended best practices. There are also training videos on how to apply screeners for women who are pregnant related to substance use and mental health. So it's a very comprehensive, I would say, menu of services that any prescriber, any physician, any clinician can access in our communities. We also have resources for women and families in the community. So those are also posted on the website.
Do you have data around how much this service is being used?
We do. We collect data. I don't have those numbers off the top of my head, but happy to send along some of the reports or meet and talk about them more specifically. But we are tracking on the numbers of consultations, the numbers of referrals that are made, because in addition to the 5 psychiatrists who are manning the service, we also have a clinician and we also have a care coordinator. So they're able to literally provide a warm handoff to women who may be looking for resources in our communities and connect them either to our existing substance use system or our mental health system.
Thank you very much for that. And just thank you for being here with us, Dr. Karanda. And just a follow up to that, and I know Senator Amor does as well. Can you just briefly describe Access Mental Health, the actual program, just for anyone who may not know who's listening along, just what the framework of that program is, and talk about, again, I think you're going to provide some details, demographic breakdowns, including the geography of that as well.
So this is a statewide program. Some may be familiar with the Access Mental Health for Kids that was initiated through Carillon, which really was kind of the first foray and ensuring that people know about various resources available in the state for youth and pertaining to mental health or substance use. Access Mental Health for Moms is a model. There's several other states who have brought this model up and had great success in terms of beginning to increase our provider capacity to manage women who may have a psychiatric or a substance use disorder. So it's really built on the idea that, you know, we're very fortunate to have a robust continuum of services and many incredible providers, but we also want to make sure that all of them feel comfortable in terms of prescribing medication, especially during the opioid crisis, that we have prescribers who are comfortable in prescribing MOUD for women during pregnancy. That's the gold standard. Very well researched, very well evidenced. So the program, in a sense, really provides the opportunity for anyone in our communities to call in and ask questions, very specific questions about a client who may be sitting in front of them. There may be somebody who's left the office and is coming back for an appointment. In the meantime, they want to acquire information about the next appointment and next steps and resources. So that program really provides an opportunity for providers to access that in real time. There's typically the ability to have a handoff within 5 minutes. So a call comes in. There may be a period of time once the clinician answers the phone and just reaches out to that psychiatrist and then makes the connection between the two of them. During that call, they're also obtaining data, like what point in pregnancy is the consultation about, how old is the woman, what race, what area of the state of Connecticut the woman lives in, so that later on we're able to do analytics around where the calls are coming in from. So this is a statewide hub. It's open to everyone. There's absolutely no charge for any of the calls or any consultation or any of the services that are provided.
Thank you for that. And just to drill down, when you say any provider, it could be a pediatrician who's seeing a parent with another child. It could be a social worker who's seeing someone in therapy. It could be their OBGYN. It could be their community health worker. Can you just clarify if that's correct?
Yeah, I would say on the consultations around prescribing, that would typically be a prescriber to prescriber. However, we have a clinician available in terms of best practices, and we get those calls all the time. There's actually quite a bit of work that's going on with the pediatric community as well, and some synergy between Access Mental Health for Kids and Access Mental Health for Moms. They're already involved in a lot of training for the pediatricians. And so we're making sure that the pediatricians are well aware of the services and opportunities to connect with the perinatal Access Mental Health for Moms. We know that many women may miss their first postpartum appointment, but they bring their child for pediatric appointment. So we really want to make sure that we can take advantage of that opportunity.
Thank you. The other thing that I just want to talk about is the fear. And I think that the fear that many moms, people who are pregnant and are dealing with issues related to substance use or to mental health issues is they're worried about losing their child, potentially. So it becomes kind of a catch-22. And what we want is to make sure that those parents are getting the help that they need. How do you directly address that catch-22? Because there are requirements in terms of reporting. So if you can speak to that, I know that crosses over into some of the DCF area and where your DMHAS, but if you can speak to how that impacts the work with Access Mental Health, that'd be great.
Sure. That's a really incredibly relevant topic. We actually do several trainings related to implicit bias, related to work very closely with the Connecticut Perinatal Quality Collaborative, the CDC's campaign here, her just really ensuring that docs are listening to women, especially women of color, when they have a complaint about something that they may be experiencing, and treating and training hospital personnel to be open to those messages. In addition to that, we work very closely with DCF on the Connecticut Substance Exposed Pregnancy Initiative. Part of that is early identification and screening. So within our 5-year strategic plan, and this is the second cycle, we've received technical assistance from SAMHSA, both on the adult and the child side. I think folks are also aware of the federal mandate around CAPTA, the Child Abuse Prevention and Treatment Act, as well as the development of a plan of safe care. So the idea is to really have all providers, as many as possible, trained up in how to work with a woman as early as possible in a pregnancy to identify what her needs are. Like, is there a mental health need? Is there a substance use need? Is there a need for her partner to get involved in treatment? And part of that plan, it evolves, and she's able to actually document it within a virtual app that we have helped to develop, so that when she's going from appointment to appointment, those needs and those specific resources that are going to be critical to her in having a safe pregnancy in a safe home are going to be there with her. So those plans of safe care, we've worked with the hospitals, we've worked with our recovery support navigators who work specifically with perinatal women. We've worked with our methadone clinics, all of them who are engaging with women, especially during pregnancy, and women who have an MOUD. Those tend to be the cases that are probably the most challenging around women's fears around DCF in custody, but we meet regularly with DCF. Our pregnant and parenting programs that we have located throughout the state, where women can enter treatment with their children, or where women who may have had children removed from their care are working on a reunification plan, or we're trying to get women back together with their children. So those meetings that happen, there are very clear lines of communication between that individual, between DCF and DMHAS and the treatment program. So I think I would just say that, you know, we work very closely with our sister agencies around ways to mitigate stigma, around ways to screen and identify a woman or a family who may be in need as early as possible so that the situation does not deteriorate.
Thank you for that. And this last question may be for the commissioner or for either one of you. But in terms of the substance exposed pregnancy initiative and the Access Mental Health, what are our current sources, primary sources of funding?
Oh, so Access Mental Health was initially funded through ARPA, but we plan to continue that with some reinvestment dollars through DSS. So that we hope will just seamlessly continue. SEPI?
Yeah, SEPI, we have some state dollars that are invested in 2 positions at Wheeler Clinic that help us to operationalize the strategic plan. There is a clinician, and then there's a care coordinator. They interface with hospitals, with providers, and really ensure that the various work groups around screening, identification, connection to care are working smoothly. So those 2 positions really work in coordination with representatives from both DMHAS and DCF who sit on various work groups and on an executive leadership team.
Okay, thank you. And just to follow up, Commissioner, are those DSS funds Medicaid tied?
It was tied to the 1115 waiver. And so part of the waiver is that any additional dollars need to be reinvested in the service system. So this is one of the areas we chose to reinvest.
Wonderful. Thank you. Senator Elmore.
Thank you so much, Madam Co-Chair. Dr. Aranda, thank you for the work that you do and your team does. I'm trying to understand, there are 40 hours of clinical help for the entire state of Connecticut. And if we look at the lack of, at least from the data that I'm seeing at times, is that 40% of all Latina African-American women who are in pregnancy, they do not have access to support when they need it the most. So the phone should be ringing off the hook. Is that what you're seeing?
You know, again, I think the commissioner pointed out part of the challenge is to ensure that folks are aware of this service. But really to think about this is more of a consultation service for prescribers. Of course, we can have women call in, ask about resources, but in terms of obtaining clinical care or talking to a doctor, that would not be typically happening on this type of call. This is typically a doc to doc or a doc to prescriber conversation around medication management, around what resources might be out and available to a specific patient for either mental health, substance use, or a co-occurring disorder. But the number of calls has increased and, you know, really significantly, exponentially. We just received the last report about 2 weeks ago. We're going through that data currently. I do know there's been several thousand consultation hours that have been invested in this program to date. In that really, you know, the first year or so, I think was a little bit slow moving, but as people have continued to hear about it, as we have worked very closely with the Connecticut Perinatal Quality Collaborative and CHA in getting the message out to medical practices, to you know, access programs in the state, I think there's been much more uptake. We've also worked with very large practices that are providing OBGYN care in the state. So part of the other piece of Access Mental Health is to enroll actual practices. So if there are questions that come up, there's the ability for a psychiatrist to do some consultation directly with the actual practice.
Thank you. And do you guys have a mechanism of a warm handoff when you have a case?
We do. We have a clinician, and we also have a care coordinator who's working directly with women. I know we had a phone call last week, and they're actually managing a caseload of about 40 women currently, who are kind of in various stages of getting connected to care. For many women in the interim who may not be ready to engage in formalized treatment, we have our Reach Navigator program. So those are women with lived experience of substance use, mental health, and many of them with DCF involvement experience, who are able to work and deploy out into our communities statewide. We have 15 Reach Navigators available in the state of Connecticut, and they deploy to hospitals, to women's homes, to shelters. They will go and see any woman who is interested in just talking and maybe considering a next step in terms of her care.
So one of the concerns that we as a committee have, and Representative Belton has been working on this as well, the mortality rate differences are very significant, and it's embarrassing that here we are, one of the most developed part of the world, and one of the most developed part of that developed part of the world, having mortality amongst Black and brown mothers much higher and almost like underdeveloped part of the world. So we have almost like two patterns of life. And CDC says that 80% of those mortalities are preventable. So we're trying to see what is the highest ROI we can get from our investment as a state, because the status quo for this is unacceptable. So we need to invest to be able to make sure that we bring the likelihood of survival for the children and the mothers to the level that it should be, minimum, if not zero. Where do you think should the investments be?
Absolutely agree. I sit on the Maternal Mortality Review Committee, so we are reviewing cases on a monthly basis. And one of the benefits of having a committee such as that is it's interdisciplinary. It brings together folks who are physicians, women who may be working in different fields, and we're able to identify what are some recommendations or next steps in terms of, like you said, Senator, like preventing this from happening. I think one of the critical pieces is, again, ensuring that women and providers in our state know about this robust set of resources that we have, and that women feel comfortable enough going into a physician's office and talking about what's happening to them. And that's part of the work we do around implicit bias, around some of the discrimination that women feel walking into a physician's office. I think, over time, we know that we need to have more treaters who look like the women that they're treating in our communities. But we've been very engaged in, like I said earlier, the CDC's Hear Her campaign, because we know that certain groups of women are looked at in a certain way, for example, who may be experiencing pain and it's seen as a drug-seeking behavior. We need to change those kinds of thoughts that docs may have about them. So the Maternal Mortality Review Committee gives us an opportunity either on specific cases to look at, was it a breakdown that happened in the emergency department? Was it the fact that we didn't have enough available to that woman in terms of resources within her own community? Are there areas that we can just begin to build up, train more on early screening and identification? We know that sometimes there are physicians who haven't been as comfortable in asking the kinds of questions that they feel like they have to ask because they're unaware of the resources that they can refer women to. So I think by ensuring that they know that there are places that women can go during pregnancy and postpartum, that's going to go a long way. So probably some additional marketing around some of the resources that we have in our state will also be helpful.
So at least in our conversation this morning and now afternoon, I'm sensing investing resources into information about the Access Health, but also increasing the appropriate level of clinicians present and more than one line for Access Health. Maybe one way is to try and make sure that we have a good triage program and a management program to take care of the immediate needs of the people. And then the preventable part is going to be a different strategy altogether. Is that a fair way to look at it?
I think that's fair.
Thank you. Thank you so much for your testimony. Thank you for being here. Back to you, Madam Co-Chair.
Thank you, Senator. And just as a follow-up in terms of that, the report data and utilization, it probably would be best if we can get that in writing, and that way we can share that with all the members of the committee, just as a follow-up to today's conversation.
Absolutely.
Are there any further questions from members of the committee? Seeing and hearing none, we want to thank you today, all of you from the agency who have joined us today, and for the time and attention that you give to the residents of our state. Thank you,
Thank you
Commissioner.
so much.
Okay. Next, I am actually going to, we're just about at that hour point, and with my apologies to you, Mr. Jackson, we're going to go ahead and go to the first member of the public, Aubrey Skelski, and then come back to you, Mr. Jackson. Welcome.
I'd like to acknowledge esteemed chairs, Senator Anwar, Representative McCarthy Vahey, and honorable members of the Public Health Committee. Thank you for taking the time and effort to actively listen to my testimony. I deeply appreciate the opportunity to share my personal story. My name is Aubrey Skelski. I am a University of Connecticut student concentrated in community organizing for the Master of Social Work program in Hartford. I am in full support of House Bill 7213, an act concerning access to reproductive health care to protect patients' access to reproductive health care, specifically youth rights. I am privileged to speak on behalf of the young women in Connecticut who may be entirely unaware of the future of their health is at risk and being decided on for them. The fundamental right and access to treatment for women throughout their lifespan is at risk. From lived experience, I can stress the impact of treatment when you are suffering the most. I was given access to treatment when I needed it the most, and I fear for the present and future generations of young women who may not have the right or access to medication when they are suffering the most. My lived experience began one morning as my family and I were in the car on the way to church. I had just turned 12 that spring. And as we were on the way, a wave of nausea hit me. My vision blurred, my temples pulsated. I hadn't realized it then, but my body would never be the same. My brain chemistry would never be the same. I missed weeks of school, days at the beach, times with my friends, and spent those weeks in my room with lights off, ice on my forehead every month. I also spent hours searching for an answer, seeking treatment from pediatricians, neurologists, endocrinologists, allergists, counselors, and eventually made it to an OBGYN. In the meantime, my symptoms persisted, including chronic complex migraines, vomiting, hand-face numbness, speech delays, brain fog, sensitivity to light and sound, emotional dysregulation, even reoccurring thoughts of suicide and hopelessness. Years later, when I was almost 16, my mother's OBGYN evaluated me and began treatment, which was able to enhance my quality of life to a point that I never expected. Established studies show that an estimated 90% of females of reproductive age are impacted by acute premenstrual symptoms. Among them, 20 to 40% encounter PMS, while 2 to 8% experience PMDD. I can look back and realize how lucky I was to have a mother who did her best to make sure I received proper treatment, open-minded, and medical professionals who knew what I needed as well.
Excuse me, Ms. Skalsky, but your time has reached. Thank you.
Ms. Skalsky, if you would like to just summarize your last sentence or two.
I ask you to think about all the young women who will not have the guidance I had. Please release the decision-making to medical professionals, the women with lived experience, and to the young women who we are determining the rights and futures of today. Thank you.
Thank you very much for being here and sharing your story with us. Seeing and hearing no questions, we will go next to Mr. Jackson.
Good afternoon, Representative McCarthy-Vahey, Senator Anwar, Representative Belton, Representative Clarice Detria, Senator Summers, and members of the Public Health Committee. I'm Boyd Jackson. I am Director of Legislation and Regulation at the Office of Health Strategy, and we appreciate the opportunity to provide testimony on Senate Bill 1507, and especially for allowing me to substitute in for Commissioner Gifford, who regrets not being able to be here today. OHS appreciates the committee continuing the conversation on private equity and real estate investment trusts. We were here several times last year talking about these topics in a committee bill, in a governor's bill, in an agency bill. We've been here already this year to talk about the governor's bill in House Bill 6873, dealing with these topics, and we appreciate the opportunity to continue that conversation today. The governor's bill and this bill both have broad definitions of private equity to ensure that we're not missing important transactions that historically the state has not had oversight of. But the governor's bill ensures that we're catching all of the transactions, and then on the back end, we can calibrate our review based on the concerns that are raised given the facts at issue. This bill would ban a broad definition of transactions. And there are some concerns that come up with there that we look forward to working out with the committee. Specifically, the definition would seem to include a number of limited liability companies, partnerships, and joint ventures that might include physicians coming together to own a group practice together. And we think that might be broader than what's intended. So OHS believes that transparency in these types of transactions and review of these transactions, the ability to halt them if there are overwhelming concerns, or the ability to impose conditions is a more appropriate way to address this broad group of transactions rather than an outright ban. In addition to the private equity issues in the first section, the third section would invite OHS to evaluate whether the Attorney General should be authorized to petition Superior Court for appointment of a receiver for financially distressed hospitals. OHS appreciates the concern at issue here, both in our state and neighboring states, and we appreciate the thoughtful approach that the committee's taking here. And we think that it's a good idea to really study this with our sister agencies, with the Attorney General's office, and with the input of the committee. To ensure that anything that comes out of that is well researched and planned for. Finally, the second section provides some protections for clinical professional decision making. Some people call these corporate practice of medicine prohibitions. These have been an interest of the Office of Health Strategy. Recently, we've been asking more and more questions about this as it affects quality in our Certificate of Need program. So we appreciate the overall goal here and look forward to working with the committee on some of the definitional pieces and what's included in the clinical decision making, just to make sure that we're looking at the right types of behaviors that we want to review. So I tried to stay under my 3 minutes because I did not wear green today, but I am happy to answer any questions.
Thank you. So just, Mr. Jackson, if you could, that last piece, you were speaking about the clinical decision-making. Can you summarize that piece again, just to repeat that for us?
Sure. The agency has definitely taken an interest in this recently, and the academic community has identified the clinical decision-making, or what's often called corporate practice of medicine, as a way to ensure that private equity or corporate ownership of group practices or health facilities doesn't cause problems. That's ownership that already exists. The first section here looks prospectively to future ownership interests, but we know that there's already a lot of private equity ownership or other types of corporate entities. So the corporate practice of medicine protections are seen as one avenue to ensure that the clinical decision-making is not inappropriately steered by the corporate interests. So we've been asking a lot of questions in our certificate of need program when we have transfers of ownership to ask, how will the transfer affect clinical decision-making? Who's setting the clinical standards and guidelines? Who's setting the time that can be spent with each patient? Who's making billing and coding decisions? Who's deciding whether a patient is admitted from the emergency department, or who's deciding when a patient is appropriate for discharge? These are kind of some of the categories that we've been asking questions and have thought about in the context of conditions in agreed settlements for that type of transaction.
Thank you. Thank you for that. And you're raising a few important issues. One is the tie-in of the conversation around private equity and its role in healthcare in our state, as well as the role of the certificate of need. And you obviously have referenced that there have been a number of bills in the past, but also this year, that will clearly need to work together. I think you understand the intention here, which is the concerns the committee has around what role private equity might play. And obviously this bill is one approach and there are others. And we know that we will remain in conversation with you, the governor's office, and many other stakeholders around this. But when you've been asking some of those questions in that CON process, what are some of the questions and what are some of the concerns that you have about the role of private equity in certain transactions and in certain institutions in our state?
Yeah, thank you for that. We've discussed the financialization of healthcare, where profits might be prioritized over patients. And so what we're trying to ensure, we're one of our 12 criteria focuses on how a proposal is going to improve quality. So we want to make sure that any of the proposals in this arena are not going to lead to decisions being made for financial reasons, but ensuring that the patient is at the center of whatever this decision-making is. So we look to make sure that there are proper safeguards to ensure that it's the clinicians, whether that be a physician provider or a APRN, advanced practice nurse, that it's the clinician making that decision about the patient care and that it's not being steered by financial decisions.
Thank you for saying that. I think that's exactly gets at the heart of some of the concern here, which is we understand that our healthcare providers need to make sure that they are staying in the black as they provide those services so that they're able to continue to do so. And that's certainly been a conversation in other committees. I'm looking at Madam Chair here to my left in terms of the Human Services Committee and Medicaid rates and what we're seeing in terms of dollars that may or may not come from the federal government, and all these pieces play together in terms of impacting how we finance healthcare. I think there are some who have said that it's unrealistic to say that we can't have private equity in healthcare, and certainly we've heard testimony here from certain groups that indicate that they have relied well and that this has worked. So can you, from your perspective, you talked about the areas that you're flagging. Are there certain reviews that you've seen where you think things are working well or in a satisfactory way? And can you give us an example of some of those cases from the perspective of the office?
Certainly. You referenced things that we've heard in this committee prior on the governor's bill, several individuals provided testimony of the benefits that private equity or other types of financial investment have been able to provide. Generally, that focuses on the ability for a practice to stay independent rather than joining a vertical integration with either becoming a part of a hospital health system or becoming a part of an insurance company. And so ensuring a diversity of provider types, provider group types, that's one area that people have pointed to as a potential benefit there. I think the biggest key is this is a really fact-dependent decision as to whether it's going to benefit patients or not. And the governor's bill allows the state to look at the facts as they're presented and determine in that instance, do the benefits outweigh any of the concerns? And are there conditions that we could put on the transaction to alleviate some of those concerns? Rather than say outright, we think that there's no reasonable or good use of this, to ensure that we're going to look at each one. And if there's a concern, we'll either mitigate that concern through conditions or we have the ability to balance and see that the benefits outweigh.
Thank you. Yes, clearly different approaches. The fact-based decision means it depends. And what this bill says is it doesn't depend. You know, we're seeking to not go forward in that way. I know Senator Amor has questions and others may as well. Senator.
Thank you so much, Madam Co-Chair. Thank you, Mr. Jackson, for your testimony. So you're politely saying that you don't want this bill to move forward and you want CON to be strengthened.
Notice of material change.
But here's the issue. Nothing good has come out in the hospital arena with private equity. So why not just ban them? That's what this bill is saying, that we don't want them anymore. There's nothing good that will come out of them. They are profit driven. They're only in it for money. They're not helping the community. So why is Office of Health Strategies hesitant to join us in saying, yes, we agree with you?
This bill goes beyond just hospitals. So that's one area of concern. I think getting the definitions right is one of the major concerns. We've seen where if you try to have kind of the precise, surgical precision of a definition, that often creative lawyers can create investment vehicles that fall just outside of that definition, and you've lost oversight or protections that you were trying to build in. Alternatively, what we think we have here is an attempt at a really broad definition to ensure nothing falls through the cracks, and we may prevent investment types or ownership structures that we don't think are as problematic. And so that I think is the concern here, and why, to Representative McCarthy-Vahey's point, why we say it depends on the facts that are before us and why we need to look at it and see what's actually being proposed rather than just the blanket attempt at a definition that catches all bad actors but doesn't inadvertently catch good actors.
So if the definition was adjusted and then we looked at only at hospital acquisition, would the Office of Health Strategies be more open to that?
We're certainly happy to talk about it and more open. But I think, these problems are likely to, the concerns are likely to persist, because we've seen in the certificate of need process, certainly, where a very clear exemption or, pathway has been defined, and suddenly every transaction fits under that exemption. And we've lost all oversight. So this has happened in the group practice arena. There's one exception to the CON requirements, and suddenly every transaction looks like that exception. So I think it causes a lot of concern when we try to do this precise definition. The definition of private equity has varied, and we think that likely people would create investment vehicles that effectuate the same practices but don't fall under that definition.
So our intent is to make your life easier, because we are not going to allow the profit-driven private equity groups to just get into the healthcare arena, especially the hospital side. So that's the intent. Would you agree with the intent at least?
We appreciate the intent, but I think we're just concerned about the blanket nature and prefer to have more of a oversight and transparency perspective rather than an outright ban.
What about the blanket statement that we don't want them to be involved in the real estate transactions that we have seen? What are you willing to accept there?
We certainly have expressed concerns about those. It was recently brought. Let me think. I want to be careful here. Recently, entities have come to us with the belief that they can explain where a real estate investment trust may be necessary for even nonprofit good actors, and we are actively researching if whether there are limited circumstances in which those types of transactions would be beneficial to the provider. But we are, I think there is generally a skepticism, and we have seen the problems that those create. And that's why the real estate leaseback agreements and private equity are both specifically named in the governor's bills. I think that highlights the general skepticism and concern around those. But we're leaving open the possibility that someone might be able to convince the Attorney General and the Office of Health Strategy that in the limited circumstances, it would be beneficial to the patients in the health system.
So I'm not too satisfied, because we have identified that there's a problem, and our bill is saying that we need to eliminate the problem. And you're saying that, well, let's not eliminate the problem. Let's figure out, is there going to be ever a good partner or some good player that will come in? So it is what it is. But I hear what you're saying. I may not necessarily agree with it, because in the rest of the country as well, nothing good has come out of private equity. If you look at hospitals in Pennsylvania, Rhode Island, Massachusetts, Florida now, every part of the country, they are some of the most vulnerable parts of our state, of the country. People in those communities are not getting healthcare because private equity came, took all the money and ran away. So we're saying we don't want them. And I was hoping that the governor and OHS is going to stand with us and scream, absolutely, we don't want them either. And then here we are hearing a little different testimony, and that makes me confused. But I'm not confused about where I stand. Just want to make sure. Thank you, Madam Co-Chair.
Thank you. Just a couple follow-ups. I think, Mr. Jackson, what you're saying is the financial markets will always be ahead of what we are able to do here at the legislature. And the same, we're not able to be as swift as the financial markets. Is that what you're saying?
That is one area of major concern.
And did you see The Big Short?
It's been a long time.
Yeah, I think it's a great example for anyone who hasn't seen it. It's a great example of how the financial markets used an incredibly opaque and complicated system to essentially cause a global crash in the markets. And I hear what you're saying. I think Senator Anwar and I have been very clear in the level of concern that we have with private equity. And to my chagrin, my sense is the horse has left the barn in a lot of ways. In my perfect world, there would be no private equity in healthcare, period. There wouldn't be private equity in a lot of things. But I'm aware of, as we've heard here at this committee, that there are places where private equity investments have allowed people to make capital investments, et cetera. I think that what I'm hearing you say today is very much that as these financial instruments evolve, whether it's private equity or perhaps private capital or REITs, the real estate investment trusts, or any other financial vehicle, that they're not all created equal. And not all actors are created equal. And that we have to, no matter what, we have to have the ability to provide the context and oversight. And I think that's something certainly this committee is, we've demonstrated willingness to work together with your office on that. But I think this conversation and the exchange that you had with my good co-chair is really an example of the conundrum that we face. Because we have seen here in Connecticut, we're living right now with 3 bankrupt hospitals. And I know that your office has been intimately involved in trying to help us move forward with that and trying to make sure that the patients in our state have access to care. But we lost access to care for people, and we've lost because of people's greed, because of the role of profits that were very clearly put above patients. And I know that you are with us on that. But the frustration that we feel as a committee, and that we know many in the state feel as communities are facing the circumstances, it's incredibly frustrating. So that's not directed at you per se, but just to get that out there. A follow-up question that I want to go back to is when Senator Amor asked you about more review and a different certificate of need process, you responded by saying notice of material change. I would like for you to really explicitly differentiate the notice of material change process, how that works, where that lands, and how that interacts with the CON process, because I think it's pretty wonky. And the more that we can understand this at, my favorite saying, the 4th grade level, that would be helpful.
Sure, I appreciate the opportunity. The notice of material change process runs through the Attorney General's office. Currently, an entity that's required to file a notice does so 30 days prior to an anticipated close of the transaction. The bill would expand that to 60 days. Currently, the notice of material change process is an opportunity for the Attorney General's office to evaluate a transaction for antitrust concerns under the federal and state antitrust laws. The proposed bill would do a few things. It would expand the scope of entities required to file the notice of material change. And that's my point about the broader definition. We would make sure that all of these transactions were captured, and it gives the Attorney General an opportunity and the state to get a closer look. The bill would allow the Attorney General's office to work with the Office of Health Strategy to review these notices. Currently, confidentiality requirements of their process does not allow them to discuss the details, the confidential details, with our office. So where we may have some health system subject matter expertise that would benefit their review, there are walls that prevent that collaboration. And so this bill would enhance that and ensure that we can work together. It would expand the criteria that the Attorney General's office was reviewing. So as I said, currently they're looking only at antitrust laws. And this would allow them to look at access to care, quality of care, and affordability of care, and the results on each of those as a result of the transaction. And they would work with our office to think about those criteria. The remedy or the disposition under the notice of material change, if there's an antitrust concern, is they can file an antitrust lawsuit, an antitrust action. If it's a concern on the access, quality, and affordability, the remedy would be that they had the option to refer that transaction to the Office of Health Strategy for a certificate of need, where we would do a deeper dive into our 12 criteria, which ultimately could be boiled down to access, quality, and affordability. It also allows the opportunity to offer conditions. So we've seen this in some past transactions. Rhode Island brings their Attorney General into this process, and they've been able to impose conditions on concerning transactions in a way that the Office of Health Strategy and Attorney General cannot work together in Connecticut and have not had the opportunity to impose conditions on some of these transactions. So that's what we've proposed. It's significantly different from the Certificate of Need program, which is a deeper dive into all of the criteria. It has many more processes and procedures spelled out in statute, including hearing times, times for the community to request hearings, interveners in applications. Every time we ask follow-up questions, they have significant time.
And we will probably have more opportunity to talk about that next week. I guess put simply, and this is very, very, very simplified, is that in many respects, the notice of material change really has a lot to do with the financial side, whereas the certificate of need side is more focused on the healthcare and the patient side. Is that a fair simplification? I know that's not all of it, but would you agree with that?
Yes, and the
Okay.
proposal would bring in just some of the elements in that review.
Great. Senator Elmore.
Thank you. Just another question or another way to look at this. The insurance industry has a lot of private equity money. And we have always been worried about their involvement in the healthcare delivery because they're looking at their bottom line. And if we restrict private equity in the healthcare delivery and the insurance industry in the healthcare delivery, we are creating a mechanism of preventing the conflict of interest. And that's another reason the bill, the way we are seeing this, has value, because we're trying to, we cannot control the insurance industry, at least through this committee. So ideally, another committee could do more. So with that said, is there an opportunity to look at it from the perspective that in the healthcare delivery, we should make it less likely for their involvement? Just wanted to make that comment because otherwise what happens is they play both sides. And the people of our state are the ones, and the workers, healthcare workers are the ones who get the short end of that entire deal.
Certainly, and we look forward to working with you. I'm sure, if I'm sure of one thing, it's that we will spend significant time talking through these issues this year, and we look forward to harmonizing the governor's proposal and the proposal that's come from the committee.
Thank you so much. Thank you, Madam Co-Chair.
Thank you. Thank you for that nice chuckle, because yes, I expect we will spend lots more time, including we know we'll see you here most likely next week. If there are no other questions from members, we thank you for the time that you've spent with us today and look forward to more conversation. Next on our list, number 5, Dr. Nancy Stanwood. I believe she's joined us online. Welcome, Dr. Stanwood.
Yes, thank you so much. I am Dr. Nancy Stanwood. I'm a board certified OBGYN with over 25 years of experience in medical practice, and I serve as the Chief Medical Officer at Planned Parenthood of Southern New England. I'm here in support of raised House Bill 7213, an act concerning access to reproductive health care. As the state's largest provider of sexual and reproductive health care to nearly 50,000 patients last year at 14 health centers across the state, Planned Parenthood believes that all people should have access to high-quality, affordable health care as a human right. I ask for your support of this bill to ensure that young people can continue to get the health care they need. The goal of this bill is simple: to align Connecticut statute with the medical standard of care and ensure contraception and pregnancy-related care remain available to young people, just as we have protected other aspects of health care for minors in our state. Although minors in Connecticut have generally been able to obtain contraceptive care for decades, potential changes at the federal level, especially to Title X, could directly threaten this access. Now is the time to make sure that our code reflects evidence-based recommendations. Young people worried about confidentiality who delay or don't get care are more likely to have poor health outcomes related to sexual and reproductive health, substance use, and mental health. This is why the American Academy of Pediatrics, the AMA, and the American College of OBGYN all recommend young people's access to sexual and reproductive health care, including pregnancy care, without mandated parental involvement. I want to share a story about a patient I cared for, who I'll call Tanya. She was 16 and came in for pregnancy testing a month after a condom broke. She was so relieved that the pregnancy test was negative. She wanted to focus on school and become a teacher. When I asked if she wanted contraception that day, she said she wasn't ready to tell her parents, assuming that they needed to give permission. When I told her that they did not, she was so relieved again. She was a good student, had done her homework, and was eager to start on contraception to protect her future dreams. 24 states and DC specifically allow minors to consent to contraceptive care. It's time that Connecticut joins them. We already know the public health benefits of contraceptive access for youth, as Connecticut has the 4th lowest teen birth rate in the country. We also know that most young people voluntarily tell a parent or another trusted adult about their pregnancy. When they do not, it is often due to fear of abuse, the loss of their home or financial support, having an incarcerated parent, or being in foster care. If they can't involve their parents, they should not face barriers to the care that they need. At Planned Parenthood, we will continue to fight for policies that protect the rights of all people to ensure our patients and communities have what they need to live healthy and self-determined lives with dignity. Connecticut has been a leader in recognizing young people's ability to make informed decisions about their health. We must do everything we can to protect young people now, which is why House Bill 7213 is urgently needed to explicitly enshrine young people's ability to consent to and access contraception and pregnancy-related care. I strongly support this bill and respectfully urge the Public Health Committee and Connecticut General Assembly to vote favorably. Thank you for your time and consideration of this crucial legislation.
Thank you, Dr. Stanwood, for your testimony and for your time with us today. Just a follow-up question. Are of those 24 states, or any of those states neighboring here in New England?
I do not know that off the top of my head. I believe there are New England states, but I cannot remember which ones they are, and I can follow up with your office on that.
That would be wonderful. Thank you for that. Representative Clara DeStitria.
Thank you, Madam Chair. Thank you for being here today. I want to clarify for whomever's out there in our virtual world or in here. I just want to clarify that currently minors are able to get contraception without parental consent. Is that correct?
That is correct. And at Planned Parenthood, we encourage all minors to consult with their parents or guardians about the care that they receive with us.
Thank you. I think you may not have heard Rep. Clara DeStitria say thank you, because I think her mic was turned off. But just to follow up on that a little bit, Dr. Stanwood, is it your understanding that there is some disagreement about kind of the level of how explicit the law is? This language in this bill is extremely explicit, but I've spoken with many attorneys who believe that this right exists currently in statute, per Rep. Clara DeStitria's question. And if that's the case, why do you think it's important now that we make this explicit, as a number of other minor rights are in statute?
Yes, I will say that having been in Connecticut practicing for a long time now, there is a lack of clarity in many healthcare settings with a legal interpretation of the current regulations and statutes about protection of contraception, and that this bill specifically for contraception would serve to make it just as clear for contraception as it is for other things like mental health care, substance use, screening and treatment, so that in particular with what's happening at the broader federal level, now would be the time for us to be crystal clear in Connecticut that minors have access to contraceptive care.
Thank you for that. Representative Dauphiné.
Thank you, Madam Chair, and thank you for being here today. I have a couple of questions. I just want to be really clear. So you believe that minor children should have the opportunity to get health care without parental permission or consent. Is that correct?
We know that for certain kinds of healthcare, if there are barriers such as requiring parental consent or notification, that minors will not seek the healthcare that they need and they will have poor health outcomes. For example, somebody who's worried that their parents find out that they're sexually active might not get treatment for or screening or treatment for an STD and suffer significant outcomes because of that. So that, yes, many states allow for minors to consent for certain types of healthcare. Connecticut already does for things such as mental health care, substance abuse treatment, and we support this bill because it makes it crystal clear that contraceptive care is also allowed without requiring parental consent or notification.
Thank you for that answer. So without this bill, we do have contraception available to minor children. I think that's crystal clear. I'm not sure why you don't think it's crystal clear, but from the community that I interact with, it's crystal clear. My question is, at what age do you think that getting these kind of services should begin?
We treat each patient uniquely, and for patients who might fall within areas of mandatory reporting, we take that very seriously. Such as anybody who's under age 13 who's sexually active, we're mandated reporters to DCF for patients such as that, so that we treat each patient as a unique individual and encourage them to include their parent or guardian or trusted adult. We also screen all of our patients, including our young patients, for reproductive coercion, for lack of safety in their living situation, for intimate partner violence, so that I wouldn't say there's a specific cutoff. We want to make sure that we are meeting each patient's unique specific needs.
Thank you for that answer. So I'm going to take that as you believe that minor children should be able to have access to this type of health care without any kind of parental consent. And I guess that's what you're saying, because you didn't give an age. So I'm assuming anybody under 18.
Yes.
Thank you. Thank you for your testimony.
Thank you.
Thank you, Representative. Senator Amar, to be followed by Representative Mara.
Thank you, Madam Co-Chair. Thank you, Dr. Stanwood, for your testimony. Dr. Stanwood, is this bill going to take the rights of the parents away?
No, nothing in this bill prevents patients who are young patients from involving their parents, guardians, or trusted adults in their healthcare decision-making. And we know that most teens do involve their parents, guardians, or trusted adults when seeking healthcare.
So walk me through this. What would be the commonest scenarios, and when will there be an opportunity to involve a parent?
So we specifically require in our system that we talk to all patients under 18 about involving their parents or guardians in their healthcare and in the care that they specifically receive from us at Planned Parenthood. We don't require it as a part of getting care with us. So, for example, if a 16-year-old like Tanya came to get care, we talk to her about, hey, do your parents know? Do you feel safe at home? Do you feel safe in your relationship? Do you want to talk to your parents? Do you want to think about how to have that conversation that might be challenging? And if that patient, if Tanya's not ready to talk to her parents, we're not going to withhold the health care that she needs.
So you in the consent process, you're asking that minor that would you be willing to have this information shared with your parents?
We're encouraging them to discuss their care with their parents and involve their parents in their health care.
Is there encouragement, or is just asking? I want to make sure I represent.
It's encouragement. We encourage all minors to consult with their parents or guardians about the healthcare that they receive with us.
And in that conversation of the consent, is there conversation about potential physical, sexual abuse?
We do screen all of our patients for reproductive coercion, for safety in the home, both physical and emotional, for intimate partner violence. So yes, that is universal screening that we do for all patients, including young patients.
And what if that minor is pregnant? Walk me through what happens then.
So care for a pregnant minor coming to us at Planned Parenthood might be for abortion care. We, again, talk to them about encouraging them to involve their parents in their decision-making and in their medical care if they haven't already, knowing that most do involve a trusted adult, usually a parent or guardian. And Per regulations, we also, for those who are under 16, follow a very specific consent form talking with them about involving a parent and the availability of contraception, and that they can take time to make their decision, so that for abortion care specifically for patients under age 16, we follow the regulations that require us to talk to the patients about involving a parent, a guardian, or an adult family member in their decision.
And wouldn't the parent know about it when they are sent a bill about the care that has been provided, or the medications and the copay, or some of the other part of the treatments? How would they not know about it?
In some cases, teens might self-pay instead of using their insurance. And also there is a requirement that health insurers allow for confidentiality and not send an explanation of benefits home if the teen has requested that ahead of time.
And help me understand, the reason is some of these laws have already been existent. So why do we have to have another one?
So the current regulations are not as explicit as we think would be important to be protective of teens' access to contraception in Connecticut, especially with the likelihood of changes to the Title X program.
Okay, so you wanted clarity, and is this because of some of the federal issues that are brewing that we are hearing about? Is that one of the reasons too?
Yes, because of expected changes in the Title X program under the current administration.
Okay. And so I probably will have a lot more questions, but I'm going to ask, give it back to my co-chair, and then I'll ask second series of questions after that. Thank you.
Thank you, Dr. Anwar.
Thank you very much, Dr. Stanwood. And I believe, in public health, we talk about regulations and we talk about statutes, the statute being the law as it's written and passed by us as a legislature. And what you just talked about in terms of the requirements around counseling a minor, that's in statute. Am I correct about that? I know you're not a lawyer, you're a doctor, so I may need to ask some of the lawyers about this, but I believe that's in statute.
Yeah, I will beg off that I am not a lawyer and I don't play one on TV.
Okay, well, good for you. So we can clarify that, but I do believe, and we'll clarify that with our own attorneys here, but I believe that is in the statute. Representative Mara.
Thank you so much, Madam Chair. And I appreciate that there's a little confusion around what's in statute versus what's in regulations. And maybe that's a little bit of some of the questions that I have as well. So, thank you very much, Dr. Stanwood, for talking to us today. And I too believe that there should be no barrier to getting contraception. But in that, I guess I'm a little confused, and obviously we'll have the discussions a little bit more behind the scenes over here on whether this is really needed or not. But I would like to talk to you a little bit more about the counseling that you have with minors about seeking help from their parents. And I understand you may do it one way at Planned Parenthood. I just read a testimony that came in from a doctor not out of Planned Parenthood. And excuse me, I guess I was a little concerned because in her testimony, she said that the child was coerced. So I'm just coerced by her parents. So I'm just curious, that bothers me a little bit that a healthcare provider is saying that when a child is talking to her parent and getting, counseling from their parents, that the interpretation from the doctor is that the child was coerced. Do you find that an issue with any of the physicians that you work with, either within Planned Parenthood, which I'm hoping is really not? They may be on the outside of Planned Parenthood, that maybe some of the physicians that are dealing with minors are maybe not supporting talking to parents?
I will say that our medical ethical obligation is to treat the patient, supporting their autonomy and respecting their dignity and independence in decision making. So that if I were caring for a patient who was a minor who's, theoretically parents had brought in coercing them to start contraception, we always have a conversation with our patients without anybody else in the room, letting minors know their rights to confidentiality and having a conversation about their safety in their living situation and their relationship with their parent or guardian. And if a patient says, I don't want to start this birth control, then we would not start them on something that they explicitly have said that they do not want to have.
Okay, I appreciate that. And I think that's really how it should work. I think that one of the things too I'm worried about in this bill is not necessarily what's in the bill, but maybe what's not in the bill. So the very last section, and I don't know if you can have any comments on this, is repealing section 19A-116. Do you have any thoughts on that?
So yes, that deals with some of the regs specific to abortion care in Connecticut. And we know that abortion care is healthcare, and that all the ways in which medicine is already regulated in the outpatient setting, in the inpatient setting, in licensure of individuals, regulates the care of, regulates abortion care, and that to have specific regs that in some ways target abortion care is overregulation and really just not needed. I will say that we are Planned Parenthood of Southern New England. We work both in Connecticut and in Rhode Island. And the specific abortion regs in Rhode Island, the legislature there decided to repeal them, recognizing that abortion care is healthcare and is already regulated in all the other ways that other kinds of medicine is regulated.
So this particular regulation has informed consent on there.
Informed consent is already a part of abortion care as required for all types of procedures or treatment.
Okay, so you feel like everything that is in this regulation now has already been dealt with. You will continue to have informed consent in the future if this particular regulation goes away.
100%. It's medically ethically required to provide care.
Okay. And then, so one of the other things I'm seeing is there's, particular issues around abortion, such as counseling about her decision, prevention therapy, consultation as to the need for follow-up care, information on family planning. Will those things still be available to women receiving an abortion?
Yes.
Okay, and now is there the other thing that has not been repealed, but I know has been talked about in the past, and I just want to make sure that if this moves forward, sometimes we see things in bills and it all looks good and it is what we want, and then magically something else appears that you didn't expect. And so I know in the past there has been talk about repealing another regulation, 19-13-D54. Do you have any thoughts on that?
I'm sorry, I'm not familiar with that reg by that number.
Okay, that's okay. If you don't mind, I just wouldn't mind reading a couple of these things just to make sure that this is not your position to take this out of regulation. It'd be during the third trimester of pregnancy, abortion may be performed only when necessary to preserve the life or health of the expectant mother.
I'm so sorry. Your audio cut out for me. Could you please repeat that?
Yeah, that's no problem.
Thank you.
So there's particularly 3 sections in here that I want to make sure that is not the intent to eventually try to remove from our regulations. And one is during the third trimester of pregnancy, abortions may be performed only when necessary to preserve the life or health of the expectant mother.
So we know that for people who need abortion later in pregnancy, that those situations are unique and unusual, and that it is best dealt with by the patient and the healthcare team taking care of them.
I'm not sure that that exactly answered my question. So would you want that removed or not want that removed?
That removed.
Sorry, I didn't hear that.
Yes, want that removed.
You want that removed?
Yes.
Okay. The next one is the newborn shows signs of life following an abortion. Those measures used to support life in a premature infant shall be employed. Do you want that removed or not?
We know that in hospital-based labor induction abortion care, the rate of live birth is near zero, and that clinicians who provide that type of care, which I will say Planned Parenthood does not, we are not a hospital-based service, that they have policies that prevent that from happening. So we see it as not necessary because it is not relevant to current clinical practice.
Have you ever had a child in your clinic that has shown signs of life and has been unable to have care to support life?
The way in which we provide abortion care at Planned Parenthood, this scenario would not arise.
So
I can't really speak to that.
Okay. The other one is no person shall be required to participate in any phase of abortion that violates his or her judgment, philosophical, moral, or religious belief. Would you want that removed?
There's already protection for negative conscience in medical care, so that is already protected in other ways and is not specifically required. I will note that there's not necessarily protection for positive conscience, but there is protection for negative conscience.
Okay. I'm not sure I got the answers I really wanted to get, unfortunately, Madam Chair, but I'll let that be it for today. Thank you.
Thank you. And Representative Mara, you were referencing 1913 D54 in statute or regulations?
I believe that's a regulation, Madam Chair.
Thank you. And we will certainly be working with our attorneys just to clarify and make sure that we're all on the same page.
Thank you.
And I believe Representative Clara DeStitria and then back to Senator Otmar.
Thank you, Madam Chair. Thank you for being here today. You may have answered this question already. I just want a quick clarification. If you have a minor that comes in and you've counseled them, that you're continuing with their treatment and they chose to use their parents' insurance, I understand that it doesn't have to fall under the EOB, the explanation of benefits. But with that said, the parents are still going to get the bill at the end of the month and see that something's in there. So I didn't know if you have some clarification on that or if you see that happening and if there's a way that you feel that would work better.
We do also counsel our patients about self-paying, and we have a sliding scale fee for people who might be self-paying to work to make care affordable for our patients while still protecting their confidentiality.
Okay, thank you very much. Thank you, Madam Chair.
Thank you, Representative Senator Otmar.
Thank you, Madam Co-Chair, for giving me a second opportunity. So, Dr. Stanwood, I wanted to ask you a question. Around various conversations in this building and also in my conversation with some of my constituents, there is this concern, especially from my African-American sisters and some of the African-American brothers, about the history of your organization. And it's believed by many that there was direct focus on abortion and reproductive prevention in minority communities, would you be able to speak to the current status of the policy and is there differential in access? And how would this bill impact anything, if at all, on this aspect?
Thank you for the question. The communities that we prioritize are those who need the medical safety net, those who are medically underserved. Here in Connecticut, we operate 14 health centers in cities and small towns. We see a demographically diverse population, and often we serve as the only healthcare provider that they see. Our priority is to make sure that all patients have access to high quality, timely, affordable healthcare. And we know that across the country, 1 in 3 women has been to a Planned Parenthood in their lifetime for care, showing how many people trust us with their care. We are the nation's leading provider of quality, affordable sexual and reproductive health care for all communities and all people, no matter their race, gender, ethnicity, income, sexual orientation, gender identity, immigration status, disability, or any other background. So while the founding of our organization had a history that we have disavowed, our current approach is to be there for any and all patients who need our care.
And what are the various things that your organization has done to mend some of those relationships, besides providing access to care whoever needs it?
We enjoy conversations. We enjoy being a part of the communities that we serve by being connected with other community organizations, having conversations with community partners. We have a specific program of community outreach because we know that we can't just be separate from the community. We need to be a part of the community, and we invest our time and our staff in that work.
Thank you for your answer. Is there anything in this bill about gender affirming care for minors?
No.
Okay, just clarifying. Thank you so much. Thank you, Madam Co-Chair.
Thank you very much. Seeing no other questions,
Madam Chair.
Yep, Representative Dauphiné, I was about to say,
Oh.
seeing no other questions, I'm going to go back to Representative Dauphiné for the second time.
Thank you, Madam Chair. Because there were other questions asked, I had a couple of more, and thank you for obliging me. My question is, so we know that there's a lot of things that could happen with things like an abortion or with taking medication that might be prescribed, such as the birth control pill or any of the such. I'm just wondering who takes on the liability if there were one of those complications. I mean, we know that they could get an infection, they could have excessive bleeding from an abortion. There's many studies that are done with regard to PTSD that has occurred in 61% of those that have had an abortion as soon as 3 months after their abortion. I'm just wondering who takes on that liability when you have agreed to give health care without parental knowledge or consent?
We know that the emotional response to abortion care in the vast majority of patients is relief and a readiness to move forward with their chosen path. I'm not familiar with what study you might be discussing about possible PTSD. And we know that from broad literature, that is not the case. People who have abortion care are generally very relieved. As far as managing complications, fortunately, abortion care is very safe. It's about 10 to 14 times safer to have an abortion than it is to go through labor and delivery. And we work with our patients the rare patient who does have a complication, to ensure that they are able to access the care that they need, either with us or if they need to be in a hospital setting, to ensure that that is done in a timely and safe manner for our patients.
Thank you for that answer. There are several studies. I can name a couple. Journal of BMC Psychiatry is one, and the Medical Science Monitor. And there's a few more listed here, the Elliott's Institute model. They speak about there's as many as 61% of those that have had an abortion that will suffer from PTSD. But I just want to move on to something else. In legislation in Hartford, we talk all the time on so many different bills that the brain is not completely developed until you're 25. All the time. We make legislation around that, whether it's choosing to smoke, whether it's choosing to gamble, whether it's choosing to even get married. So many of these to own a gun, so many different things because of this, claim that brain development, it doesn't happen and is not complete until you're 25. How is it that you think that minor children are capable of making some of these very, very complex decisions, and serious ones, I might add, that could bring lifelong effects to them?
I think of a patient who I cared for, who was 17 and who was very clear about what she needed and very clear about her decision making. And she gave me no qualms whatsoever that she was sure of her decision and ready to move forward. And all of the medical organizations that I named before, such as the American Academy of Pediatrics and the AMA and ACOG, they all support minors' access to this care because we know that mandating functional family conversations is not possible, and that most teens involve a trusted adult when they have a trustworthy adult. And it's pretty rare that a teen comes without their parent or guardian or another trusted adult. And in those cases, we very carefully assess the patient's decision-making, support their process through the informed consent. And it is a harm reduction model that the medical community supports. We know that putting barriers to care hurts our youth. This bill is protective of our youth.
Thank you. I appreciate that answer. While I don't think it was the answer I was looking for, I was looking to see why it was that you believed minor children could make such a decision when we are making legislation built around the fact that a brain is not completely developed till they're 25. But I just wanted to make one more comment that this legislation absolutely leaves the parents out, whether they're encouraged or not. Parents make decisions every day, whether their child can take Tylenol in school, get their ears pierced, go on a field trip. They give consent for tattoos, all sorts of things, camp programs. So those are required. Here it is not required. So while you may encourage them, this clearly leaves the parents out unless the child has decided to talk to the parents. I wanted to thank you today for your testimony.
Thanks for your questions.
Thank you, Dr. Stanwood. Representative Gilchrist.
Great. Thank you so much, Madam Chair, and nice to see you, Dr. Stanwood. Just wanted to have a discussion about the repeal language. And if you could just clarify, does the repeal of the 19A-116 mean that abortion clinics won't be regulated here in the state?
No, we will still be regulated in all the ways that are required for licensure of outpatient care.
And so the regulations that are currently on the books really treat abortion care differently than other health care. Is that correct?
Yes, it falls into what we sometimes call abortion exceptionalism, of lifting up and over-regulating and targeting abortion care. And we know that that's not necessary, that abortion is healthcare, and that we are regulated under all the ways that other types of healthcare are already regulated.
Great. Thank you so much. And thanks for your other answers today.
Thank you.
Thank you very much, Dr. Stanwood. Seeing and hearing no other questions, thank you for your time with us today. Oh,
Thanks so much. Happy St. Patrick's.
thank you. Next, we have Megan Smith, who is joining us online.
Thank you. Good afternoon. Dr. Megan Smith on behalf of the Connecticut Hospital Association. I appreciate the opportunity to testify on House Bill 7214 pertaining to maternal health. CHA supports sections 1 and 2 of this, 1 and 3 of the bill pertaining to the Perinatal Mental Health Advisory Task Force and the creation of the Hospital Doula-Friendly Advisory Committee. CHA opposes Section 2 of the bill, pertaining to the creation of a maternal health equity report card. The opposition centers primarily around issues of data validity and availability, and also issues of patient privacy and and current ongoing efforts on maternal health equity in the state. Specific to data availability, the bill around the report card asks for information reported by patient race and income. And hospitals currently do not collect data on patient income. This would require patients to disclose their income to hospitals prior to care or during care. Also pertaining to data availability, the report card calls for the use of qualitative data on maternal health equity. These are data that hospitals also currently do not collect in a systematic manner and would require the use of qualitative data software and employment perhaps of qualitative data researchers and staff. In terms of data validity, the report card proposes creating hospitals as either equitable or inequitable pertaining to maternity care, or giving a grade of A, B, C, D, or F around equity. We are not aware of any national committee or task force or scientific body that has determined what is equitable or inequitable maternal care. And thus an arbitrary designation could in fact exacerbate inequities and mask the root causes of inequities and also potential solutions. In terms of patient privacy, the current reporting for the Maternal Mortality Review Committee in the state and the current reporting to the DPH adverse events around maternal health does not require reporting on facilities or hospital name. And this is primarily to protect patient privacy so that mothers involved in a maternal death or a severe maternal morbidity incident could not be re-identified. Finally, we want to call attention to ongoing efforts in the state on maternal health equity, where there are a significant number of data indicators already being collected that pertain to issues of inequities by race and income. One example is the pregnancy risk assessment monitoring system currently in place with Department of Public Health and the CDC. Another example is the Reproductive Justice Alliance data that's qualitative focus groups on patient experiences of care, implicit bias, and discrimination. And finally, the Connecticut Hospital Association has a 4-part maternal health strategy that we are deploying with hospitals in partnership with Department of Mental Health and Addiction Services and Department of Public Health that involves training of providers on implicit bias and discrimination in maternity care. Thank you for your consideration.
Thank you very much for your time with us today. And I just want to confirm that you have also submitted written testimony.
That is correct. Thank you.
Wonderful. Questions, Senator Anwar?
Thank you so much, Dr. Smith, for your testimony. Dr. Smith, help us understand, because there's a perception amongst the mothers who have been through healthcare system where they feel that the healthcare system was not respectful of them based on some protected classes. And there's some healthcare facilities that go above and beyond to make sure that everybody feels at home and others do not. And how do we measure that in a manner that would be acceptable to Connecticut Hospital Association, but at the same time highlight that some hospitals are doing better than the others?
So, I appreciate the question, and I think that it's important to highlight, one of the pieces of the Hospital Association's maternal health strategy is to ensure that the voices of those giving birth are included in their care. And that is, because different hospitals organize care differently and serve different populations, that strategy is really centered around training on implicit bias. An example is the incorporation of the CDC Hear Her campaign, which is centered on implicit bias. And we are currently talking with DPH as part of the AIM, Alliance for Innovation in Maternal Health Award from HRSA to the state, as really incorporating the Hear Her campaign across the state. And so I think, we can measure, for example, the level of training that is conducted at each hospital. There is also the birthing friendly hospital designation that CMS imparts, which is every hospital participates in the Connecticut Perinatal Quality Collaborative, which is very focused on addressing discrimination and implicit bias in care. And then also that hospitals participate in the Alliance for Innovation in Maternal Health, or the AIM, patient safety bundles. Currently, birthing hospitals are implementing the AIM hypertension safety bundle, and then have plans to implement the perinatal mental health conditions and substance use disorder safety bundles. And as we know from our Connecticut data on maternal mortality and morbidity, perinatal mental health conditions and substance use disorders are, large drivers of inequities in our state and of maternal health in our state. So I think measurement can center around training, and it could also center. We are already looking at hospitals that are implementing the AIM bundles and are participating in that work.
Thank you for your answer. And if I may say that some of that appears more of a status quo in some respects, and then perhaps a little bit more clinical in depth, but it's not, the status quo is already showing that the Black and brown mothers are not feeling comfortable. So we have to do something different. And I love the fact that you're looking at the clinical outcomes data, which is important and perhaps a very critical part of the outcome measurement. But we are talking about how they are made to feel. And that's a different situation. And the questioner in question is, how is somebody feeling that they are welcome and they're being treated as equal?
Yeah, thank you, Dr. Anwar. I appreciate the question. And I think one of the pieces that hospitals have in place is the patient and family advisory councils. And there are certainly efforts at the birthing hospitals to really focus with those councils on doing exactly what you say, and really using best practices, again, from the Alliance for Innovation in Maternal Health Safety Bundles, to ensure that patients are feeling welcomed and heard. And I think that's also, so using the patient and family advisory councils to really specifically focus on the birthing experience can certainly help to do that. And again, that's part of what ACOG's AIM initiative is really focused on, including the voices of those, who are giving birth in their care. I think the other piece, in addition to ensuring that patients feel welcome and respected and heard, and that's why we really want to look at campaigns like the Hear Her campaign and deliver that statewide. I think another piece of this is when we focus so specifically on the birth event, we don't want to disregard the whole entire life course of the mother. And we know that it's so important to think about the health of the mother prior to pregnancy, during pregnancy, and also in that postpartum period. And so another part of the Connecticut Hospital Association maternal health strategy is to also really focus on those upstream root cause drivers of maternal health, like discrimination and implicit bias and economic inequality, and really focus together with our communities about how we can address those upstream root cause drivers. So that's certainly another piece that's central to the work of birthing hospitals, in addition to the part I mentioned about ensuring that patients feel respected and heard.
Thank you so much for your answers, and we look forward to working with you as well. So back to you, Madam Co-Chair.
Thank you, Senator. Representative Belton.
Thank you for all of that information. My question for you is, do you feel like we're doing enough to collect data to improve the quality care for birthing people?
I appreciate the question. Again, alluding back to the Connecticut Hospital Association's maternal health strategy, the fourth part of that is actually really focused on data collection and thinking about optimizing data collection. And we took that directly from some of the national reports at the time, focused on the fact that as a country, we're not doing enough to collect data in general in maternal health. And so we have, again, as part of our work on the Alliance for Innovation in Maternal Health, really begun a quality improvement cycle around data collection for certain indicators of maternal health care. And so the examples are around hypertension and really the time to treat for hypertension. And then when we plan to incorporate the perinatal mental health conditions bundle and substance use disorder bundles, those would be additional areas that we're exploring and collecting additional data on maternal health care.
Thank you, Representative Belton. Just to follow up about one of the programs. You were talking about the CDC Hear Her campaign, but you also talked about HRSA funding. Has that funding remained steady, or have you heard anything about that in recent days?
Sure, I appreciate that question as well. So what we've heard is that funding is here and is we do anticipate that there will be a contract with the Department of Public Health that would allow us to implement the additional AIM patient safety bundles.
Thank you for that answer. Seeing and hearing no other questions, we appreciate your time with us today. Have a great day today.
Thank you very much.
Next, we will actually go to number, I believe, 59. Nope, excuse me. That's wrong. Number 69. Sheila Carney is going to trade places with number 7, Yvette Martis. Ms. Carney, I believe you are online with us.
I'm turning on my auto. Esteemed Chair and members of the Public Health Committee, my name is Dr. Sheila M. Kearney, and I am a resident of Milford, Connecticut. I am a member of the Board of Directors for the Hispanic Health Council, and I am testifying in support of HB 7214, an act concerning maternal health. HB 7214 aims to support racial disparities in maternal health care. Unfortunately, many women of color face higher health risks during childbirth. This bill establishes the Connecticut Maternal Health Report Card, a system designed to assess and publicly report on maternity care at hospitals and birthing facilities. This data will be made public, assist hospitals in addressing inequities, improve transparency, and ensure high-quality maternity care in our state. HB 7214 is a step forward in decreasing maternal mortality and complications for women of color. This bill will hold hospitals and healthcare providers accountable for their treatment of women of color and stop preventable deaths and unnecessary complications from occurring. It is and will require hospital and healthcare providers to investigate their current policies and procedures and make necessary changes that will ensure women of color have births free of trauma and can return home to their loved ones. As we are the most mighty of countries in the world, the United States has one of the highest maternal mortality rates among high-income countries. And here in this country, the maternal mortality rate for Black women remained over 2.5 times as high as that for white women. Why is this? Another example in Connecticut regarding women of color, especially African Americans who make up only 13% of live births. They make more than 27% of all pregnancy-associated deaths. Why? Currently, I'm sorry about that. Currently, I serve as a member of the Hispanic Health Council. However, the issues of healthcare disparities in minority populations in the United States have been of great interest to me academically and professionally over time, beginning with my academic tenure as a researcher at the Harvard Chan School of Public Health.
Excuse me, Ms. Kearney, but your 3 minutes is reached.
Okay, sorry.
Dr. Carney, I thank you. I was actually going to ask you if you could tell us a little bit about your background in practice and in research, and you were going right there. So if you could.
Okay, sure. Unfortunately, I never had the chance to give birth, but in my academic research, I have done research on adolescent pregnancy and school-based health care at the Harvard School of Public Health and Graduate School of Education. I served as a consultant to the Centers for Disease Control, the National Medical Association, and concluded my doctoral research. Oh, sorry.
Is the car there yet?
Oh, please continue, Kathleen. I think you're not muted right now. Go ahead, Dr. Carney, please continue.
Following the unfortunate progress in improvement on maternal and child health care for people of color, it's really discouraging, and I'm asking, why can't we lead the country and the world in this area? Thank you.
Thank you for that answer. Were you able to listen in to the previous testimony just before you?
Yes, I have been.
And I wanted to ask if you had any reflection on that, just some of the barriers that were brought before us from the Connecticut Hospital Association, and if you had thoughts that you wanted to share in response.
Well, in my previous background as being a teacher and also a director of a daycare facility for a number of years, I have seen the evidence of some of the treatment some of the mothers did have in going through the birthing experience, where they suffered unnecessary complications, which they shared with me during the birth of their children. And some of the kind of attitudes that they felt were kind of cold in their during the birthing process. They felt that they may have been discriminated against. They felt that people weren't listening to them when they had questions. And that was kind of a major concern, that we should be able to improve upon that. And that no matter what age you are, ethnicity, whether you are immigrant or not, that everyone has an opinion and that they should be able to get full service.
Thank you very much. Yes, this committee is, I believe we have strong agreement here that the kind of disparities that we see are not acceptable and that we need to make changes going forward. Now we have a question from Senator Elmore.
Thank you so much, Madam Co-Chair. Thank you, Dr. Kearney, for your work and your advocacy. Dr. Kearney, the Connecticut Hospital Association's perspective is that they do not want the financial information to be a consideration in the question and answers or in the questionnaire that we are looking at. And I think that's fair, because they want that to be not collected, and patients may be hesitant to share that. But we can still probably get the data without that piece of information, because what we are looking at is the perception not based on financial aspect, but based more on the racial perspective. Do you think that we can find a compromise there?
I believe so.
Okay, thank you.
Yes.
Thank you so much. Thank you, Madam Chair.
And thank you, members of the committee. This is very important to so many.
Thank you. I believe we have a question. Representative Belton, was I wrong? No. So seeing and hearing, let me actually just double check online. One follow-up, Dr. Carney, have you been able to submit written testimony for us?
I am amending my previous statement, and I will submit it shortly.
Wonderful. Thank you. That will be helpful to us in the committee. Thank you so much for your time with us today.
Thank you.
Next, we have George Austin. Mr. Austin here with us? Okay. If not, then we have Liz DuPont Deal.
Hello, can folks hear me all right?
Yes, we can.
Okay. Good afternoon. Happy St. Patrick's Day. Good afternoon, Dr. Anwar and Representative McCarthy-Vahey and all the distinguished members of the committee. Thank you for the opportunity to speak. I am Liz DuPont Deal. I am the Associate Director of the Connecticut Citizen Action Group. CCAG has worked for more than 50 years to alter the relations of power. In Connecticut, I speak today on behalf of our thousands of member families. CCAG works with allies and our members to combat the corporatization of healthcare, under which for-profit insurance companies and other healthcare industries have resulted in our current broken system, under which the quest for ever increasing profits is the driving priority, and too many people lack coverage and have difficulty getting and paying for medical care. Add this to the rampant inequality, legacy of institutional racism, and social determinants of health, and we have a completely unacceptable healthcare disparities in our state. Some of the bills before you offer the opportunity to make improvements. To that end, we speak in support of 1507, which would improve patient care and protect workers. We applaud limiting private equity ownership of healthcare practices, and Section 2B, which bars interference with clinical decisions, time spent with patients, and other critical elements of healthcare practice. We further urge the committee and the legislature to conduct a comprehensive assessment of private equity ownership of healthcare facilities and nursing homes to better understand its extent and to allow us to develop and implement an appropriate comprehensive response. HB 7213, an act concerning access to reproductive health care, we speak in strong favor. This legislation will strengthen young people's ability to consent to contraceptive and pregnancy-related care, aligning state statute with the medical standard of care. Connecticut has been a leader in recognizing young people's ability to make informed decisions about their health, and passage of this bill would explicitly reaffirm young people's ability to consent to and access contraceptive care and pregnancy-related care, which is to say, healthcare. We speak in partnership with our allies on this issue and strongly urge the committee and the General Assembly to support this bill. Finally, we are in support with our partners and allies on SB 7214 regarding maternal health, which creates a report card system under which hospitals and freestanding birth centers would disaggregate data by race, ethnicity, and socioeconomic status. The Hispanic Health Council and others are offering compelling testimony about racial health disparities that demand action. DPH should appoint a committee to determine what qualitative and quantitative measures will be included in the report card. We must hold hospitals accountable and help decrease the maternal mortality for women of color and their babies. Thank you for the opportunity to testify today. I welcome any questions.
Thank you so much for your testimony, Ms. DuPont-Dale, and the work that CCAG does. And I appreciate your views. Did you get an opportunity to listen to Office of Health Strategies testimony on Senate Bill 1507 about private equity?
I did listen to it, yes.
Any thoughts, any concerns from your perspective?
Not in particular at this point. You know, we applaud the committee for this deep dive that you're taking in the overview of the problem and the recognition of the extent and the scope of the problem. I think there are certainly details to work out, as this committee has recognized, but I think it's extremely positive that this public hearing is happening, and that this and other bills to quantify the problem are being heard. And, you know, as others have said too, recognizing the driving profit motive in terms of being the determinant of how our healthcare is delivered. We're very happy that this is being addressed and look forward to working to make it happen.
Thank you. And thank you for all the work you do as well. So it was good to see you again. Seeing no other questions or comments. Oh, wait, Representative Mara has a question or comment. Rep Mara.
Thank you so much, Mr. Chair. Thank you for your testimony. Just a quick question, please, concerning Bill 7213 concerning reproductive health care. I guess I'm a little bit confused on some of the back and forth that we've heard. It sounds like in practice that minors do have access to health care. So I guess I'm just asking you, from your perspective, have you heard of any issues of minors not having access to health care?
As I understand it, this bill provides additional protection which is needed for minors accessing healthcare. And as I understand it, this is acknowledging the sad reality that not all parents or guardians necessarily are, how do I say, that sometimes this is needed for some young people.
Okay, yeah, no, I thank you. I know what the bill does. I was really looking from kind of a citizen perspective, if you've actually had any complaints or heard that this is an issue, because I think sometimes we write legislation in search of a problem. I'm just curious if there is a problem out there that we need to address particularly.
Do I know of any young people, or do I know any young people who would benefit from this? I could say yes.
Now, do you know of any problems, not of people that could benefit? Have you heard of any problems with your group where there's gaps to care?
No, CCAG, I don't believe has heard that, but as I said, this is a protection that is necessary in our opinion.
Okay, thank you so much. Thank you, Mr. Chair.
Thanks for the question.
Thank you very much. Seeing and hearing no other questions, Liz, thank you very much for being here with us today.
Thank you. Representative
Oh, I think we lost her. I'm sorry about that, Liz. Next we have Andy Beltran. If you could just press the button right in front of you so we can all hear you.
Can you hear me now?
I think if you, yep, there you go. Thank you.
Can you hear me now?
Yes,
Perfect.
thank you.
Thank you. As you can tell, this is my first time doing this, so I appreciate it. Good afternoon, Senator Anwar, Representative McCarthy, Belton. My name is Dr. Andy Beltran. I am a resident in North Haven. I serve as Chief Medical Officer at the Hispanic Health Council and Medical Director at Community Mental Health Affiliates. I am testifying in strong support of HB 7214. And that concerning maternal health, particularly the establishment of the Connecticut Maternal Health Report Card system. Despite advances in healthcare, maternal health outcomes remain deeply unequal, and many women, especially women of color, continue to face barriers.
Take whatever time you need. We're just grateful that you're here with us today.
That put their lives and babies at risk. I have witnessed them firsthand, not just as a healthcare leader and clinician, but as a husband and a father. When my wife, a registered nurse with over 10 years of experience, gave birth, we expected the typical challenges of labor and delivery, but we never imagined she would struggle to have her voice heard. Despite our background in healthcare, we found ourselves fighting to have her concerns acknowledged. The cultural nuances that mattered to her were dismissed, leaving her feeling powerless in a system that she had spent over a decade working within. If an experienced nurse and a physician face these barriers, what happens to those without the knowledge, language, resources, and confidence to advocate for themselves? This is not an isolated experience. It is systemic. Healthcare systems have been built without fully accounting for the cultural preferences and lived experiences of people of color. For centuries, people of color have been used as test subjects in medical experiments, but not treated as human beings with equal rights to care, dignity, and respect. These injustices continue to shape the disparities we see today. This is why this bill is so critical. The Maternal Health Report Card holds institutions accountable, highlight disparities, and drive needed improvements. By tracking racial and ethnic disparities in maternal health outcomes, patient satisfaction, and hospital interventions, this system will provide clear, actionable data to eliminate preventable harm. It will also empower families to make informed choices about where to seek care, because transparency is not a luxury. It is a necessity when it comes to saving lives. I urge this committee to support HB 7214 and make maternal health equity a priority in Connecticut. No mother should feel unheard, unsafe, and unseen when bringing life into this world. This bill is not just about evaluation through a report card. It is about ensuring that hospitals listen, learn, and do better before more families suffer preventable tragedies. Thank you for your time.
I want to thank you so much for being here as a physician, but most of all as a husband and as a father. And the power of your statement and your witness here to us is really just a testament to you.
Thank you.
Thank you for taking the time to be with us and share your story. I know Senator Anwar would like to speak.
Agradecemos su testimonio. Muchas gracias.
Gracias.
Arreglaremos mi hermano.
Muchas gracias. Sí. Igualmente.
Gracias.
There we go. Now I have to remember to turn my microphone on. I don't know that we have questions for you, but I do just want to linger on the fact that you and your wife together had years of medical expertise and experience. But when in the role of patient, it was hard to translate that into the ability to be able to be heard and to provide a safe and just to not experience what sounds like was a painful and difficult experience. So I think that's really telling for us. I think what you said, this is not an isolated experience, it's systemic, was a very powerful statement as well.
Thank you.
So you also heard the testimony earlier from the Hospital Association and hearing about some of the efforts that are there, as well as some of the barriers that they had spoken about. Did you want to reflect on that at all?
I listened to it and I thought of two things. And one was our chair of the Hispanic Health Council mentioned to me, and it didn't make sense at the moment, but it makes sense now, which is that we can't have the fox guarding the hen house. And that resonated with me because it's really hard to remove bias when you have a hospital system or association, or the system itself to monitor itself. It's difficult to do that. I think there has to be an external reporting system or report card in this case. That's number one. And number two was about whether or not we need socioeconomic status in this bill. And it doesn't have to be socioeconomic. We can use even what insurance they carry as a way to indirectly monitor or I guess get a data point on where they lie in a socioeconomic, I guess, spectrum. Those are my two reflections on those two things.
Thank you. Yeah, that's an excellent idea. And I think that's a great example of how we can work together to see how we can achieve these results. I think the bottom line, as we continue to say here, and we're going to continue to say in this committee, as long as we need to say it, is the disparities are unconscionable. And the disparities are not something that we will accept. And I don't believe our hospital systems or our department or anyone is okay with seeing that. It's what can we do to change those systems and to address the issues from all the angles necessary.
Thank you. I appreciate it.
Seeing and hearing no other questions, we will go on to Mr. Thomas Burr. Thank you for being here with us, Doctor. Mr. Burr, welcome.
Yes, good afternoon, Senator Anwar, Representative McCarthy Vahey, and members of the Public Health Committee, and happy St. Patrick's Day to you all. It's good to see you all again. My name is Thomas Burr, and I'm the Public Policy Manager of the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. NAMI, as you know, is the nation's largest grassroots mental health organization dedicated to building better lives for the millions of Americans affected by mental illness. I am testifying before you today in support of House Bill 7214, an act concerning maternal health. The bill will establish a perinatal health task force to study and make recommendations regarding the improvement of mental health care services in the state. Approximately 1 in 9 women in the United States experience symptoms of postpartum depression. So this is a significant issue that affects approximately 4,000 women every year right here in Connecticut. 4,000 women. Among other things, this bill will provide an analysis of available perinatal mental health care programs, treatments and services, notable innovations in perinatal mental health care treatment, and gaps in the provision and coordination of perinatal mental health care services that affect the diverse perinatal experiences of unique populations. This bill also establishes the Connecticut Maternal Health Report Card, a system designed to assess and publicly report on maternity care at hospitals and birthing facilities. This data will be made public, assist hospitals in addressing inequities, improve transparency, and ensure high-quality maternity care in our state. So, in conclusion, I'd just like to say that I'm very pleased to hear that the Connecticut Department of Mental Health and Addiction Service is already involved in these spaces and supports this legislation. And we strongly urge the Public Health Committee to favorably vote on House Bill 7214. Thank you for your time and attention, as well as this committee's continued support of legislation involving mental health. It is duly noted and very much appreciated. Thank you.
Thank you for being here today, Mr. Burr, and thank you for your ongoing advocacy.
My pleasure.
Seeing and hearing no questions, we will go next to Rashad Gibson. Welcome.
Good afternoon. My name is Rashad Gibson, and I am a PhD candidate and a pastor, and I oppose HB 7213. My first thought regarding this bill when I first read it was, as a state representative proposing this, how do you sleep at night? Are you all willing to tell me that you have a clear conscience while giving the right to a minor to have an abortion without parental consent? But let me go a step further, because I believe this is a layer of lawlessness. I find it very difficult to concede that it is a woman's, or in this case, a child's right, historically or theologically, to dismember their child in utero and then call it reproductive health care. Or to take a pill and then flush the baby down the toilet as if it's nothing more than human waste. The question that I have when it comes to these issues is, where do our rights come from? If you guessed our rights come from our creator, you guessed right. According to Thomas Jefferson, he said this in our Declaration of Independence. He said, men are endowed by the creator with certain unalienable rights, which meaning that these are rights that they cannot be taken away. And he gives us a short list. And that list is life, liberty, and the pursuit of happiness. And let me be very clear. The pursuit of happiness is not to do whatever you want. Historically, that meant to live a life of virtue. And most importantly, the government is supposed to secure those particular rights. And when I think about this particular bill and this organic law, it's hard for me to understand how this particular bill would be in sync with organic law. Now, I know that many of you on this panel probably feel partisan pressure to pass this bill, but I would implore you to do this. Consider your own soul. Consider if this was your child. How would you feel if you got a bill in the mail saying your child had an abortion and you had no idea this even happened? So with that being said, please reconsider and rescind Bill HB 7213. Thank you.
Thank you, Mr. Gibson. Just to be clear, the bill does not provide a minor's right to abortion. That is already codified into state statute, which was done in 1991. The bill provides an explicit right for contraceptive care and pregnancy care, which some here today have asserted, and many lawyers would agree is a right in statute, but the bill explicitly gives a right again for contraceptive care and for pregnancy care. Representative Dauphiné.
Thank you, Madam Chair, and thank you, Rashad, for being here today to testify. I think there's little left to be said on how you feel. I just wondered if you could expand a little bit, and to the good chair's point, this is just making it very explicit, but I think that what you're sharing today is that you don't approve of that either. But can you just speak to a little bit about earlier there was a testimony with regard to a doctor who said that she does not believe this is an affront on parental rights. And I just wondered if you could speak to that, because in these cases, minor children get an abortion, which is already in law, and to the good chair's point. These children go for an abortion and do not necessarily notify the parents or get their consent. And do you think that is an affront on parental rights?
Absolutely. And I'll speak to both points. I understand that this law has been on the books to a certain degree for some time. But as William Penn once said, an unjust law is no law at all. And the fact of the matter is, when we understand the barbarism within the act of an abortion, it is absolutely horrific. And we can rationalize these things all day long. Of course, I'm speaking from a pastoral perspective, but I will even more say or state this from a human perspective, because we all know within our own souls, our own conscience, that this isn't right. But to even make this law more explicit for children in that regard, with pretty much doing away with parental consent, I think that is horrendous. With my daughter, she's 7 years old, so thank God she's not able to have babies right now. But if my daughter was in this position, I would be horrified to find out she went through this process without us, my wife or I, even knowing about it. And so I just think that this is the state going way too far in trying to make this law so explicit that the parents are left in the dark.
And thank you for that answer. And just one other question. Can you speak to where your experience has been from the Black community? I know there was a question earlier about the origination of abortion and where it started. Can you just speak to that and how you feel today with regard to making it? Actually, it seems sometimes as though we advertise to do it, and with regard to the Black community.
Yes, I think, frankly, most in the Black community are unaware of the history behind abortion, particularly in the case of Planned Parenthood. And I think if most did understand the history, it may give them something to think about at the very least. But not only the Planned Parenthood history, but the actual act itself. Most people have never seen an abortion and know what goes into it. But when you understand the nature of it, the barbarism, and then the history, it should be something that we all should consider. And it's indeed not healthcare. We can use that term to try to cover up the guilt behind it. But the reality is, it is barbarism. And it is not a right. In fact, this goes to my fundamental point. Our rights have a theological nature built into it. And if a theological nature built into it, then we have to consider the morality of it. But for some reason, in this case, that goes out the window. I don't understand why. Perhaps maybe I do. But the reality is, yes, indeed, in the Black community, this is a problem. We lead the nation in abortions. We're proportionately, and it's affecting our community as a whole. And so, yes, it is a very, very serious problem.
Thank you for that. And thank you, Rashad, for your testimony.
No problem.
Thank you. Seeing and hearing no other questions or comments, thank you for being here with us today. And we will go on to, actually, we're going to have another switch, number 71. Dave Hannon will be trading places with number 14, Tom Gilberti. So Mr. Hannon, welcome. Mr. Hannon, if you are able to unmute yourself, please.
Yep, sorry about that. Good morning, chairpersons and members of the Public Health Committee. My name is Dave Hannon, and I am the president of Connecticut Healthcare Associates District 1199 of the National Union of Hospital and Healthcare Employees. Thank you for the opportunity to testify today in support of Senate Bill 1507. This bill takes critical steps to protect our healthcare system by addressing three major issues: the financial stability of our hospitals, the growing threat of private equity in healthcare, and the need to protect clinical independence for medical professionals. First, SB 1507 directs the Commissioner of Health Strategy to evaluate whether the Attorney General should have the power to petition for hospital receivership in cases of financial distress. We already have a process for nursing home receivership in Connecticut, which has helped keep facilities open and stabilize care during financial crises. But right now, there is no equivalent protection for hospitals. Other states like New York and California have used receivership to prevent hospitals from closing overnight and leaving entire communities without care. Connecticut must be prepared to act before a hospital collapses, not after. Second, this bill would prohibit private equity firms and real estate investment trusts from acquiring or increasing control over hospitals and healthcare institutions. This is a problem across the country, but we don't need to look that far to have an example of this. It's happening right now in Waterbury, Rockville, and Manchester. Nearly 750,000 Connecticut residents in the catchment areas of these three bankrupt facilities have been and will continue to be impacted by Prospect Medical Holdings and Medical Property Trust's predatory practices which leave no doubt what their primary motivation is, not patient care, but profits above all else. Connecticut is acutely experiencing what happens when private equity takes over healthcare. They cut staff, strip resources, and pile on debt, forcing hospitals to close. As a point of reference, Waterbury Hospital employs nearly 5% of working Waterbury residents. This is about putting patient care ahead of profit and local communities ahead of out-of-state investors who have no ties to those communities. Connecticut should always prioritize our residents and not allow outside investors to gamble with our healthcare system. Finally, SB 1507 ensures that medical decisions remain in the hands of doctors and nurses, not corporate executives. It prevents healthcare facilities from interfering with the clinical judgment of providers, ensuring that patient care is driven by medical need, not financial incentives. We cannot afford to wait until the next hospital closure to act. This bill puts protections in place now before it's too late. I urge you to pass SB 1507 and take a stand for Connecticut's patients, healthcare workers, and communities. Thank you.
Mr. Hannon, thank you for being here with us today and for your advocacy.
You're welcome.
Seeing and hearing no questions, we will next have Olivia Rinks. Okay, if she's not here, then we have number 16, Bonnie Roswig.
Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee. Thank you for giving me the opportunity to testify in support of House Bill 7213, an act concerning access to reproductive health care. My name is Bonnie Roswig, and I'm an attorney with the Center for Children's Advocacy. I am the director of our medical legal partnership, and a significant portion of my practice is working with healthcare providers as they work to meet the needs of their adolescent patients. House Bill 7213 seeks to accomplish a number of critical treatment alternatives for our youth. First, it codifies the right to confidential access to birth control for minors. Secondly, it expressly gives minors the right to confidentially agree to a range of treatment options during pregnancy and during the birthing process. Connecticut has a long history of respecting the right to confidential reproductive health care for all of our residents, regardless of age. Our existing law explicitly includes the right of minors to consent to abortion as well as treatment of HIV STDs. These existing laws work to protect the health and well-being of these minors. Specifically, adding confidential access to birth control to these protections impacts the health and well-being of these young people. The benefits include access to safe and reliable birth control medication. We never want anyone to try and access a medication from an unreliable source where we don't know that the medication has been properly vetted. Also, communication with a medical professional as the source of sexual health information is an important step. If adolescents know they can have a confidential relationship with a healthcare provider, then they have an open door to accurate information. Finally, confidential access to birth control avoids consequences such as unwanted pregnancy. House Bill 7213 also expressly gives the minor the right to confidentially consent to appropriate supports during pregnancy, labor, and delivery. Expectant mothers should have the right to all pregnancy and pain management options, and no healthcare provider should have their treatment alternatives limited because the law is ambiguous. Healthcare professionals believe and support open communication between their patients and their parents and guardians in all areas, including sexual activity. However, we don't want our youth to reject treatment because access is not confidential. As the Academy of Pediatrics has noted, confidentiality is a foundational element of high quality, accessible, and equitable healthcare. The public health data shows that confidentiality provisions promote access to medical needed services and improves outcomes. Thank you for the opportunity to testify today. I'm happy to answer any questions that you may have.
Thank you, Ms. Rosswig. Thank you for being here with us today. So since you are a lawyer, I'll ask you some of those.
And you will, the questions will be gentle in that context.
Yes, and I'll try not to ask you questions that belong with the medical providers. But in questioning earlier, I'm sure you heard just why the need, why this now? Because sometimes, I guess I would put it this way, lawyers sometimes disagree, which is why we have the courts. And what we've heard is that there is disagreement and a lack of clarity, and there are some places and spaces where providers have been hesitant to provide care because of the lack of clarity in the law. So if you, again, back to my question, why is this necessary now?
I think there is lack of clarity in the law. I think there are certain protections that are specifically spelled out. And in the statute, it does not say birth control. And so I think even though that has been the practice for decades, because it is part of, our respect in the state for self-determination and control of one's body, the words birth control are not in the statute, which particularly given the political environment, has raised concerns among some of the providers. It gives clarity, and it lets the providers do their job. It's not forbidden, but is not specifically stated.
So that clarity gives protection to the providers and provides more legal certainty when it comes to, for example, the issue of liability that we were hearing about earlier.
Yeah, I mean, it gives clarity in terms of their treatment options. Again, there is nothing in the statute in HIPAA that prevents them from providing that treatment. But I think that that the comfort level is raised if that language is specific. I wanted to go back to your question about which states in the area allow confidential access to birth control. There's something called the Guttmacher report, which is referenced in my testimony and some of the other testimonies. Maine, Massachusetts, New York, Vermont, in terms of the area states, all have confidential access to birth control for minors.
Thank you. And I did note that was in your testimony, although I don't believe the hyperlink is working in testimony. So we'll see if we can figure that out.
We're happy to provide that
No,
separately.
that's grateful. So basically, the statute doesn't prohibit a provider from providing birth control.
Correct.
But it's not clear that a provider is able to provide birth control. And your position is that this language provides the kind of clarity that providers are looking for, especially right now, given some of the changes in terms of the court rulings that we've had, for example.
That is what has been articulated by some providers, not all providers, but some providers.
Okay, so it's not across the board, but it's, again, what's not across the board is the clarity that there is an ability to provide this care.
Correct.
Specific to pregnancy care, because you've been talking more about the birth control aspect. Can you just elaborate a little bit on that? That in your testimony, you talked about a minor's ability to access. And I think we've heard, not necessarily in conversations here today, but in other conversations, that, hospitals would be providing a certain standard of care. So if you can get into some of the legal details with that as well, it would be helpful.
So I think perhaps the confusion, the concern, or the narrow interpretation is around access to reproductive health care versus what is a medical procedure. And I think some hospitals have taken the position that certain forms of pain management during birth are procedures that where the adolescent cannot consent to treat. This is all around certain carved out areas of consent to treat in the area of reproductive health care. So I do not have personal experience, but it's been articulated to me by some of the relevant physicians that some hospitals will not provide all range of pain management during labor and delivery.
For example, an epidural.
Correct. That, again, that is what's been articulated to me. I have not called those hospitals. I do not have personal knowledge of that, but I think that, again, in this, because that concern has been raised, we don't want to limit the patient's options, and we don't want to limit the physician or the healthcare provider in terms of what they think is medically necessary and appropriate for their patient.
I very much appreciate the answer. As a lawyer, I appreciate that and respect that, and your representation, just sharing what you know and what you have heard and are aware of. Senator Anwar.
Thank you so much, Madam Co-Chair. I think you asked one of the questions about the epidural, because I think that was part of the issue where we are hearing that the minors were not able to get epidural and having to undergo delivery, which was painful and not the way we would treat individuals. Can I ask you, why do we need a bill like this?
You know, I think we want to make sure that young people get the services and supports they need. We don't want any young person, if the provider feels that they cannot offer this service to this young person, then it leads to all kinds of negative, it can lead to all kinds of negative consequences. You know, young people are going to be engaged in sexual activity, and to therefore not provide access to reproductive health care isn't going to change behavior, it's going to change protections. And so young people need to know that there is a trusted healthcare provider out there that they can get accurate information from, and whatever services and supports they need. If they don't have that confidential resource, then they're going to go to sources that could be dangerous, medication that isn't properly vetted, other services that negatively impact their health. Again, as you know, as we discussed earlier, this is not to say that, again and again, healthcare professionals encourage their patients to have conversations with their parents about sexual activity. But if they do not feel comfortable doing that, then they need to have a trusted healthcare provider who they can have these conversations with. If the provider feels that they're not able or somehow prohibited from providing this care, then that is going to be hugely problematic to the safety and well-being of these young people.
Thank you for that answer. And would you be able to give us an insight into situations where a minor the reasoning why the minor would not want the information to be shared with their parents or guardians?
Certainly. I mean, we have been, again, some of the providers have shared that there are situations where parents might react very negatively and aggressively against young people who are engaged in sexual activity in terms of abuse and so physical abuse. And so we never want to put a young person in that position. And so that is, you know, that is the rationale behind the other reason for protection.
And there's a physical abuse, but there are very thankfully rare cases of other kind of abuse that leads to some of these situations.
I'm sorry, could you please clarify the question?
In other words, some of these children are sexually abused too.
You know, I don't know necessarily by parents, but in situations where, you know, you bring up a really important point. If a young person has a confidential relationship with a healthcare provider, they can discuss sexual activity that actually might rise to the level of sexual abuse and thus mandated reporting. I mean, we have very clear, very specific laws in Connecticut around under what circumstances a healthcare provider must report if the sexual activity of the young person is problematic. But we want young people to be able to access that professional resource, to have those confidential conversations, so that if mandated reporting is necessary, then that door continues to be open.
Thank you so much for your responses, and thank you for your testimony. Back to you, Madam Co-Chair.
You're welcome.
Thank you very much. Representative Mara, to be followed by Representative Dauphiné.
Thank you so much, Madam Chair. Thank you for your testimony. I really appreciate you being here. I do believe there should be no barriers to birth control. So I would like to make sure that that is somehow codified. I do have some other concerns in this bill, though, and I just kind of wanted to walk through a couple of them with you. We talk a lot about minors. I mean, we know there's a big difference between someone that's 16, 17, 18-year-old maybe, and someone that might be 12 or 13. So do you have any thoughts about whether there should be differences in whether a parent should be involved, or there should be other considerations when you're dealing with someone particularly young, or maybe their cognitive ability to even make such decisions?
It's an excellent question. Thank you. So the law provides that any healthcare professional or anyone who learns that a child under the age of 13 is involved in sexual activity is mandated to report. That is, addresses your concerns that 12-year-olds, should not be engaged in this kind of activity. And so that is really the legal, line of demarcation, so that absolutely those young people are protected. And the law specifically was drafted so that their, potential abuse is addressed.
Okay, thanks. The physician at Planned Parenthood mentioned that before, and I appreciate you reiterating that. I think that's important for everyone to hear and understand. For those cases, would you're reporting them, but are the parents involved at all?
The parents are going to find out because DCF is going to be, it's reported to DCF. It is possible that they will file a police report will also be filed. So,
Okay.
The young person might not want that to happen, but at the end of the day, the reality is that the parents could very well find out.
Okay, yeah, sure. As I kind of go through this law, I think one of my concerns is Section 4, which repeals regulations 19A-116. Do you have any thoughts on that?
I don't have specific thoughts on that, but as the doctor from Planned Parenthood said, we don't want abortion procedures to be restricted. That is a decision of the medical provider, and therefore, we need to leave it. We don't want to tie their hands in terms of what they can do and not do. And I have to say, I am not an expert in that area. So I'm going to pass on any other evaluation of that portion.
Okay, no, that's okay. I think we're talking about two different regulations, and it's not fair because I have it sitting in front of me and I've just sprung this on you. So this one particular is not the one that I read out to the physician earlier. This one mostly follows what the law says, but then there's a section in there that has informed consent prior to performing an abortion. And I just wonder what your thoughts on are repealing informed consent in our regulations.
So, the statute itself has very specific guidelines around counseling and what has to happen before a provider, goes to the next step in terms of abortion care. And so I think that takes care of it.
Okay, I don't see that in that particular language, but behind the scenes, I think we can go back and look at it. I don't see informed consent in that particular statute section. I see it only here in the regulations, but that's something we can certainly look into. I think what you were alluding to earlier, and if you don't mind, I'll just kind of refresh your memory, is one that's not particularly not repealed, but I know has been attempted to repeal in the past, is Regulation 19-13D54. And this one particularly says that during the third trimester of pregnancy, abortions may be performed only when necessary to preserve the life or health of the expectant mother. Do you think that we should be taking that out?
I'm not going to comment. I'm commenting today on this particular statute that has to do with birth control and delivery and not on the abortion statute. It's my understanding that is not currently in front of the committee today.
You're correct. It's not in front of the committee. It's something that has been tried to be added in the past. So I think my concern is I'm looking at this bill when we pass it out of committee. If I hear and I see that there's a lot of enthusiasm for removing that, as well as if a newborn shows signs of life following an abortion, those measures used to support life in a premature infant shall be employed. If that is removed, I have serious problems with moving forward. And unfortunately, I was kind of unable to get clear understanding from someone that testified earlier. So I just thought it might help me understand what the motives are for this particular bill moving forward, because it seems like this particular bill could be shortened quite a bit by just add oral contraceptives to access for minors. It could be a one-liner. And otherwise, it seems to be a rather large bill for what I believe should be a very simple process. Do you have any comments on that?
I don't have any comments on that section that you're concerned about. But I agree that it could be, in terms of access to birth control, it could be a very short ad.
Okay. Thank you so much. I really appreciate your answers. And that's all, Madam Chair.
Thank you.
Thank you very much, Representative Mara. Representative Dauphiné to be followed by Representative Clara Distitria to be followed by Representative Jenga.
Thank you, Madam Chair, and thank you for being here today to testify. My questions, I was glad to hear that you were an attorney, because I think some of them are specific to the law. Do you, what kind of experience do you have working with minors, those under 18?
So I work for the Center for Children's Advocacy's Medical Legal Partnership. And so a good part of my practice is working with young people and their parents in all areas that affect them.
Thank you for that answer. So, well, earlier I had mentioned that we pass a lot of bills up here, and a lot of them are, the argument is made that our brain isn't fully developed till we're 25, and those under 25 shouldn't be allowed to make certain decisions like deciding to smoke or drink or get married, and many others. I just wondered if you could speak to that with regard to the ability for those from, I guess we're talking about 13 to 18, because you're saying that those under 13 would be reported. So a 13-year-old making a decision, perhaps some of these decisions, what are your thoughts on their ability to make those decisions? I guess I look at them as rather adult decisions. Can you speak to that?
So it's a really good question. And you're right. What our laws say is that a young person does not have capacity to consent until they're 18. However, there are very specific carve-outs related to reproductive health care. And that is because of the potential dangers of young people not accessing that support. So it is very specific. It's very specific in the law. It's been the law in Connecticut since 1991. So it is not for all things, and we do not give minors the capacity to consent to many things, but we do in these areas of reproductive health care.
So you don't have any thoughts on their capabilities and where they're at in their development regarding making these kinds of decisions?
I just as you mentioned, there are a number of studies the Academy of Pediatrics, American Medical Society has done. I have a file folder with me here of many of those studies and technical reports around the importance of reproductive health care for young people, and in particular, confidential reproductive health care.
Thank you for that answer. My next one is about liability. We talk about complications, side effects, those types of things. When a parent is not involved and not part of that decision making, where does the liability lie when something goes wrong, goes awry?
I mean, I think it is a general liability issue in terms of who has the capacity to, bring that lawsuit for whatever problem ensued on behalf of that child. If it is some kind of tort claim, it would be on behalf of the parent, would do it on behalf of the child.
Okay, thank you for that answer. And do you understand this bill to force doctors who would otherwise not participate in some of, the contraceptive abortion type things to force them to do that? Or is that not, as you see it, as any part of this bill?
I don't think we ever force, if a doctor isn't comfortable with a prescribing something, I don't believe that they ethically are going to do that.
Okay.
But again, that goes to the ethical obligations of physicians.
Well, thank you for that answer. We have had discussion about doctors being, I don't want to know, forced is not a good word, but liable to give information to a patient that they would go against the religious beliefs, and I'll just leave it at that. Sex trafficking, we know that that's huge across the country. What are your thoughts on perhaps minors coming for treatment and, they may not talk about what their sexual experience was and where they came from with regard to that piece of it, and being able to get services without parental knowledge? Can you speak to that?
So again, that is all, you raise a really good reason for young people knowing that they can have confidential conversations. The physicians and the healthcare professionals that deal with young people, those, particularly if it's a young child, I mean, they're looking at the history of the child. They're going to screen if implicitly, if not explicitly, in terms of who is this child, what is their background, what is their experience, does it appear they're being trafficked? And that is why it is so important to give our young people the opportunity to have these confidential conversations, so that someone can red flag that there's an issue and that this child, it needs to be reported and this child needs to be protected.
Thank you for that answer. I was speaking specifically to those that would still be afraid to speak about it, but thank you for being here today, and thank you for your answers. I appreciate it.
You're very welcome.
Thank you, Representative. Representative Clara DeStitria.
Thank you, Madam Chair. Thank you for being here today. I think you were able to answer a lot of questions from a lot of people, and unfortunately we have to ask the same question a bunch of times, maybe to get a different response or an answer, but I appreciate everything. So I just want a little clarification. So you had mentioned, look at my question. As part of your screening, I know when my son was a minor and we would go to the pediatrician would make me boot out of the room, and then they would talk to my son. You feel safe at home? Do you have any concerns? Is that the same process that you go through, trying to find out if these minors are having any issues with domestic violence or feeling unsafe at home?
I think so. I am not, I am not part of the screening process, but that is part of the general screening that the pediatricians will do, particularly as young people get to be adolescents, in terms of, what their experiences, what they're going through, whether they have any concerns, whether they're articulating any risk factors.
Thank you. And I think a large part of, a lot of times we pass legislation up here for a small portion of people that truly need our help. So those, to your point, those minors that can't talk to their parents, because in a perfect world, we want all our kids to be able to come to us or a counselor at school or an adult to get help to get those answers. But it doesn't always work that way. And if they're having issues at home, we want to be able to make sure these kids have safe spaces to talk to people to get the answers to these questions and the help that they need when they know sometimes they can't get it at home. So I appreciate you being here. Thank you, Madam Chair.
You're very welcome.
Thank you, Representative. Representative Jenga.
Hi, Mrs. Roswig. I don't know if you remember, we worked several years ago.
I certainly do.
children's stuff
I
with
certainly
energy and
do. It's very
technology.
nice to see you.
I want to ask you a specific question because based on what you said about services before, are you familiar with the school-based health centers?
Very much so.
Okay. Can a student in high school, 16-year-old student, go to a student-based health center and request birth control?
They have that ability, and the question becomes whether the school-based health center at this time feels comfortable providing that birth control on a or information about birth control on a confidential basis.
Okay, so under current law, they can do that.
It is as we've discussed, it is not explicit in the statute, but for decades, that is what Connecticut providers have been doing. It is not, there's nothing that stops the provider from providing that.
And my understanding is just what you said, but I have a parent who opposed that. Well, great. Thank you. Thank you for your testimony.
Thank you, Representative Jenga. Representative Mara.
Thank you so much, Madam Chair. Appreciate this for the second time. Just a really quick question. Just because you're here for children's advocacy, I'm just wondering, have you, I know that this bill is protecting for the future. I'm just curious, have you had any complaints or issues that have happened already that you've heard about where there's problems and that's why we need to do this?
There are providers who are suddenly very concerned that it is not specifically in the statute and it is impacting their comfort level in terms of providing birth control to their patients. Okay, thank you. So no minor has gone without oral contraceptives now that have requested it, but we have, if I'm just to clarify, but we have providers that are concerned with the current political climate, maybe federally. Is that what I'm understanding? I don't know that that's true. Okay. I don't know the extent that health centers have stopped doing it. I don't know that we have that data. Planned Parenthood might. So just to clarify, so they have or they have not stopped providing oral contraceptives, or you don't know? It is possible that they have. Okay, but you're just unsure. Correct. Okay. All right, I think that's good. Thank you. Thank you, Madam Chair.
Thank you, Representative. And would you say it's probably good for us to speak directly to the health centers, who I'm hoping we'll hear from later today? And I think we should ask that question when they come. But thank you very much for your time and testimony here with us today.
You're very welcome. Thank you so much for hearing this bill.
Next, we have both Adrian Morrill and Kyle Probst, who will be coming up together to testify. Welcome.
Thank you. Thank you, Senator Anwar, Representative McCarthy-Vahey, and members of the Public Health Committee. My name is Adrienne Morrell, Vice President of Government Affairs at MRO, and I'm here to testify in support of SB 1508, an act concerning medical records. For more than 2 decades, MRO has partnered to provide release of information solutions on behalf of hospitals, health systems, physician practices, and other healthcare providers in Connecticut and across the country. In Connecticut and in other states, healthcare providers assign staff to perform ROI or contract these functions to specialized companies like MRO and my colleague next to me that utilize technology and skilled staff to disclose PHI securely, efficiently, and cost-effectively in accordance with applicable law. By outsourcing administrative burdens associated with ROI, healthcare providers can devote more of their resources to providing care to what is most important, their patients. Despite advances in interoperability, retrieval of PHI cannot be achieved with a single click of a mouse. Patient records may be spread across multiple health information systems, include paper records in various locations, and retrieved in other stored media. The ROI process involves up to 45 specific steps, each presenting its own complexities and compliance risks. Federal HIPAA and HITECH Acts control the fees for when a patient requests their own medical records, while state statutes govern the fees charged to third-party requests. It is important to note that the fees in Connecticut's current law or proposed in SB 1508 are not charged to patients. SB 1508 recognizes the importance of this approach to ROI and appropriately updates the law in the following ways. It prioritizes patient privacy. It takes skilled ROI staff to produce records. New laws to protect reproductive health information have been promulgated, adding 10+ review steps to this 45 steps that staff perform to identify highly sensitive information and whether it's authorized for disclosure, such as mental health, substance, and AIDS status. SB 1508 protects against cost shifting to providers. It updates fees that are charged to third-party requesters that have not been updated since 1993, prior to the establishment of HIPAA. This measure modernizes and ensures third-party rates adequately reflect the current complexity of the work to fulfill ROI requests and safeguard patient-sensitive data. Lastly, SB 1508 provides a framework for more predictable charges for third-party requesters. Thank you for the opportunity to voice our strong support for SB 1508. We appreciate your leadership on this issue and look forward to continuing to work with you on it.
Thank you. Go ahead, and then we'll ask questions together.
All right, thank you. My name is Kyle Probst, and I'm the Deputy General Counsel for Datavant, as well as the Vice President of HEOS. And HEOS is the Alliance for Health Information Operations and Standards. We are a group of companies that work as HIPAA business associates for providing release of information services to medical providers across the country. And that would be for hospitals, that would be for clinics, practice groups, and even individual doctors. And we operate in all 50 states, and we rely on these laws both at a federal and state level to make sure that our companies can continue to provide these release of information services for medical providers. In my written testimony, I submitted a detailed description of some of the labor that's involved in protecting patient privacy. And I would encourage each of you to go ahead and read through that. And if you have any questions on it, by all means, I'll entertain those today. But I'd like to veer from the script a little bit and talk a little bit about these two concepts that are competing right now within medical information and privacy generally. We have these two concepts where we talk about interoperability, where we're trying to get medical records in the hands of the patients, the providers, the payers, as well as government entities and even other requesters, so that patient care can be improved and so that we can get better patient outcomes. But at the same time, patients are more concerned than ever with their privacy rights. And we're seeing consumer data privacy laws, we're seeing health data privacy laws, and we're seeing focus on HIPAA itself protecting patient privacy. So how do we juggle these two, I guess, concepts that appear to be antithetical at their core, which is we want this freedom of this free flow of information, but at the same time, we want to honor patients' privacy rights. And I think that one of the struggles that we have as an industry and that you'll have as government agencies or governments that regulate this is, how do we pay to protect the patient privacy? And for years, we've had these state statutes that would say that if a third party were to request those records, that's really when you have the most risk of disclosure. And so that's where that burden has lied for years. And since 1993, these fees have been in place and they have not been addressed. And so we're asking that you support this bill because it would address that fee concept and allow us to continue to provide these valuable services to protect patient privacy. Thank you.
Thank you very much. And Mr. Probst, I don't believe that your testimony has actually hit the system. So to both of you, and I guess I'll address this first to you, when you talk about all of those steps that you have to go through, can you actually, and it sounds like your testimony written will have some of those for us, but can you just put forward what some of those steps are, just explicitly, even give us a number of examples?
Absolutely. And I apologize. I did upload my testimony this morning, so it probably is a matter of it not being in the system yet. But as far as the actual steps, the first thing that we do when we receive a request is we'll have to validate that request. We'll have to make sure that that is a valid HIPAA and a state law request for a patient's medical records. Now, if there's a HIPAA authorization attached to it, we're going to check to make sure that under federal law, all the elements that are required for a HIPAA authorization are included on that authorization, that the information is being provided to us. For instance, one of the most important things I personally feel is included on that authorization is a notice that that record may be redisclosed by the recipient without notice to the patient. So if you have some other means of requesting or directing the record to a third party, it's important for the patient to know on that authorization that when they disclose that record to that third party, it could be redisclosed. And so that's a notice that's required under HIPAA, and it's on every HIPAA authorization. So we'll go through and we'll make sure that it has all the, I believe it's 9 core elements and then some notices, 3 core notices that are required as well under HIPAA. The next thing we'll do is we'll retrieve a medical record number from separate software than the actual electronic health record. So we'll go in and we'll identify the proper medical record number for that patient, and then we'll use that to actually access the EHRs. Now, this is where it can get a little tricky because it's not typically one EHR. Many of the facilities that DataVant works in, for instance, are facilities where you've had consolidations, where you've had one hospital that purchases another one, or you've had mergers where 2 hospitals come together and merge, or you'll have a practice group that's been consolidated with a hospital system. And so you'll have multiple EHRs. And what the hospitals or providers typically don't do is combine that technology into one. If you're on Cerner, it's going to be very expensive to take that Cerner and update it to your Epic software. So they'll leave those legacy systems in place. And if you've got those records for, say, a period of, say, 10 years under law or 7 years under HIPAA, you'll have to go back and check each of those record systems. So when you get a record request for, say, John Doe's record, you'll have to check each of your EHRs, not to mention any paper or possibly even microfilm that you might still have. So then we'll go in and we'll actually pull the records that we have, and then begins the actual laborious process. We've got to take those records. Now, granted, they mostly are electronic in this day and age, but we've got to compare to make sure that each of the records is John Doe's record if John Doe is the patient being, or the subject patient. Because believe it or not, we still have a lot of misfiles in this day and age. A lot of things that happen with medical records are records that come from one provider to another provider and become part of that provider's designated record set. So you'll have records that are transferred from, say, an oncologist to the primary care doctor. The primary care doctor may get records from the hospital where there was an ER admission after a car accident. So now your primary care record has the oncologist records and the hospital records in it. And so we'll have to go through and make sure that those records have been uploaded properly to John Doe's file. We can't just make an assumption that because it says John Doe, that that's going to always be John Doe's records. So we'll go through and identify each page of that record, make sure that it is John Doe's record. The next thing we are looking for is highly sensitive information. Now, the Connecticut General Assembly in June of 2022, it may have actually been the first week of July of 22, passed a reproductive health privacy law in response to the Supreme Court decision in Dobbs. So you were one of the first states actually that protected reproductive health privacy in addition to mental health treatment, substance use and abuse treatment, things like STD and AIDS treatment, HIV AIDS treatment. So now we have this other standard, and many states are following in their footsteps and adopting reproductive health privacy laws as well, where we've got to look for reproductive health privacy within the record and make sure that the patient has expressly consented to that disclosure to a third party. So now we're going through the record and identifying any reproductive health information, making sure that that is not in there. And if it is, that the authorization allows for its disclosure. So this is all highly sensitive information that our people are trained to go in and identify and then take to someone who's a clinician for the medical practice and say, or for the hospital, and say, is this something that we can redact, or do we have an authorization in place? And that goes back to what we first did, reviewing the authorization to see if we can disclose that to that third party.
Thank you. There are many other steps, I'm sure, but
We could be here a
yes,
while, but I'll stop.
yes, I appreciate this was an example of an illustration. EHR, electronic health records, and ROI, release of information, just
Correct.
so that we're all on the same page and following along. Are you finding that AI is being used in this process now?
I am not finding AI being used in this process at this time, but I could see maybe a point in the future where it would be. Right now, we are still very heavy on labor. Labor is reviewing the record. Labor is identifying potential reproductive health information, substance use and abuse information, and making the attempts to either contact the patient for release or to redact.
It's not taking the place of a human. It may be used at the front just for patient matching, but that's about it.
Okay, thank you. Senator Omar.
Thank you so much, Madam Co-Chair. Thank you so much for your testimony, and thank you for being here in person for this testimony. It's important to have this discussion. Now, I was reading the testimonies about this bill. One of the testimonies from Connecticut trial lawyers saying that why is it so expensive in this bill? You just go to Staples and make copy, and that's what the litmus test should be. Help me understand why this is not just a Staples job. In other words, go and make copies and then give them to anybody.
Well, for one, I think, we're all about protecting patient privacy. I mean, as my colleague described, the steps to protect that highly sensitive data, you're not going to Staples to, they're not in charge of protecting your highly sensitive data. It's apples to oranges, I think, to make that comparison. We have highly trained staff who does this work. And to protect patient privacy is job number one.
And if I may add, I'm also a Georgia licensed attorney, and I don't want to make any representations about Connecticut law because I'm not aware on this point, but I do want to say that in Georgia, if you go to the clerk of court and try and copy your deed and you're doing it by yourself, there is a standard $1 fee for each page of your deed or mortgage. So if you're going to refinance your mortgage, it's $1 a page. The current fee right now in Connecticut is 65 cents a page with your protected health information, which has been deemed by many to be more valuable than bank information.
And there's danger of the protected health information, people's privacy and their medications and everything just to be out in front of people who it does not belong to and it does not need to. And I believe it's my understanding that when it leads to somebody in a legal firm, then after that, their ability to share may not necessarily follow the HIPAA laws.
I would agree with that. It's not necessarily governed by HIPAA. It may be governed in other ways, maybe under professional rules of ethics, but not under HIPAA, because the attorneys would not be business associates or covered entities.
And that's why there is relevancy as this data is gathered by an individual, a lawyer. It has to be known in depth about what is being asked for, a specific question, rather than just a text message or an email would come that this patient is giving the permission, give me all of their data for the past 15 years or 7 years in some cases.
I would agree with that.
Have you heard about law firms doing fishing expeditions, getting all the data and getting experts sitting there, retired physicians, and then trying to see what they can find wrong in any level in the mistakes anywhere?
I can say that we have heard that there are, I guess, what you would call fishing expeditions to obtain data to see if there are viable lawsuits. I think that there are some terminology about how you would say that, whether they're valid or not, but I think they're searching to see if there are actually lawsuits that are viable.
And how does that impact healthcare, cost of healthcare?
Well, we do know that, some requests are very large swaths of medical records, often for, cases to see potentially if they're looking to take a case. So, it's whether or not they're taking that case or not.
With respect to healthcare, I would say that one of the ways that if there's not a vendor like an MRO or a Datavant or any of our HEOS companies, providers are required under federal and state law to produce these records. So they've got an administrative and a financial burden that's placed upon them in order to make sure that they're fulfilling these requests and protecting the patient privacy, which is also required under federal and state law. And so that has to be compensated in some way. I mean, as far as I know, the way that medical providers make revenue is from providing medical services. And so having the people who are requesting the records pay for that protection seems equitable. And I think it's been that way for years, and it's that way across 45 states.
And if somebody was to say, look, it's electronic medical records now, most of the places, it's just a few clicks and you're all set. Help me understand that that's not true.
Well, yeah, I mean, I think as we mentioned the 45 steps and then, added steps now to the reproductive healthcare law, it is, regardless of being electronic or paper, it is the same amount of work to ensure that's the right patient on every piece of that record, and ensure that sensitive data is authorized to be disclosed, and whether or not that's extracted from each of those pages. So it's sort of irregardless if it's paper or electronic, it's the same amount of work.
And I think it's also important to note that there are many different EHRs out there that our people have to be trained on. I mean, we're not talking, there might be 10 that are heavy players in the EHR market. I mean, we know the names like the Epics, the Cerners, Allscripts, but there are a lot of independents, and a lot of providers actually will prepare their own EHRs to try and save on costs. And they use the meaningful use money to do so back when that was adopted. But at the same time, you're going to have a lot of different technologies that you have to deal with.
And I just wanted to clarify, both of you feel that the law, the way it is stated in the current form, you're in agreement with it?
I'm sorry, the
proposed bill, sorry. Yeah.
Oh, so
I'm getting ahead.
The bill, we, I believe, support the bill, but we do have some minor technical issues we would like to address with the committee. One is that we noticed that it only addresses, I believe, and I'm going from memory here, but I believe it's 19A 490B. And there's also another code section with fees that's 20-7C. And so we think that it would make sense to update both of them. One regulates the hospitals, the other regulates like physicians and practice groups, I believe. So that, I believe that was 20-7C.
And that would be in your testimony as soon as we get it?
Yes. Yes. And we'll be able to communicate later with the committee on specific revisions that we would suggest if you entertain those.
Actually, your testimony just came in.
Okay.
All right.
Thank you.
Perfect. Thank you so much for being here. Thank you for your testimony, and appreciate you guys being here in person.
Thank you.
Thank you.
Thank you, Senator Elmore. Representative Kennedy.
Thank you, Madam Chair. And I'm just going through the language of the bill again. And the good chairman just asked a question. A lot of things are electronic now, so I'm just trying to grasp this. So let's say you have doctors there with my chart. Okay, it's a Yale related. They all have access. So if I were to change from one doctor to another and they're all in my chart, I don't have to request my records because they already see them. So how does this bill impact if someone has a request for record? I'm just trying, if you could help me to understand that.
Would you like to? So the first thing I would say is about my chart is a synopsis of a record. It's not the entire record. The entire record is actually within the EHR itself, and it's called a designated record set. My chart is a synopsis that's provided to patients that does not include things like your nurse notes, progress notes, daily notes that are taken, especially if you're an inpatient. You've probably, if you've ever been inpatient or known someone, you may have like checks every 15 minutes to check on your status, your blood pressure, your heart rate, make sure that you're, aware and awake, things of that nature. Those aren't going to be in your My Chart. My Chart's going to have things like your surgery reports, your lab reports. It's going to have maybe diagnoses, it's going to have prescriptions, things like that. Think of it as more of a summary. Whereas when we're producing a record, we're actually going into the EHR and we're producing all the records that were authorized to be released under law, as well as by the author or by the patient's authorization.
I think of it as the ROI process is more about completeness. So I think as Kyle just said, the My Chart's sort of the snapshot, but we're pulling from various different
Okay, so thank you very much for that.
EHRs to make a complete record.
Okay, so then what I see in it, let's say, if you were the physician, you don't see all those notes and test results and blood work, whatever. You don't see that, but I see it.
Well, no, we would see it in addition to all the progress notes and everything else. We see, when we go in and pull a record as an MRO, Datavant, a HEOS company, we see the entire record.
Okay,
The only thing we aren't able to see is metadata.
right.
And metadata would, okay.
Okay, no, that was clear on that. I was just, okay,
Yeah.
I appreciate that because we talked about privacy as well. So I just wanted to clarify that. Thank you so much. And thank you for being here.
To be clear, we're business associates under HIPAA, and we've been authorized by the covered entity, which is the medical provider, to access the EHR. So we have certain obligations regarding privacy as a business associate as well.
Okay. Thank you very much for your testimony today. Thank you, Mr. Chairman.
Representative Mara.
Thank you, Madam Chair. So just to confirm then, if Representative Kennedy has a chart and someone else within that same system wants to view her chart, they're not allowed to. Is that correct?
They would have to have a reason to do so. You can't just go and view someone's chart just because you would like to, correct?
Reason or permission?
Yes.
Permission.
Well, it could be both. I mean, it could be a continuing care situation as well.
Okay.
Which I guess would also be classified as a permission, but
Right.
yes.
Yes. Okay. Thank you. That's helpful. Thank you.
Thank you. And just to follow up, I know we'll talk to the attorneys later, but in terms of the getting medical records in order to be able to seek basis for a claim. No, I think what earlier Senator Amor was talking about was kind of going out and looking for that versus the idea of a client has come to you and as an attorney, you're looking for that. I'm sure that's something that you see happen, right? I think you referenced that a little bit and I wondered if you could speak to that a little bit more.
Yeah, I mean, as I said, we've fulfilled the ROI process for patients, providers, and sort of we call third-party requesters, which is what's this particular statute is for, and it's attorneys, life insurers, doing underwriting. There are also sort of third-party that help law firms get records, so that's sort of the types of requesters that we see. But did you see, further clarification on sort of?
I think the difference between kind of putting out a blanket, putting out a blanket request versus a client has come to you and, is seeking to, you're seeking as the attorney to establish, is there an actual case, which you can't do without establishing within the record. So I guess what I'm saying is in what instances are you seeing that blanket request versus those individual client case requests?
So if I may, I think that you would need an authorization from the patient. So I don't think we're seeing like a blanket request, as you would say, to just request patients' records without having some kind of an attorney-client relationship. But I think that when you have an interview, you may have a viable case or not a viable case. And so you're going to request usually any and all records going back sometimes decades to find out if there are any pre-existing injuries, to find out if there's any other things that could weaken the claim, find out if it's a repeat claimant, that kind of thing. And I think that's one of the additional burdens on the healthcare providers is providing this any and all records when we have to go back for, like I said, sometimes decades to produce records.
That's a helpful clarification and confirmation that essentially those records aren't available unless there is authorization or to the conversation with Representative Mara permission
Correct.
in some form. Okay, thank you. Let me just check online. I believe, yep, that's it. Thank you very much.
Thank you.
Thank you for being with us. Okay, I believe next is Kenneth Barella.
Oh, good afternoon. Can you hear me?
Yes, welcome.
Great. My name is Ken Barella. I'm a resident of Hartford, and I'm also the CEO of the Hispanic Health Council. I'm testifying in support of House Bill 7214, an act concerning maternal health. Bill 7214 aims to tackle racial disparities in maternal health care. With your permission, I'm going to edit my comments a little bit so that I can more thoroughly address the comments made by the Connecticut Hospital Association earlier. Is that permissible? Thank you. A few years ago, because of our research and feedback from the community, we established the Maternal and Child Health Center, one of many programs the Hispanic Health Council provides, and organized our annual Maternal Health Conference. The Maternal and Child Health Center provides culturally sensitive integrated services for women before, during, and after pregnancy. This center is imperative for the community in that Black and Hispanic women are less likely to receive routine medical procedures and have higher maternal morbidity factors. As a result, the care experience can be perceived as disrespectful and in some cases has resulted in some serious implications. Unfortunately, many women of color in Connecticut do not have access to these types of culturally resonant services and end up having higher health risks during childbirth. House Bill 7214 will help create access to services and providers that treat women of color with respect and ensure a safe birthing process. More specifically, this bill includes a requirement for a Connecticut maternal health report card, a system that disaggregates qualitative and quantitative data of pregnant women by race, ethnicity, and socioeconomic status at all hospitals and freestanding birth centers. This data will be made public, assist hospitals in addressing inequities, improve transparency, and ensure high-quality care in our state. House Bill 7214 is a step forward in decreasing maternal mortality and complications of women of color. This bill will hold hospitals and healthcare providers accountable for the treatment of women of color. In response to the Connecticut Hospital Association's comments, I want to note the following. One, the proposed report card was not developed in an arbitrary manner. It was based on the following feedback. Research conducted by the Hispanic Healthcare Research Center, Yale, and many others outside of our organization. Also, a maternal health conference on the care experience for people of color. Over 300 professionals attended, physicians, community health workers, doulas, researchers, etc. And as a result of that, a white paper was developed. And we have had feedback from over 200 pregnant women. The 200 pregnant women our maternal health center serves on a regular basis via focus groups, etc. The summary findings were as follows. There is a lack of transparency, care coordination, and cultural sensitivity, which the report card will address. I want to emphasize that our feedback was directly from hundreds, if not thousands of people through the mechanisms that I referenced. The Connecticut Health Association's response was based on feedback from their constituency, which is a limited number of hospitals and birthing centers. We represent a large number of constituents who we did access feedback back from. Number two.
Excuse me, Mr. Barella, but you've reached your 3 minutes. Thank you.
Can I finish these last few comments?
Yes, please do. I'd like to hear the rest of your response. I would have asked you anyway, so go ahead.
I appreciate them very much. The reporting mechanism she referenced is indeed based on status quo and internal reporting mechanisms. The status quo is the problem and is an example of self-monitoring. Number three, we are indeed requesting them to produce and disaggregate data that they are not currently producing or sharing, as is evidenced by their own comments. Number four, We believe that the report card will encourage hospitals to do a better job of coordinating with other agencies on a pre and post basis, subsequently improving outcomes. If in fact your hospital, your birthing center is reporting some negative outcomes, they will do a better job of not only the service at hand, but also ensuring that the pre and post services are being done in a way that ensures better outcomes and, more importantly, the health of their patients. Number 5, we have spoken with and gained support of multiple agencies throughout the state of Connecticut, the Department of Social Services, and the Department of Public Health. And number 6, they indicated that no other states have passed this type of legislation, which is not factual. There is another state who successfully adopted a mental health report card that was passed in Maryland last year. So with that, I ask that you please consider House Bill 7214 in its totality, which aims again to tackle racial disparities in maternal health care. So with that, I thank you for your time and am happy to entertain any questions you might have.
Thank you so much for your advocacy, and I appreciate you thinking ahead and knowing that I was going to ask you to reflect on and respond to what you may have heard. I think we will be in ongoing conversation about this, and just to clarify, I think that you have been working, I know, with a number of these organizations, and just officially, we have not heard directly from DPH and DSS, but you've been in conversation with them about their hopes to move forward on making sure that we're addressing these disparities. And
yes, ma'am, I have, and the conversations have been extremely positive in terms of the potential process towards making this happen, ensuring that it's done in a way that's embraces the community in totality, so that lots of people are involved in this process and addresses the problem at its root. So yes, we have been in contact with them, and they've been extremely supportive of our endeavors.
thank you, Senator Anwar.
Thank you, Mr. Barella, for your testimony. Would you be able to update your testimony or send us another one with the responses to CHA's concerns?
Yes, sir. I'll make sure that happens on an immediate basis.
This was very helpful, and I've looked at the proposals, and I recognize the value of that. So I just wanted to thank you for your work.
You're very welcome. Yeah, my testimony went from this type to this after I listened to their commentary. So
that's good. Thank you, Madam Chair.
Thank you very much, Senator. Seeing and hearing no other questions, thank you so much for your time and testimony today, and we look forward to further work together on this issue.
I am as well. Thank you very much.
Thank you. Okay, next we have Eleanor Sterling. Welcome.
Thank you. Good afternoon, Senator Anwar, Representative McCarthy-Vahey, and honorable members of this committee. My name is Eleanor Sterling. I am testifying here today on behalf of the Connecticut Trial Lawyers Association. My testimony is going to address raised Bill 1507 concerning a prohibition on private equity in medical care. And there were obviously a number of questions directed to 1508, the medical records bill. My colleague Peter Dreyer is going to address that later today. He's a medical negligence specialist, and I'm not as much. So I'm going to leave that to him unless the committee objects to that. And then, of course, I'll take questions. But with regard to 1507, so the Connecticut Trial Lawyers Association is a group of lawyers who represents individuals and families who are the victims of negligence and corporate wrongdoing. And one of the things that we see in our work that can be so devastating and have such a huge human cost is the prioritization of profit over people. And that is one of the reasons why we felt it so important to come in and support 1507. We're testifying as lawyers but also because one of our jobs is to give a voice to our injured clients. And our members currently represent patients injured, seriously injured at Manchester, Rockville, and Waterbury hospitals. Paraplegia injuries, death. So we're aware of the growing body of research that indicates that bad outcomes, particularly infections and falls in the research that we quoted in our written testimony, are associated with private equity control of hospitals. And that makes us recognize that it's possible that some of the clients that our members represent would not have been injured if Prospect hadn't been permitted to invest in these hospitals. And that would have been the best outcome for them. So we support this bill because it would increase patient safety in Connecticut, and that is incredibly important. We also support this bill because of what happens when private equity projects go bad. When a private equity project goes bad, their answer is bankruptcy. They walk away from the community. They devastated the local hospitals, but also these injured patients now become participants in a bankruptcy, which is taking place in Dallas, Texas.
Excuse me,
So-
Ms. Sterling, but you've reached your 3 minutes. Thank you.
Thank you. May I just have 1 minute to wrap up?
Well, please, I was going to ask you, why don't you talk a little bit more about that bankruptcy and the impact and process, please?
Sure, I'd be happy to. So our members have, we've identified at least 35 claims of Connecticut patients who are injured. And this is really the tip of the iceberg in the sense that these are people who are represented by CTLA members, and they're recent cases, but obviously Prospect's investments in Connecticut started years ago in 2016. So those cases now are stopped from proceeding in our superior courts where they would normally go. And what happens is those families now have to bring claims in bankruptcy. They have to go through the expense of retaining a bankruptcy lawyer, and then their prospects for a remedy through the judicial system are diminished. It's too early to say just how greatly diminished they are. In the absolute worst case scenario, they'll have no recovery or a recovery of pennies on the dollar. But the bankruptcy also jeopardizes what insurance coverage might be available. So there's layers of difficulty from the added expense and delay and complexity to the potential for no recovery at all.
Thank you for adding that and that's exactly where I was going to go, is if you could talk about that bankruptcy piece and what that means. And I don't know if you are a bankruptcy attorney or if that's part of the work that you do, but in terms of, how that works in a bankruptcy action, who gets paid? There's an order, there's a prioritization. Can you speak a little bit about that?
I can. I'm not a bankruptcy lawyer, but I have, as a personal injury lawyer, I've worked with clients in bankruptcies or clients who are claimants in bankruptcy. So let me give you a little background. So the debtor, right, which is Prospect, files bankruptcy. They get to file frequently in places that are difficult for the people in the injured communities. So they chose Texas. That means that people from injured in Connecticut are going to have to bring their court claims in Texas. But people from Rhode Island and all the other states where Prospect will have the same issue. The bankruptcy process moves very fast and it's very expensive. So that means that Prospect will have and does have a team of lawyers who are billing by the hour. Typically those teams bill tens of thousands of dollars an hour because they have so many lawyers working on it. The process ultimately will pay secured creditors first. So whoever has, I mean, I know the Prospect doesn't, or the hospitals don't own the land that they were on anymore. Of course, if they did, that would be an asset that would potentially be available in the bankruptcy. But secured creditors get paid first. So injured victims, patients are never secured creditors. They're unsecured. That means that who gets paid first is banks and the big corporate players who had a security interest in whatever hard assets the debtor had. After that comes the unsecured creditors, and the unsecured creditors typically recover pennies on the dollar. If there is insurance, that may be a different picture, but the fact of a debtor going into bankruptcy complicates the availability of insurance. So again, it's the injured patient and other tort claimants who are going to lose out in this process.
Thank you. Senator Elmore.
Thank you, Madam Co-Chair. Thank you, Attorney Sterling, for being here and for being in person. In your experience, we have various models of healthcare for the hospital systems. We have hospital systems which are university-based. They're all linked with university one way or the other, but they're primarily university-based, not-for-profit. But then there's private equity. Do you see the difference in care, systematic care, from the organizational level? There are clinicians, good and not so good clinicians in every place. But for the systematic issues, do you see a difference?
So obviously we evaluate each case on its facts. And as we look at our cases, we're confined to the information that we have regarding that specific patient typically, right? So if there was a systemic problem with an infection, we won't necessarily know that from looking at one individual patient's records. And I'm giving you that background so that when I give you my answer, it's tempered. That being said, we read the medical literature just the way I can tell the members of this committee do, and it's frightening, the doubling of infection rates, the 25% increase in falls. So I can't, as I sit here today, tell you that I have a causative relationship. But what I can tell you is I think that it is very likely that in that pool of cases that we're looking at, there is a group of them that have to do with those systemic failures. And it just would be a case-to-case analysis, but also one that, of course, I can't talk about specific cases here.
And from a policy perspective, our bill is also talking about the real estate ownership and then the sale of it.
Yes.
And when a healthcare system does not even own the place where they're functioning, then there are no assets tied, meaningful assets tied to this. And then does that lead to, and this is hypothetical, right? Does that lead to less responsiveness? Because there's, for a lack of a better way to say it, there's nothing to lose.
It certainly does. It certainly does. Because if you are trying to protect your assets, then there are all these steps you would take around quality care. If that valuable asset of the land were on the line and it needed to be protected, yes, of course. So it also, I mean, the lack of assets then also, from where we sit in the bankruptcy, there's going to be that much less for all those people who are injured.
And as I ask you these questions, I'm asking more from the owner's perspective, not for the people on ground perspective, because I've had the chance to talk to the nursing staff and many of these healthcare facilities and the physicians, and they're trying to do the best that they can with the resources that they have. And every day the resources are being moved around quite a bit, and that's part of the frustration. And perhaps we'll hear from some of the nurses and others today as well. But I think it's the owners who have made decisions on how the ratios will be kept, how things will be managed, and that actually has a direct impact on the well-being of the patients.
Yes, depriving hospitals of necessary equipment, not keeping things up so that, there's the example of the elevator that was out, so they had to move patients up and down the stairs. I mean, that's a terrible burden, not only on patients, but of course on staff who are already under an enormous amount of pressure.
Yeah. Your testimony is very helpful, and it was very much needed. Thank you so much for being here. Thank you, Madam Co-Chair.
Thank you very much. Just in going back to the real estate piece and wanting to get into the weeds a little bit about this. In this case, in our state, you were mentioning that the real estate is not an asset that is owned by the hospitals at this point. And if it were an asset that were owned by the hospitals, what would that mean for this bankruptcy?
So if it were an asset owned by the hospitals, then it would be an asset of Prospect's, what they call bankruptcy estate. But it would be available both to, I mean, if we're really running this out, this hypothetical, it would obviously make those hospitals more attractive to a potential buyer who could come in and run them in a more effective and better way. One of the things that bankruptcy does is it, potentially takes all these assets of Prospect, so each different hospital, and it offers the possibility to sell them to a better buyer. And I know that's one of the things that's been considered, and there was one of the Rhode Island hospitals was actually sold. So it makes the hospital potentially more attractive to the next buyer, who hopefully won't be a private equity buyer. Obviously, that's the goal. But it also, if it were available in bankruptcy, it would provide part of the pool that could then compensate people who got hurt by the Prospect bankruptcy. And, one thing we didn't talk about, but we're talking about injured patients, but very often they're also, and I don't know if this is the case in Prospect, in the Prospect bankruptcy, very often there are also employee contracts that are adjudicated in bankruptcy. So it's not just patients, it's also nursing staff who had contracts with the hospitals whose rights may be resolved. So when you think about what that real estate might do, that it's the pool of assets that all those people may have recourse to. I hope I answered your question.
You did, and I think you made an important point, because at this point in time, our hope certainly is that these 3 hospitals will be purchased and run effectively and efficiently and serve the communities where they are, continue to employ residents of the community, continue to care for patients. And your point about that real estate asset is extremely well taken. And I know, we're the Public Health Committee, not the Judiciary Committee, but we've certainly seen the impact of the way the law is constructed on our access to healthcare. And we appreciate your conversation here with us today. I don't believe we have any other questions or comments, so we thank you for taking the time to be here with us today.
Thank you very
Appreciate
much.
it. Now we will actually go back to number 19, who was here with us in person. We're sorry we missed you. And that's Bianca Neuronis.
Good afternoon. My name is Bianca Noroñas. I am a resident of West Hartford. and I am the director of the Maternal and Child Health Center at the Hispanic Health Council, where each year we serve hundreds of families. And also I have more than 10 years experience providing service and education to families during pregnancy, labor, and postpartum. I'm here to strongly support HB 7214, an act concerning maternal health, which is essential for addressing racial disparities in maternal health care in Connecticut, particularly for women of color. I speak not only from my professional experience, but also from my personal one. In 2021, I became one of many women of color who face life-threatening health risks during childbirth. After my son was born, I was alone in a hospital while he stayed with my mom, who flew to Connecticut just to meet her grandson. But now she had to take care of a newborn for several days and several nights by herself. This because despite repeatedly asking my providers to reduce my over medication I was receiving during labor, they did not listen. As a result, I suffered several complications, dangerous high blood pressure, swelling, and fluid retention. My heart wasn't functioning properly, and now in 2025, I still need medication to manage my blood pressure. I didn't file a complaint or complete a satisfaction service because I was fighting for my life in a hospital that wasn't even the one where I gave birth. My story could have been different if there had been more accountability and transparency. This bill, HB 7214, ensures painful experiences like mine are documented so the Department of Public Health knows what is happening during labor. It demands greater transparency from hospitals, holding them accountable for how they treat patients, particularly women of color who are often ignored or mistreated. No mother should ever endure what I went through, feeling unheard during the most critical time of her life. This bill will help ensure women receive the care we deserve, care that listens to our voice and acknowledges our pain. By passing this bill, we can protect the health and life of mothers, especially women of color in Connecticut. I urge you to vote in favor of HB 7214 to help reduce maternal mortality and morbidity and give children the chance to grow up with healthy, stronger mothers. Thank you for your time and your consideration.
Ms. Noroñas, thank you so much for sharing your story here with us and for the work that you're doing to help hundreds and thousands of other mothers. Senator Elmore.
Bianca, gracias por un testimonio importante. So thank you for sharing your experience. When you were in the hospital, how did you feel? How were you treated? Would you be able to share with us a little bit?
They didn't hear me. Literally, I was just asking for somebody to reduce my medication because my body was not accepting the over medication. So I feel like literally I was going to die. And I was like, please call somebody, call the person in charge. Because the nurse wasn't able to make the decision, and then the person was not there. Probably, I don't know. But I was like for almost an hour asking for help. And after that moment, my heart is not the same and still not the same. I was in a healthy pregnancy. I was doing beautiful during labor, but just they changed the providers. It was a shift the turns. And when the new providers came with another vision, she changed the quality of what we are going to do to go forward with your labor. And in that moment, everything changed.
And do you think you had good prenatal care? Did you have a physician taking care of you during the pregnancy?
It was fair. We always have room for improve, but it was okay. The problem with me was during labor. And can I add a little bit more?
Go ahead and answer. Yeah.
I would like to add that mothers need to have the information to have a proper decision of what hospital I'm going to choose. Not because the hospitals have a webpage that they sell a fantasy of what we are doing. No, because they see it, a report card with the real information of what's happening. And that information is going to provide more tools to families to literally make proper decision on what hospital I'm going to choose, because I'm going to receive a better outcomes. And at the beginning, it could be a little bit bad for hospital, but with the time, they are going to have better goals. Like, oh, I have a not good report, so I'm going to do better for the next one and the next one. And then they are going to compete between them to provide the better service, because they want to have more families to provide the service. So they are going to be trying to do their best so they can have a better report card. And at the end, this is going to have a good benefit, important benefit, life benefit for not only women, but also the rest of the family and the rest of the community.
Thank you for your testimony. Appreciate you. Thank you.
Thank you.
Thank you, Madam Chair, or excuse me, Mr. Chair, sorry. Mr. Madam. I appreciate that, Senator Anwar. Thank you so much for being here with us today and for your testimony and sharing your story, and again, for all of your work. I appreciate it. Next, we will go on to Sally Grossman, who is with us online.
Hi, how are you? I'll be really quick, I promise. So my name is Sally Grossman from Windsor, and I'm here to testify in favor of HB 7213, an act concerning access to reproductive health care. Over the past decade or so, this body has taken many steps to ensure greater access to all forms of reproductive health care. In fact, Connecticut is a leader in this regard. The next logical step would be to enshrine a minor's right to confidentially consent to contraceptives and pregnancy-related care. The state already allows minors to consent to many medical services like abortion, mental health care, STI testing and treatment, and just to name a few. We have recognized the importance of minors being able to make certain medical decisions for themselves. While minors are currently able to access contraceptives without parental consent, clarity is needed to leave no doubt. I think this is especially important now, given the backdrop of the broader national context. I have 2 children, including an 8-year-old daughter. I have open and honest conversations with both my children about many sensitive topics and do my best to let them know I love them no matter what. I imagine almost all parents would want their child to come to them when they're in need, and most do. But the reality is not every parent is a safe person to talk to. If my daughter chooses to access reproductive health care without my knowledge, I would be horrified. But because I failed her as a parent and did not cultivate a relationship with her or provide an environment was built on a foundation of trust, safety, and support. Access to contraceptives and a pregnancy-related care can have lifelong implications. If we force young people to have to face the consequences of their actions, we must also provide them with the necessary tools to make the best decisions for themselves. So I urge this committee to support HB 7213. Okay.
Ms. Grossman, thank you so much for your testimony and your showing up here today with us. Just a question to follow up on what you were saying. You were talking about with your own kids that you would want them to talk with you, and your sense is the importance of that trust, safety, and support. My question is, do you think that there are cases where there is trust, safety, and support in a relationship, but a young person still remains uncomfortable or unwilling to talk to their parents about reproductive health care?
Yeah, I think it can be an uncomfortable conversation. And when I was listening to testimony earlier, and about I think it was the doctor from Planned Parenthood had said one of her patients didn't want to go on, she had a pregnancy scare and didn't want to go on birth control because she thought she needed her parents' consent. And since she didn't, that's not to say that she has a bad relationship with her parents. She just was uncomfortable having that conversation with them. But instead of foregoing, birth control altogether, she she was able to still access that care. And again, and that's what I would want my daughter to come to me. I would want my daughter to feel comfortable with that. But what's more important is that my daughter gets the care she needs.
I think what you're saying is that she would have the choice and ability to access that care. So thank you. Thank you for being here today. Are there any questions from the committee? Seeing and hearing none. Ms. Grossman, thank you for being here with us. Next, we have Diana Good, who I believe is here in person, or maybe not Diana.
Madam Chair, begging the committee's indulgence, Diana actually has the flu, and we thought it prudent not to expose members of the Public Health Committee to the flu during session. So my name is Paul Tarbox. I am the Director of Public Policy and Communications for the Connecticut Council on Problem Gambling. I'll be representing Diana while she gets well. Thank you so much for your time today. We're here in support of HB 7215, an act concerning problem gaming. We've submitted written testimony. Essentially, we just wanted to come and help raise awareness about the internet gaming disorder, this bill in general, and the fact that it's a topic of concern and a correlation between gambling that we've noticed. And we understand that it may be a bit premature in these kind of days for a program to kind of be launched, but we do anticipate and forecast that this will be kind of an issue that's going to affect young adults as well as kids. And we just wanted to come out in support of it. Thank you. And I'm here to answer any questions.
Thank you, Mr. Tarbox. So were you here earlier today when the commissioner was testifying and able to hear some of that conversation?
I was. And obviously, DMHAS is a strong partner of ours, and we appreciate the commissioner and the government relations team. And we would hope to work with the committee and DMHAS in the future, obviously, as this becomes more prone to kind of address the issues. Currently, right now, there's private providers, but there's not a lot of state kind of providers to send people to. So hopefully we can all work together to address this as it actually rises.
So Mr. Tarbox, can you talk to us a little bit about what is happening and what you are seeing in terms of internet gaming and video games and what's happening out there? I know sometimes as a parent of a former middle schooler who had epic battles over things like Minecraft, which we would sometimes exactly chuckle and laugh about, but there I know have heard, many conversations from parents who have concerns. And the question, I think, is, does this behavior then lead to other problem behavior on down the line? And, we're seeing certainly a lot more availability of gambling opportunities for people and lots more commercials about all that. So can you just talk about what you're seeing right now with the video game piece?
Sure. Again, it correlates to some of the same behaviors we're seeing in gambling. Well, the majority of people can responsibly play video games, but there's a segment of the population that become essentially addicted to loot boxes or chasing certain skins, or they spend excessive time inside of virtual environments to the detriment of school, studies, work. They're using monies that's supposed to be allocated for bills or for other things inside of these environments. And it's those people that need some type of help that we're kind of looking to target that can't kind of stop themselves.
So, and I think the members of this committee know that I love to have my opportunity to do these public health announcements. So could you share with us what some of those warning signs are that we might want to look for, especially if you're someone with, if you're living with someone who you think is having some issues with this?
Sure. Also, there's a great resource that we kind of created called Connecticut gamblingandgaming.org. Essentially explores the correlation between both, where you can actually look for problem signs in gaming, problem signs in gambling, how to have a conversation as a parent with kids. But essentially, one of the biggest things is ignoring appropriate boundaries when people are kind of engaging in activities that aren't regular, the acceptable kind of normal stages where they're withdrawn or they're becoming kind of excessive if it's altering their mood or other kind of timetables. Parents kind of just really need to monitor if they're losing type of control of their kind of day-to-day life, if they're using it as kind of an escape vehicle for whatever problems they're dealing with in their regular life, they're now exclusively kind of spending more and more time in a virtual environment or kind of a game. If they're lying about how much money or time they're spending inside of these environments, that's obviously a concern. If their play is causing negative consequences with their friend groups, schoolwork, their jobs, and essentially if their general priorities shift, if they're very focused towards working toward achieving a goal to get into a certain college, but now they're exclusively spending more and more time working towards a game or just spending time away from the things that you feel important, those are all general signs that they may need some type of help.
Thank you for that. So it sounds like your comments earlier with respect to what we heard from our Department of Mental Health and Addiction Services is this is a conversation you're interested in continuing to explore to see how we can partner. But you recognize, I don't want to put words in your mouth, but would you say you recognize some validity of some of the concerns that they expressed?
Not only do we recognize it, we respect it, and we just want to be a good partner with them moving forward, and we look forward to working with them in the committee.
Great. Thank you for your answers. Senator Elmore has a question or comment.
Thank you so much for your testimony. So I'd asked the commissioner at that time that we are in a matter of a few years, it's going to be a tsunami of young boys and girls who would be somewhat addicted to gaming. And then gambling would be the next, God forbid, the step in this. And it's almost like we can't afford to wait, and it's more so having the ability to be prepared so that we can advance this further. I think that because of a variety of reasons, we may not necessarily achieve all that we need to, but we cannot not achieve anything either. There's a way I see this. We have to be ready and start to have that process and create that framework to try and take care of our young boys and girls who are being targeted by some of these companies at this time. So I think we look forward to working with you and DMHAS in this effort. So just wanted to put this for you to consider.
Thank you, Senator. We appreciate it.
Yeah. Thank you, Madam Chair.
Thank you, Senator. Representative Kennedy.
Thank you, Madam Chair, and thanks, Paul, for being here. Really appreciate it. And you brought to light something that's really, really important. It's actually not just for our young adults. It's also for our youth, 18, 21, they're supposed to be 21, who are, like said, the gaming and everything. But it actually starts with parents sometimes. And as you know, I had the opportunity to sit on a panel this past weekend with Dr. Lee, representatives from Mohegan Sun, a psychologist. And it's something that kind of flows under the radar a little bit, if you will. So I was invited to this, and it really got me to thinking, wow, really wouldn't have thought it's where we're at. And the few people that I spoke to that day, it's also a cultural thing. And especially with, so I was at the New England Asian American Cultural Center. And they were telling me that it is cultural for them, that when their relatives come to visit from over in China or wherever the case may be, the first thing they want to do is go to the casinos. They also gave us some statistics of how many buses actually come out of New York City a day, like to the tune of nearly 200 buses a day leave New York City to come to Connecticut. Great revenue, certainly, but it's something that it impacts family life. And that was a lot of what I learned. And I also had spoken with someone that we do need to monitor what our children are doing on their phones. This person told me that their child had racked up $8,000 in debt. And that's, I was taken aback by that, but it's just so easy. Our kids get drawn in, and there's more and more, there's a lot more advertising for it. And certainly it's just so easy to pick up the phone, your cell phone. And it's like, oh, even if you lose, we'll give you $50. Well, doesn't that sound great? That $50 is not free. So I just want to really give you kudos. And I too look forward to working with you more. And this is something that's really, really important. And we have to make sure that we don't fail our kids with this. And especially with all the, it's March Madness. We know that this is one of the busiest bedding seasons. So, keep an eye on your kids. So, but I just want to thank you so much for being here, and thank you for indulging me, Madam Chair.
Representative Kennedy, I want to thank you. It's not an indulgence. I think you're naming exactly why we put the bill before the committee and wanted to have this conversation, because what you're speaking to and what we've heard from Mr. Tarbox and Ms. Good is exactly that issue. So I think the challenge before us is, how do we go forward? Given that this isn't, in the DSM at this point, and given the challenges that the department has outlined, how do we recognize what's happening and begin to do some work with respect to this? I think is a conversation we'll need to continue. But Senator Anwar.
Oh, I didn't have much to add. I was just gonna say that even when we place bets that this public hearing will be over before midnight or not, is bad behavior. So just wanted to mention. Thank you.
Well, that was good. Thank you very much, Senator Anwar, and Mr. Tarbox. Thank you for being with us.
I should probably also add that we have a great website called responsibleplayct.org that teaches you responsible betting strategies if you need it.
Well, see, there you go. We'll take that under advisement here in the committee. Next, we have Brenda Buckbinder, who is joining us from online. Ms. Buckbinder, are you able to unmute and join us?
And start video. There we go. Yeah, I've got both of them. Good afternoon. My name is Brenda Bookbinder. I'm an LCSW and I hail from Willimantic, Connecticut. I am here to support the passage of Maternal Health Act HB 7214 in hopes of promoting more access and equity for maternal health, an issue very dear to our hearts in this community. I found that I am a co-chair of the Health Committee of the NAACP in town, and I'm also a co-founder of the 16-group community coalition known as Wyndham United to Save Our Healthcare. And we have been looking for access and equity and being heard and seen, and we're still struggling with that. I did find that our community is over 50% women and families of color. Even though we're rural, we have no limited access highways. We're all back roads to getting to other facilities. We are struggling for sure. I did find two resources that I wanted to offer those who are listening today. One is the New England Maternal Health Institute. They are a coalition of experts and women consumers, family consumers of healthcare all throughout New England. And they're currently doing a study in Connecticut of fentanyl use and fentanyl overdoses in perinatal women. And I thought that was important for the committee to know. I also watched the PBS special that was completed in January last year of Providence, Rhode Island, not far from us, of the problems of rising maternal morbidity and mortality, even in a highly technical college hospital there. So what they did to repair that was to invite the community in, something that's not happening in Connecticut. Hospitals, and particularly corporate ones, are not listening to the community. Some of the terminology that I learned from that film, there's a fourth trimester that goes from 7 days to 1 year. And this is often where there are pulmonary embolisms, there are eclampsia stories, there are heart failures, a variety of things that happen that do not show up earlier on. Implicit provider bias, we've heard that. This is about not being seen or heard. And healthcare terms and limits are imposed upon the patient. Structural racism and distressed municipalities. We know now that Wyndham has 2.2 years less lifespan from these cut healthcare services. new families and professionals are walking away. We lost a whole bunch of new teachers that wanted to come to Wyndham, but then when they recognized what was going on in town, they walked.
Excuse me, Ms. Bookbinder, but you've reached your 3 minutes. Thank you.
Perfect. And then when it's ready, I will text you.
Oh, I think.
Are there any questions?
Just making sure everyone else is muted. Thank you very much for being here with us today. I don't see any questions or comments, but I also just wanted to say thank you for your ongoing work in this area. And
Thank you
hopefully
so much.
we'll connect you with some of the other advocates who I believe you may well already be connected with.
Thank you so much.
I believe next is John Brady.
Good afternoon. Happy St. Patrick's Day. Senator Anwar, Representative McCarthy-Vey, members of the committee. My name is John Brady. I'm a registered nurse. I'm the vice president of AFT Connecticut. I am a member of Wyndham United to Save Our Healthcare, and I am a member of the Wyndham chapter of the NAACP. I've submitted testimony on 2 bills in favor of 2 bills, HB 7214, the Maternal Health Bill, and SB 1507. And I'll just try to summarize those because I took the under on the 12 o'clock finish for this committee. On 7214, specifically on section 2, labor and delivery services are closing at an alarming rate all over the state and all over the country. In Connecticut, Wyndham, Rockville, and Johnson have closed, and Sharon would have closed had the Attorney General not blocked it. Disproportionately, they are affecting rural communities and communities of color. So obviously, we have to fix the problem. We have to have a strategic plan on what needs to be open for maternal health and what is safe to close. And to do that, we need to understand the problem. 7214 creates a report card for birthing centers and hospitals and an advisory committee to recommend improvements. And I think it's a good step forward on that. On 1507, I think this bill, along with HB 6873, which we had a hearing on last week or the week before, increases protection against private equity in healthcare, and not just in hospitals, but across healthcare. I know that the #1 goal of this committee, and I applaud that this year, is to prevent another incident like what's happened in Prospect, where they literally sold the land out from underneath the hospital. 1507 also requires OHS to look at the need on whether the AG should be able to report to appoint a receiver for a distressed hospital, which I think is a great idea. It might decrease the chance of future bankruptcies before it's too late. And as Dave Hannon said earlier, we have that in nursing homes now. Finally, 1507 protects clinical judgment of healthcare professionals from pressures of profits over patients. There was a time when doctors, nurses, and other healthcare professionals were in charge of hospitals. They weren't questioned. But that's because the directors of the hospitals at those times were doctors, nurses, and other healthcare professionals. And that's just not the case anymore. Healthcare professionals have become an expense to hospitals, not a resource. And, all we have to do is look at the doctors at St. Francis Hospital right now, what's happening to them as an example of that. So I think that combining 1507 and 6873 is a good way to increase protection for Connecticut's patients and residents, and I would push for those to be adopted.
Mr. Brady, thank you for your testimony and for your consummate advocacy on behalf of patients and providers. Senator Anwar.
Thank you so much. Earlier, we were having a conversation on the bankruptcy and what it has done to various hospitals, but the healthcare workers. I know you're in touch with the nurses and what's happening to the contracts. How is it impacting patient care and the healthcare workers?
Yeah, thank you. Our members serve at Rockville and Manchester, and Dave Hannon's members serve at Waterbury. And I am learning more about bankruptcy than I ever thought I would and ever thought I wanted to. Our two unions are working together and with our parent unions, AFT and AFSCME. And we have a team of lawyers, both on in-state lawyers we use for everything, but we also have national lawyers from our parent organizations, and even a lawyer on the ground in Texas working on this. So a lot of smart people, and I'm trying to keep up with what they're saying. It's my understanding that we all have successorship language in our contracts so that if a hospital is sold or merges, then the contract goes with it, at least until the end of that term of the contract. So if it's a 3-year contract till the end of that. Bankruptcy can make that different. The bankruptcy court can set and does set the conditions for what is an acceptable bid, because it's basically an auction, and they can set aside contract successorship language if they feel they need to get enough successful bids. So that's one of the things our attorneys are petitioning and filing paperwork on, fighting for our members and Dave's members to protect that. And we hope that we will protect those things. If we don't, you know, we will be coming back to you guys to try to twist some arms if you can in the governor's office, because it's a matter of protecting the rights of those workers.
Would it be fair to say that these private equity companies have a playbook which includes extracting everything that they can and then go to Chapter 11 bankruptcy and extracting more and having protections in this book, and then do what they did in other states?
Yeah, they do it across the country. When I first took this position, we were in the spot where Tenet was looking to buy ECHN, and I know that some of our people at our DC office at AFT, who really know this kind of stuff, told me that, you know, Tenet's not good, John. You got to see if you can stop this. But like, there seemed to be nobody else that wanted to buy ECHN, Manchester and Rockville. And then when the state OHS put some conditions on the sale, Tenet decided they didn't want to do it. They didn't want to accept those conditions. They backed out and Prospect came forward. And the same people in Washington said, you went from bad to worse. They will do this. They will sell the land underneath the hospitals. They will use that money to pay themselves dividends and bonuses. And then they will have to lease back that land at whatever price the company that owns the land decides. It's the playbook, and then they'll walk away from it. And in states that do not have the certificate of need law that we have, and we have one of the better ones, even though we're constantly trying to close loopholes, in states that don't have it, they just close the hospitals. They don't have to ask the state for permission. They close the hospital like they were closing a 7-Eleven. Declare bankruptcy, walk away. It's unbelievable.
Yeah, that's the bad case scenario that we are all worried about. And then we want to have laws that something like this would never happen again. So your testimony is always helpful. Thank you for being a strong voice for the nurses and your union. Thank you. Thank you, Madam Co-Chair.
Thank you very much, Senator. And again, thank you, Mr. Brady, for being here with us today in so many days. And hopefully, not after midnight.
Thank you.
Thank you. I believe that we may go back to number 26. We're working on some technical issues, but for now, we're going to go to Jason Privilege, who is here with us online. Jason, welcome.
Hello. Thanks so much for having me. So it's always a pleasure to see you all. I'm Jason Privilege, and today I represent the Connecticut Academy of Physician Associates, known as ConAPA. I'm a PA practicing emergency medicine in Waterbury, and I live in Fairfield. ConAPA would like to bring forward an area of omission in Senate Bill 1507 that raises a concern for the Academy, but with a simple change would make the language much stronger and inclusive. Specifically, Section 2, beginning at line 56, speaks to the inability for healthcare facilities or management services to interfere with the professional judgment or clinical decision-making of a, quote, clinician with independent practice authority, end quote. The question is, why is it written in such a way? Because of such language, it opens the door for PAs and non-independent APRNs to have their judgment interfered with or directed through coercive practices. I'll be honest, I'm unaware of any of the major hospital systems allowing APRNs to practice within the system without a collaborative agreement, which then essentially excludes the vast majority of the nearly 15,000 PAs and APRNs that are listed in Connecticut, or that are licensed in Connecticut from the protections listed in Section 2. Despite the common misperceptions about how PAs practice every day, the reality is that PAs are autonomously assessing, diagnosing, and treating thousands of patients in Connecticut every single day. In other words, exercising individual judgment and clinical decision-making. Every patient we see is not then seen and approved of by a physician. So all 6 of the elements listed within the subsection C, beginning at line 88, are all areas that PAs are engaged in every single day. And so while the appearance of the objective of this bill is to protect certain clinicians, ultimately it's the patients who will benefit the most, and such prohibitions will help assure that their care is safe, efficient, and high quality, as it eliminates interference in that care. However, if only some of the members of those 3 groups of clinicians, physicians, PAs, and APRNs, are called out and protected, it leaves a number of patients in jeopardy, as the non-included clinicians are then subject to such interference. And so CONAPA respectfully requests that Section 2 be reworked to eliminate the independent practice authority section and simply include all physicians, PAs, and APRNs. And this is kind of similar to my testimony from last week that I was offered on Senate Bill 1452, and just ensuring that new laws fully recognize the current state of the medical practice landscape. So thank you for all of your work, for being here today, and for hearing me, and for all that you do for Connecticut's patients.
Mr. Privilege, thank you so much for being here again, and have a few technical issues going on. You can't see that in the room. So if you can just I just want to make sure I heard you correctly and fully, just because I was needing to do something else a little bit while you were talking. So what you're asking for in 1507, is it Section 2? Is that right? To include PAs?
Correct. Exactly.
And was there another section as well that I missed?
No, that was the section.
Okay. Okay. Thank you for that. I appreciate your time and testimony. And as I said to Mr. Brady, to also for your consummate advocacy here at the committee. We appreciate you. Seeing and hearing no questions, we will go back. I think we have identified number 26. I believe this is Francis Nunez. Are we correct? Okay, success. You're up.
Thank you. Greetings, Senator Anwar, Representative McCarthy Vahey, and honorable members of the Public Health Committee. My name is Francis Nunez, and I'm calling in from Bridgeport, Connecticut. I'm writing in support of HB 7214, an act concerning maternal health. My daughter, Rosie, is 5 years old now, and she was born at Yale New Haven and spent 23 days in its NICU. I also spent a while in and out of Yale and other hospitals due to complications during and after childbirth. I've worked in and for community organizations for the last decade, and while I was pregnant and in the throes of a health crisis after health crisis related to pregnancy, my mentor at work made an observation and filled a need that I had no idea I even had. My mentor had experienced infertility and high-risk pregnancy herself, so she knew that I would need support with baby and with advocating for myself in healthcare spaces, and so she paid for doula services for me. In the first few weeks of establishing care with my doula were a challenge. I was very used to being hyper independent and was apprehensive of what felt like overburdening my doula with my needs. And she affirmed me and made me feel comfortable with accepting her support rather quickly. She also eased my anxiety about the childbirth journey to come. I went into preterm labor. Like I said, my daughter spent 23 days at Yale's NICU, and she was at the hospital before my own parents could arrive. She asked questions about my emergency C-section that I wouldn't know to ask for myself. She walked me through the chest feeding process over and over until I started to lactate. She not only provided much needed information in moments of need, she also validated my feelings and experiences to alleviate what was very difficult postpartum anxiety and depression for me. My first time experience as a mom would have been drastically different had I not had a doula, and I was extremely privileged and lucky. Not all Black women and women of color are as lucky, and they pay severely for it, even in a state as progressive as Connecticut. According to the March of Dimes birthing report card for Connecticut, the preterm birth rate among babies born to Black birthing people was 1.4 times higher than the rate amongst other babies. Doulas are a critical intervention in the birthing process for Black women and women of color, whether there are complications or not in childbirth. and infant and maternal mortality rates will continue to rise if we don't pool resources to support birthing people in the state. And this includes the establishment of an internal report card from within the state. I have since spoken to mothers and birthing people in my role as community organizing director for various community organizations across the state, including my current role as Planned Parenthood of Southern New England's director of organizing. Each time I found myself asking them about their access to doula services. It concerns me to know that most birthing people who would benefit from doula services cannot afford them or do not wish to navigate the healthcare system's rejection of doulas and doula services within hospital systems. HB 7214 is another important policy that will address the maternal health crisis in our state and improve maternal health outcomes, identify and improve support systems for birthing people, and improve access to doula services. I urge you to support HB 7214 to improve the experiences and needs of mothers and birthing people across the state. The parents of tomorrow's residents of our state deserve well-rounded, comprehensive, equitable healthcare that covers us mentally, physically, and with easy access to support services. Thank you.
Ms. Nunez, thank you very much for sharing your story and experience with us. And it's been a great conversation today, highlighting some of the services and supports that are available. We haven't talked as much about doulas, but they certainly are an important part of maternity process for many people. So we thank you for sharing that.
Thank you.
Seeing and hearing no questions and comments, thank you for being with us. And we will go on to, I believe, Marcella Kurowski.
Hi there, members of the committee. I am Marcella Kurowski. Thank you for the opportunity to speak today. I oppose HB 7213 because human life is precious. This bill is an overreach of state government for it disregards religious and parental rights. Contraception and abortion allows for the use and abuse of women. May our youth be raised to be respectable with healthy boundaries. And if a female is impregnated by coercion or force, may the predator be held accountable instead of killing innocent life. Thank you for your time.
Thank you very much for your time here with us today and for sharing your testimony with us.
Thank you, Representative.
Seeing and hearing no questions or comments, we will go on to, actually, let me just double check. Magali Sagihas, please forgive me if I have mispronounced your name. Welcome, you're online.
It's okay. Can everyone hear me okay?
Yes, we can.
Awesome. Okay. First, I need to commend all of you for hanging in there this whole day. God bless you on that, and hearing everyone's deliberations. So my name is Magali Cajigas. I'm the Connecticut State Director for the Hispanic Federation. And I am here to support the bill that has been raised, 7214, an act concerning maternal health. One of the most significant aspects of this bill is the creation of a Connecticut maternal health report card, which will provide essential data on maternal health outcomes. Transparency in maternal health metrics is vital to identifying disparities, improving healthcare policies, and holding institutions accountable for the well-being of mothers and infants. Currently, maternal mortality and morbidity rates remain alarmingly high, especially among communities of color. A comprehensive report card would allow policymakers, healthcare providers, and the public to track key indicators such as maternal mortality rates, racial and economic disparities in healthcare access, and the effectiveness of state-funded maternal health programs. With this data, we can make informed decisions to improve maternal care and reduce preventable deaths. The report card would also empower expectant mothers with knowledge, allowing them to advocate for their own health and make informed choices about where and how they receive care. By increasing transparency, we can build a healthcare system that prioritizes maternal health and ensures no mother is left behind. On a personal note, I remember when I was pregnant with my daughter, I was an employee of Yale New Haven Hospital and worked for the Patient Relations Department. My colleagues that covered the maternity ward guided me as to what to expect during my stay, what classes to sign up for, such as breastfeeding, labor delivery, etc. When it was time for me to deliver, I came by ambulance because my daughter was sitting on my sciatic nerve and I couldn't walk. I was brought directly to the maternity floor, and because I was not at the point yet to give birth and had been dealing with contractions all day, it was decided to slow my contractions down and let me rest. In the meantime, other moms on the floor, from what I overheard, were C-sections, and I was the only vaginal birth. Hours passed, I rested, and then much later that evening, my contractions were moved up and I gave birth to my daughter. My experience was a total of 31 hours, and luckily my daughter and I both came out of it in good health. Not everyone has that type of experience. I urge the Public Health Committee and the legislature to support HB 7214. This bill has the potential to save lives, improve healthcare equity, and provide a model for maternal health accountability nationwide. Thank you for your time and for your consideration.
Thank you so much for sharing your story with us. It's striking today as we're here hearing very similar stories over and over again in terms of that really difficult experience. And we're glad that you're here to share
Thank you.
with us and to advocate.
Yes, thank you.
Seeing and hearing no questions, we will go on to Mr. George Saris, who I believe is here with us in person. Welcome.
Make sure I put on the right button there. My name is George Saris. I would like to strongly oppose Bill number 7213, an act concerning access to reproductive health care. I have 5 children who I love and am concerned about more than any other person on this planet, except for my wife. Each of our children has a precious gift given to us for whom I would not hesitate to give my life. During their growing up years, there were often times when my children asked for something that I knew would be adversely affecting them, and I said no. Sometimes those decisions didn't line up with what other parents or even physicians and healthcare providers thought they should do. But those other parents, physicians, and healthcare providers didn't have anywhere near the love or concern for my children that my wife and I had. And none of them had the God-given responsibility to care for them that my wife and I had. Minor children are minor because they're not mature enough to make many of the decisions that life requires. That's why they have parents or guardians. Their state of mental development, their knowledge of life experiences, and the frame of reference they have is too short to enable them to fully understand the consequences of their actions. For the state of Connecticut to pass a law that mandates that any minor child should give consent or could give consent for services without the consent or notification of the minor parent's child or the minor child's parents or guardian, and no physician or other healthcare provider shall divulge any information concerning that provision to the minor child without the minor child's express consent, is beyond foolhardy. It's thoughtless, reckless, irresponsible, and dangerous, and it's well beyond the authority that any governmental body should be able to dictate. The actual meaning of the word kidnap is child thief. And the dictionary notes that kidnapping may be accomplished by use of force or fear, or a victim may be enticed by fraud or deception. Why is the state of Connecticut attempting to make the kidnapping of a child legal? Why is the state of Connecticut attempting to pass a law allowing people to steal a minor child from its parents and, against its parents' wishes and knowledge, perform what could be irreversible actions on that child, including terminating a pregnancy, dispensing what could be life-altering drugs, or give advice and counsel that may be motivated by philosophical ideas in clear opposition to the values and concerns of the child's parents? Why is the state of Connecticut mandating that a minor child who may be fearful and easily enticed by fraud or deception be given the authority to make life-altering decisions that are beyond their ability to fully understand or make? Please vote no on Bill 7213.
Mr. Saras, thank you for being here with us today and for your testimony. We appreciate you staying here with us for such a long day.
Well, thank you for being here as well.
Representative Zupkis.
Thank you, Madam Chair. Thank you for coming today. I happen to agree completely with you. Have you looked at this bill and all the sections of it?
I read through the bill, and the point that was most concerning to me was this whole idea that the parents are a minor child, like I said, a minor child who's not able to make, in fact, we just heard someone say about gambling, that a minor child got $10,000 or $8,000 worth of gambling debts. And I'm thinking, this is crazy.
Right. Well, I just wanted to bring
Yeah.
to your attention that there's part of it where the bill wants to repeal some of the statutes that are already. And one thing I just want to tell you what they are that in this bill is asking to be repealed. One is that even if you are of religious belief or like St. Mary's Hospital, that they would, that right now they don't have to perform abortions, but they would have to if that is repealed. Another section is that if a newborn shows signs of life following an abortion, those measures used to support life would be employed, but that is also being asked to be repealed. So if a baby is breathing and alive after birth, you could,
That
I
is
guess,
horrific.
choose to abort it.
Yeah.
And then the last one that is asked to being repealed is in the third trimester, if it comes to a mother and she's in harm, that they can abort the baby, which happens now, but that's also being asked to be repealed, which ultimately means you could have an abortion in the third trimester. So just wanted to, I'm sure I know what your thoughts are, but if you had a quick comment on that section as well.
Yeah, it is kind of amazing that we seem to be pursuing death instead of life in those situations. I was talking with a friend just recently, and he said, you know, Elon Musk is going to be sending up a rocket to Mars. If they happen to find some little tiny bacteria on Mars, they will say, wow, we found life. But now you've got a little child who has a beating heart, and yet you deny that that's life. You say, well, let's just kill it. Unfortunately, abortion kills babies. That's the bottom line. And it's a sad, tragic thing that we have laws that allow that with no restrictions. It's just, for me, it's horrific to think that.
Thank you. And I agree. And it seems that what's being proposed here is even worse than what already exists in law, but really bad. So thank you for your testimony and for coming today.
Well, thank you for the privilege of being able to testify.
Thank you, Madam Chair.
Thank you, Representative Zupkis. And just to note that those religious freedoms are protected in federal law. And the bill before us is not a bill to provide minor access to abortion care. That's something that's already in statute. This bill is specifically related to contraceptive care and pregnancy care.
Yeah, but it's denying the parents the right to be in charge. It's saying that a child, a minor child, who is not capable of making these decisions, can make those decisions, and the parent is not allowed to be notified. That just is beyond my ability to understand why anybody would ever think that that was good.
Thank you, Mr. Saris. Representative Zupkis, did you have a further comment? And then Representative Dauphiné.
Thank you. Just to, I think to your comment talking about it being banned federally, right? So is marijuana. And there are things that are banned federally that this state passes anyway. So discussion for another day, but I have seen in this state that this body, even though something is banned federally, tends to make our own laws. So, but thank you, Madam Chair.
Thank you very much. Representative Dauphiné.
Thank you, Madam Chair, and thank you for coming today to testify. And just a quick spinoff of what Representative Zupkis said about federally making, well, our state making things quote unquote legal here, even though they're illegal and federally, that doesn't change the law. The law still says they're illegal. So if a federal agent were here in the state of Connecticut and saw somebody participating in marijuana, they could be arrested because it is federally illegal. So we cannot make it legal. We can take the prohibition off of it, but we can't make it legal. Oh, I'm sorry. Hold on, just. Okay.
I think we lost Representative Duffy for just a moment. Okay, she's.
Sorry, I'm so sorry.
Okay, Representative Dauphiné, are you good to proceed?
I am. I apologize.
Go ahead.
Somebody was at my door. I just wanted to if you could weigh in on, I know you said you had 5 children, and I'm assuming they're adults now, but could you just weigh in on any one of those children making one of those life choices as a minor, and how just looking back, if they would have been capable of making that kind of decision responsibly?
One of the things that I cut out of my little talk, I remember back when I was a child. And at one point, now I'm 76, so I'm old. But I remember when Superman was a big television program. As a child, a minor child, I thought, I'm going to be Superman. And so I went to the linen closet of my house. I got a towel. I stapled it to my shoulders. And I decided I'm going to fly, because obviously the reason he can fly is because he has a cape. And so I decided I would go up to the top of my garage and jump off from there. And then I realized, maybe I ought to try it a little bit lower than that. So I went to my porch and I jumped off, and I was not Superman. That's the kind of thing that happens when you have children. They're minors. They don't have that fully developed brain. Earlier in this afternoon, or maybe morning, I'm not sure, whatever it was. I guess it was afternoon because it started at 11:30. But someone mentioned that 20, maybe even you, Representative Dauphiné, that 25 years old is when the brain really fully develops. And so we're talking about major decisions, not just minor decisions, major decisions by people with undeveloped brains, people that are not able to make that kind of a decision. And without the parents' knowledge, without the parents' consent, and if it's something that needs to be taken to a court to be able to say, no, we have an abusive parent, that's fine. Go to the court and get some kind of a court order. But to make this as a law that says you do not need to get consent from the parents is foolhardy. It's beyond foolishness.
Thank you. Thank you for your testimony. And I apologize for the interruption of my dog, my protected dog. Thank you.
Thank you, Representative Dauphiné. We all certainly understand. Representative Clara DeStitria.
Thank you, Madam Chair. Thank you for being here today and sharing your life experiences. My question to you, and I've said this before, in a perfect world, and not even perfect because everything is imperfect. You have your 5 kids, you were able to be there, do everything that a parent should do while they were minors. And you made that decision for them. But what about the children that aren't as fortunate to have a family like yours, that maybe have drug dependent parents, or they're in abusive relationships and they need a place to go to get help, to get advice, and they may not have another family member or an uncle or even a neighbor, which again, we would love for that to happen. You don't see that this could help children that are in a really difficult situation get some advice and some help as to what they need to do, even though they know they can't go to their parents for fear of being hurt or something worse?
That's a hypothetical situation that I'm not sure really exists as much as people think it exists. As I said just a minute ago, if there's a real concern that you've got a child who's in the home of abusive parents or whatever, you go to the officials, you can go to the police. Just say, hey, I'm reporting that I've got some parents that are not doing it right. You can go to a school teacher or whatever, and they can go before a court of law. And if they necessarily need to do that, then what would they do? They get some kind of an injunction against it. But to make it a blatant statement that any person can get this information at the request of a minor child who is not capable of making that decision without, that's what blows my mind. I mean, the fact that you actually put this as a statute that says any minor child can go to somebody and say, I just want to have this kind of activity done on my body, and you don't even let the parents know, even if they do have really good parents.
All right, I appreciate you being here and giving us your opinion. Thank you.
And by the way,
Thank you, Madam Chair.
I have older children,
Thank you.
obviously, who are, they make decisions different than I did. I mean, I made some major decisions. They chose to make some other ones, and they have the right to make those decisions.
Thank you, Representative Claridge Teacher and Mr. Saris. Thank you very much for being here with us today.
And
We
thank you very
appreciate it.
much for listening, and God bless you all.
Thank you. God bless you too. Next, we have Tia Woods, who's joining us online. Ms. Woods, welcome.
Hi, can you hear me?
Yes, we can.
As a single teenage mother of 5 children ranging from the ages of 35 to 17, with their professions being Army vets, police officer, correction officer, business owner, licensed massage therapist, holistic guru, I have a full-time college student, maintaining a full-time job, being on the dean's list, and I have high school seniors. In having many ups and downs while raising them, I must say that I have earned a right to call myself a great parent. Not always perfect, living under the circumstances in which I have come, but I stand in this title. Now, I can sit here and talk to you about why parents like me should not have their rights taken away when it comes to raising our children in regards to being notified of life-threatening occurrences, because this is what pregnancy and pregnancy prevention is. A life-threatening occurrence. Now, I've spoken with some state reps, senators, doctors, student health-based officials regarding this matter, and it boggles my mind in some of the responses that I've gotten. Now, some are empathetic and saying, I feel you, and I don't agree with this, but this is my job. And they carry on as if injecting a child with Depo is like getting a choice of deciding what flavor ice cream to eat. My daughter was 14 when the opportunity for her to discuss these things with me were taken away when the school system injected her with Depo. Most children nowadays, if you say that they can do adult things and not tell their parents, they would go along with it. You stole that opportunity from me to give her good, solid advice. You snuck in like a thief in the night and took it with a smile and no remorse. Minor children under 18 cannot vote, they can't drink, they can't own guns, they can't smoke, but they can murder people in the name of this country. And I can say that because I have vets. However, when they even finish that job, they still can't vote if they're under 21, drink, smoke. I am baffled to understand how a minor child is capable of making life decisions like pregnancy and pregnancy prevention. And can one please, please help me with this? My heart was hurting a couple of years ago when I found that this bill was in place. It has been told to me that this bill protects children from abusive parents. I respect that. I get some parents are neglectful, abuseful, so many other terrible things, and I want to do everything possible to protect those children. However, with this bill, are you really protecting those children, or are you separating families by coming in and setting policies that empower children that still need to be told to clean their rooms, take a shower, clean the bath, take out the trash, and they can't even file a tax return? You know, your basic stuff. Children graduate from high school still not knowing how to balance a checkbook, fill out a basic job application, but you actually are trying to convince me that they have the capacity to make decisions about pregnancy. Now let's talk about counseling services. This is the same country that didn't want people who look like me to be here, the same country that enslaved people like me, the same country that had Tuskegee experiments. Pause on that. The same country that Jim Crow took place, in which formally instituted in the 1890s, but was happening many years before that. It ended in the 50s and 60s with civil rights movement came in. Now think about it.
Excuse me, Ms. Woods, but
Yes.
you've reached your 3 minutes. Thank
Okay. You're welcome.
Ms. Woods, do you want to just summarize for us?
I just wanted some, I'm hurt. My soul hurts. And I have a part of a solution because I know we can come to y'all with a lot of problems, but really no solutions. And this is the only thing that I can think of, right? Because I feel like I'm a great parent, not a perfect parent. So the only thing that I can think of, and it might be off the wall, but you know how we get pulled over when we're speeding or running a traffic ticket or running a stop sign or something, and the police in like 2 minutes or however long, they can know so much about you just by running your name. All right. And we all probably have been pulled over. So the thought process that came to my mind in giving us good parents a chance, why don't, when a child comes to you, because I understand those children need to be protected. Okay. So why, when a child comes to you with these issues, why can't you just pull our names? And I know that's not end all be all because there's some parents out there who's never had a problem with DCF, don't have a felony. That's not end all be all, but that at least gives us the opportunity for us good parents who want to be involved in our children's life to have an opportunity to have some say so. I mean, there has to be a way. I'm not saying take the bill away, but there has to be some type of tweak or something to be able to put us in back in charge of our children's lives.
Thank you. Thank you so much for your testimony and for you. I believe you were here earlier and for staying online with us.
I was. I had to
Thank
come to
you.
work.
Yes, thank you for doing that juggle. Senator Anwar.
Thank you, Tia. Thank you. Good to see you in
you,
person
Senator.
today and also good to see
Yes.
you on Zoom. Thank you for being here and trying to be in person, but we appreciate your testimony. And I agree with you. You're an amazing parent. I'm fortunate to have interacted with some of your children, and you've been an amazing parent. Uh, could you expand a little bit about the solution that you were exploring further? In other words, you want the parents to have some opportunity in some situation, and help me understand that, what your thoughts were.
Well, in my situation, my daughter went to the school-based health center and she had problems with her period, and I don't even know how it all got to be this, but they injected her with Depo, not even giving a condom, but really injecting her. So my thought process is when she comes to you, instead of just trying to persuade her to come talk to me or whatever the conversation might have been, you have access to almost everything, right? You can run my name, Tia L. Woods. You can actually run my name, see what's going on in my household. I mean, technology is amazing nowadays. And if I have things going on with me that you can see, or maybe you can talk to some teachers, I'm not really sure, but to me, that's part of a solution to try and get into the household instead of believing what a 14 or 13-year-old says off the rip. Like, give us an opportunity. So that was my thought process, just literally running our names and kind of see it. And I know that's not end all be all because the system is definitely flawed. You can have stuff in there that's not accurate, but at least that's a way to try instead of just saying, okay, little Sally, we're going to believe what you say, and here's an injection.
Thank you. This is helpful. I appreciate your testimony, and I'm going to have a conversation offline with you in more depth. Thank you, Tia, again for your testimony.
Thank you, Senator. Appreciate you.
Of course. Back to you, Madam Co-Chair.
Thank you very much, Senator Anwar. Ms. Woods, seeing and hearing no other questions, thank you for your time today. And we'll go next to Heather Dawson, also joining us online. Welcome.
Thank you. My name is Heather Dawson. I'm the president of the Connecticut Association for School-Based Health Centers, which is a statewide nonprofit organization that supports over 300 school-based health centers. I'm here to testify on Raise Bill 7213, an act concerning access to reproductive health care. CASBAC fully supports the Raise Bill 7213 to ensure that the legal language surrounding reproductive health care for adolescents is clarified in accordance with current practice. This bill is not to question the rights of minor reproductive health care, but to clarify already established law to help support the current standards of care. These laws are in effect to protect adolescents, not to isolate anyone. This extends to not only the service, but clarification on billing practices that could conflict with established adolescent privacy rules. Medical providers who care for Connecticut's adolescents deserve to have legal clarification when it comes to providing health care. It is vital to have laws that support our providers who can in turn continue to provide much needed access and quality health care to the adolescent population. School-based health centers give adolescents the opportunity to be drivers in their own healthcare. It is a critical need for adolescents to receive access, education, and services in a safe environment with reliable, trustworthy providers. School-based health centers are often a trusted source of information for these critical preventive services and often provide counseling to reduce risky behaviors for Connecticut's young people. We want to encourage our providers to continue providing reproductive services and not hinder or question the legality of what they are currently doing. CASBEC supports this bill, equitable access to care, and our medical providers who provide care to adolescents. Thank you for your support of school-based health centers.
Thank you very much for your testimony. So you serve as the president of the Connecticut Association of the School-Based Health Centers. Is that correct, Ms. Dawson?
Yes.
Okay. And in that role, you serve in a particular health center and work to coordinate, or can you tell us a little bit more about your role?
So in my role here as the president of the association, it's a nonprofit organization that kind of supports school-based health centers throughout and advocates for school-based health centers throughout the state of Connecticut.
Thank you. So one of the things, well, let me ask you this. Have you been able to listen into testimony today?
I have, yes.
Okay. So earlier in the conversation, we were talking about whether or not there have been issues. And my understanding is that some of our school-based health centers have been hesitant in terms of providing contraception or pregnancy care because we don't have the same kind of explicit language that we do for some of our other provisions. And I wanted to know if you could just talk to us a little bit about that. There may be some further specific questions related to that, but if you can share that perspective, it would be great.
I think the way the current statutes state, it's not definitive. And I think what we're hoping is that we are able to have language that allows us to be able to continue to provide this, and instead of being open to interpretation. So just to support our providers and school-based health centers and beyond who are providing this care, which is already the standard of care.
So you're looking for certainty.
Yes.
So I think one of the questions is, have there been issues at some of the school-based health centers that would lead to supporting this?
I don't think that there's been, not that I'm aware, put it this way, not that I'm aware of there is issues at school-based health centers, but I know that, people just want clarification in how we practice, and being able to have the support from the law to help establish our practice.
Okay, thank you. Representative Mara. Oh, I'm sorry, Senator Almore, to be followed by Representative Mara, to be followed by Representative Zupkis. Senator Almore.
Thank you so much, Madam Co-Chair. Ms. Dawson, thank you for your testimony. I just wanted to explore with you a little bit. We just heard the testimony of Ms. Woods and perhaps some of the others. While even today, theoretically, a minor can go to a healthcare facility and ask for contraception, and they would be able to get this. This bill is going to make that even more firm and clear. But having said that, the process, the consent process, is encouraging the minor to have a communication with the parent or the guardian or trusted adult. And you probably heard in the tone of a mother and perhaps other parents who have spoken, and they feel that they lost that opportunity of a very critical time when they could have had the conversation. And arguably, the children are getting younger and younger before they have these conversations. So the mindset of a parent may not have been ready, and they were thinking it's going to be at 15, 16, or 17, it's happening at 12, right? Because of whatever reasons. That opportunity is lost, and that leads to pain for the parents. I'm wondering, how does one explore this beyond the legalities? How does one explore this on the human level to make sure that as long as the child is safe and guide them through it, it's not like writing a prescription and okay, next kind of a thing. So I want to bring this to the human level of the opportunities that are potentially lost. And can you help, and are you a clinician by the way, or not?
I am, yes, I'm a nurse
Okay,
practitioner.
perfect. Then that would be a good perspective to look at it from a conversation perspective. Thank you.
So I would say that I don't think that anyone takes any of this lightly. And we always, our goal is to provide access, not to isolate parents. So obviously the conversation is, we want them to go back to their parents and have these conversations with them. Sometimes, unfortunately, students will disclose to us that they've done risky behaviors, they've been sexually active, they've done that before they've told their parents. And I think our goal is to be a trusted place for them while encouraging their parents, communication with their parents. But a lot of times, for whatever reason, they're not comfortable doing that quite yet. I think one of the things that we do well in school-based health centers, sometimes we're able to give the students language, they're nervous about telling their parents, like, oh, hey, maybe if you say this, or if you approach it this way. I think we do a lot of counseling that way so that they are comfortable and they can start that initial conversation, because that's a big thing for a younger, teen to be able to say. But I don't think we're just handing out birth control or any of that stuff just, freely without having, in-depth conversations and in-depth counseling with them regarding some of these choices.
Thank you for that answer. So there's so much more conversation around this topic that one has to have. So if there's just not about pregnancy prevention, there's sexually transmitted disease prevention. There's also about risk of abuse. There's so many aspects to this conversation. What kind of training and discussions are there in a school-based healthcare center currently and hopefully in future to make sure that there is a comprehensive strategy about addressing the things that could go wrong, but also recognizing that there could be parts of the family history that would be relevant for that child if they're getting any medications, especially hormonal treatments and so on.
So I think there's so I know we're talking about specifically school-based health center, but any medical office that's out there that are providing services, we do have access to a lot of electronic medical records that provide information. We can do a deep dive into some of the electronic records about some of the history of the student. A lot of times our students, are for school-based health center, it's an opt-in enrollment. So parents have already filled out health history. So we have that information available to us. If there's any question or is something contraindicated or whatnot, we would not just go ahead and prescribe without some clarification. So I think that there's a lot of opportunity to get more information out there. As far as training, I would say just like any other medical provider that's out there, we do train with, a lot of school-based health centers. We do health risk assessments, meaning, they ask all the general questions that you would need, based on their histories. So we do a lot of work towards this and making sure that we have a full picture before any decisions would be made.
Thank you. I just want to make a quick little statement. I think the concern many of the people, not everyone, many of the people around the Public Health Committee would be that when a child asks for contraception, they should be able to get it. But they should have an opportunity, more than ample opportunity to understand what it means, but also if they were to get pregnant, they should get all the treatments relevant to that pregnancy, including pain control and the top-notch care for the prenatal care as well. But while they're looking at the contraception options, they should have a much more in-depth conversation with the clinician to the point that they are strongly encouraged to have a conversation with the family member, unless there's a danger, physical danger or beyond to that individual, so that the family is part of that conversation. That's the moral part of how I see it, but the legal part is there to have a prevention because they're not straight line in many cases, and we want to prevent some of the things from happening. So that's how I feel it would be worthwhile. We want every child to get the care that they would need, but also have involvement of the parents as well. But that's something that we should figure out how we clinically manage those situations. That's important to keep in mind. So I'll give it back to my co-chair, and then she'll have questions that she can answer.
Thank you very much, Senator. Just a follow-up. Actually, I'll let Representative Mara go, and then Rep. Subkis, I have a follow-up from that. Rep. Mara.
Thank you so much, Madam Chair. Thank you for coming in and testifying today. It really does make me feel good to hear your thoughtful response when talking about how you speak to kids come in and you helping them have those conversations at home. I think that's really important, and I think you offer such a good perspective there. And I do truly believe that that's kind of the same that if someone went into Planned Parenthood that they would get as well, because you have this group of people that are very much trained around this. So my first question to you is, do you think that there needs to be some sort of training around how to talk to kids, how to counsel kids to open up to their families and bring their families into the conversation? Did we lose you?
Yep, I'm there. Sorry. I always think as far as, more training is never a bad thing, right? Like, it's always a good idea to be like how to foster great communication and things like that. I do think that we get a lot of it just because our model is, we are with other mental health clinicians. And so I think we get in the school-based health centers, particularly our medical team is able to really kind of get involved in a lot of the mental health trainings just because we all work so closely together. So I would never say that training is a bad thing or anything like that. I would support that. I just feel, but again, I do think we do get a lot of that kind of just the nature of where we are.
Yes, I would agree. One of the reasons why I bring this up is because when I looked through the testimony and I did see there was testimony from, and I realized it was probably a very young doctor that had testified and maybe a resident. And their quote is that this child was coerced to, and I can't remember whether it was either to have the baby or to get an abortion. I'm not sure what it was, but I just find that language maybe not very sympathetic to what the conversations were behind the scenes, and not very, I think that leads to, a bad back and forth between families and then caregivers. So I think more training around that maybe could be something we could really address here. The other issue, I do believe there shouldn't be barriers to contraceptives. And, I try to say that every time I come out because I want people to understand where I'm coming from. However, this bill, I think, seems a little bit more than probably what it needs to be. To me, it should be a one-liner in there to allow oral contraceptives for minors. And this goes on quite a bit. And matter of fact, it actually repeals, it repeals a regulation. Do you have any thoughts on that?
I don't think I've done enough. I mean, I've heard the testimonies today. I don't think I've done enough research to really have a strong, a well-informed opinion on that right now. What we're really focusing on was the access to the reproductive health care, pregnancy testing and contraception.
Okay, fair enough. And so the particular regulation that I'm speaking of actually has informed consent on it. I've been told that it's possibly in other parts of our statute, but do you think that that piece should go away?
Again, I don't want to take a strong stance without being able to do a little bit more research on my own.
Okay, nope, fair enough. I appreciate it. The other concerns that we have is when we look at bills like this and they come out of committees, they look one way, and you probably heard me talk about this otherwise, but I really like to get a feel of people that are supporting this bill, where they really want to see this go. Because if someone's like, yes, I really want to see that this continues access to oral contraceptives for some of our minors, then that's one thing. But if the point of this bill is eventually going to be a vessel for something further, then that concerns me. So the next regulation that I've heard people have wanted to repeal in the past is section 19-13D54. And it has 3 particular sections in it that I just want to get your opinion about. One of them would be repealing that no person should be required to participate in any phase of an abortion that violates his or her judgment, philosophical, moral, or religious beliefs. Is that something you want to repeal? And it's okay if you don't have an opinion. I just want to.
Yeah, I just don't have an opinion right now. To have to, as an organization, we'd have to go back and talk about that.
Okay. The second one is if the newborn shows signs of life following an abortion, those measures used to support life in a premature infant shall be employed. Do you want to repeal that?
Again, I would just go back to my previous statement.
Okay. And then the last one would be during the 3rd trimester of pregnancy, abortions may be performed only when necessary to preserve the life or health of the expectant mother.
I'd have to, again, go back to my organization to get a full scope.
Okay. And if you could do that, I would appreciate it, because I think these are very important pieces of this regulation. And I would, as much as I am in support, I would be horrified if these 3 things were repealed. Absolutely horrified. So I just want to know where this bill is going, what track it's taking, because I would love to get behind it, but I need to know where we're going to take this. Thank you, Madam Chair.
Thank you very much, Representative Mara. Representative Zupkis.
Thank you, Madam Chair. Thank you for coming and testifying today. So your school health-based centers do give out contraceptive to kids, correct?
Some of them do.
Okay. So if you, and I'm just asking, excuse me, for clarity. So if you're in a certain area and you go to one, you might get contraceptives, but if you go in another area and you go to your place, you might not. Is that correct, what you're saying?
I think it's just, there's some organizational decisions that are made on that level. Yeah.
Oh, okay. So what would happen if a minor came to you, a child, and they were pregnant? Do you recommend them to go somewhere? Do you deal with what's your process for that?
So I think obviously we want them to go into prenatal care. So it would be kind of working with them, depending on where they are and figuring out what the next step would be.
I'm not sure what that means, but does that mean you would recommend them to go to their doctor? I love the fact that you talk to them and encourage them to talk to parents. I think especially in schools, I sit on the education committee, and a lot of the problems are parents and being disconnected. And also I think we need to bridge that gap for parents and kids versus separating it more. But do you say, okay, you're pregnant, so go to the hospital, go to Planned Parenthood, go to here, like kind of what are your next steps? Or you listen to them as to where they want to go?
I mean, we would recommend that they would have to obviously get further care outside of the school-based health center, because that's not the kind of care that we provide. So that could be their doctor, it could be Planned Parenthood, it could be, I mean, I guess if they want to go to the hospital, they could. I don't know if that would be the first step, but it would be establishing a connection with, whoever their care provider is.
Right. Do y'all recommend like faith-based pregnancy centers also? Do you give them an array of options, or is it just here's kind of your 2 options?
Again, I think there's some organizational preferences, so I don't want to say every school-based health center does things one way, but I like to think that we give them an array of options.
Okay, well, thank you for that. And Representative Myra asked the questions I was going to ask about the repeal sections. And I would just say for everyone that's testifying, when people come to support a bill or not support a bill, there's a lot to bills. And it's always not just one piece. And even as legislators and us sitting here, we have to really look at what's going to be, what is this path going to be forward? What's it going to look like? So I would encourage you and would like, as Representative Marrow, your feedback on the other sections of this bill. So if you would please do that, you could submit it to the clerk. She'll share it with us. But I would like your feedback on some of those because some of them are really horrible. I would say if a baby's born and breathing and you choose to kill it, that's a whole nother issue. But so I would appreciate, your thoughts on that because I'm sure you do deal with children and we're grateful that you do and encourage them to talk to their parents. But this bill is much more than just that. So thank you. Thank you, Madam Chair.
Thank you, Representative Zupkis. Ms. Dawson, do school-based health care centers provide abortion services?
No, not that I'm aware of.
Subject to regulation of abortion care at school-based health care centers?
I'm sorry, excuse me?
You do not provide abortion services at school-based healthcare clinics, is what you said, correct?
Correct.
So as a result, you're not subject to the regulations in question in this bill. Is that correct?
Correct.
Okay, thank you.
Thank you.
Are there any other questions or comments? Thank you, Ms. Dawson, for being here with us today. Next is Megan Scher, who I believe is here with us in person. Welcome.
Not moving. Hello, good evening, chairs and members of the Public Health Committee. My name is Megan Scher, and I'm a resident of Hartford. I am the Policy Advocacy Manager at the Hispanic Health Council, and I'm also a student and getting my master's in social work at UConn School of Social Work and Policy. And I am testifying in support of HB 7214, an act concerning maternal health. HB 7214, as we've heard, aims to tackle racial disparities in maternal health care. The Hispanic Health Council is the largest Latino service provider in the state of Connecticut. Our mission is to promote equity and address health disparities for Hispanics, Latinos, and other vulnerable communities through research, advocacy, and culturally resonant services. One area we see significant health disparities is in maternal health. Unfortunately, many women of color face higher health risks during childbirth. And 7214 establishes the Connecticut Maternal Health Report Card, a system designed to assess and publicly report on maternity care at hospitals and birthing facilities. This data will be made public, assist hospitals in addressing inequities, improve transparency, and ensure high-quality maternity care in our state. Our maternal health services providers at the council go above and beyond to ensure Latina women have the resources they need to feel comfortable and safe during the birthing experience. They are able to provide services in the client's language and culture, which has made a significant difference in our client's birthing experience. Women feel safer and able to give birth free of trauma. Our services help because they recognize the discrimination that women of color face in the healthcare system and ensure they do not become another statistic. The truth is, though, the Hispanic Health Council is one organization. We are unable to work with every single woman who will give birth as much as we strive to, and women end up going to hospitals and service providers who do not recognize the impact discrimination has during the birthing experience. This leads to women of color either having incredibly traumatic birthing experiences or worse, dying. We need to begin to hold our hospitals and healthcare providers accountable so that every single woman can give birth free of trauma. We need to investigate hospitals and freestanding birth centers and work with these centers and hospitals to eliminate discriminatory practices so their patients feel safe giving birth. It is 2025 and the US has the highest maternal mortality rate among high-income countries, and the maternal mortality rate for Black women has remained over 2.5 times higher than the rate for white women. How is this fair? Connecticut needs to step up and be a leader in the United States on maternal health advocacy for women of color. I want to urge the committee to vote in support of HB 7214, an act concerning maternal health, so that Connecticut can work to decrease the maternal mortality rate that impacts too many women of color. Together, we can ensure mothers of color can thrive in Connecticut and give their children the life they deserve. Thank you for your time and listening to testimonies.
Thank you very much, Megan, for your being here with us today, for your testimony and for all the advocacy that you've done. I know you've done a lot of work to bring many people together and many stakeholders to the table. I believe there are a couple of people who may want to speak, Senator Elmore, and then Rep. Supkis.
Thank you so much, Megan, for your testimony and the conversations we have had offline multiple times about your passion and about your vision and the work that the entire Hispanic Health Council is doing. So this is important work you're doing. I wanted to thank you and being with us morning, afternoon, and now evening.
Thank you.
Thank you. Back to you, Madam Chair.
Thank you, Representative Supkis.
Thank you, Madam Chair. Thank you for coming, and your passion comes through for the people that you serve. So thank you for doing that. In this bill, you mentioned women and mothers. In this bill, it says birthing parent, and it says Black birthing people. To me, that sounds insulting. How do you feel about that?
I respectfully, I disagree. I think that we can't put a gender these terms. I know historically we have used women to talk about birthing, but birthing comes in all different experiences. Some people don't identify with a gender, other people are part of the trans community. And I think it's more respectful to make it more inclusive because birth is now, as we have grown as a country, birthing is different for everyone with different identities. And I think we need to respect how people identify. And I agree with that language. I actually would probably correct my own language in
I was
this.
just going to say, maybe you need to change your language because you said women and mothers and mom. So that's not in this language.
But yes, I respectfully, I would correct my own language. And I don't agree with how I actually wrote this. I do work on many, many different policies. So sometimes I write my testimony quite fast, but I do believe birthing people is the correct term to use.
Okay, thank you.
Thank you, Rep. Supkis. Seeing and hearing no other questions, thank you very much for being here with us today. And we look forward to further work with you on this policy issue. Next is Kathy Flaherty, who's here with us in person.
Welcome. Thank you for being with us all day and morning, day, afternoon, and evening.
Yes, and I've got green on, so,
Yes.
but I hopefully won't need more than the 3 minutes. Senator Anwar, Representative McCarthy Vahey, members of the Public Health Committee, my written testimony says good afternoon, but at this point it is good evening. My name is Kathy Flaherty, and I'm the Executive Director of Connecticut Legal Rights Project, and we're a statewide nonprofit that provides legal services to DMHAS clients. We represent clients at Connecticut Valley Hospital as well as at Whiting Forensic Hospital, Capital Region, Connecticut Mental Health Center, and Greater Bridgeport Mental Health Center. And I'm here to offer testimony about Senate Bill 1509, an act concerning patient protections and standards of care at Connecticut Valley Hospital. And when I saw the bill as written, one of the first things I did was look up the EQMI statistics for Connecticut Valley Hospital. And in the general psych division, it reveals that 64% of the clients identify as male, 35% female, and 1% transgender. And in order to comply with the prescriptive language in this bill as written, DMHAS would have to move a lot of people around to establish units that segregated people by biological sex. And some patients may have a good relationship with their clinicians and their providers and not want to move to a different unit. And I don't think that the legislature should get involved in telling the hospital how to organize itself. Requiring that people be separated by biological sex could potentially result in less access to services by people who need inpatient level of care. The general psychiatry division at Connecticut Valley Hospital does have one unit that houses all male patients, but every other unit houses patients of all genders. And if these were required to be segregated, there would be more units for men than there would be for women, and thus creating a longer potential wait for space for half of the population that DMHAS serves. People who receive services from DMHAS are entitled to humane and dignified treatment, which includes respect for their gender identity. Gender identity is a protected class under state law. DMHAS has instituted a policy respecting the rights of transgender persons in compliance with those state civil rights protections. I think this bill as written would represent a step backwards from acknowledging the humanity and dignity of all people. And in our years of advocacy at CLRP, we've rarely received complaints about the mixed gender units. Although I do want to add that one can't ignore or discount that there might be benefits in creating a specialized unit open to those who've experienced significant trauma and for which admission is limited to those of one sex. But there's a very significant difference between the hospital choosing to create such a unit based on the clinical needs of the people it serves and the legislature prescribing that happen at all times. People should have equal access to treatment at each level of care. And this bill, as written, could hinder that objective. So I urge the committee to take no further action on the bill.
Thank you so much for your testimony. Thank you for being with us. If my colleague was here who proposed this bill, there's a background for this, and you probably heard the background.
I did hear the background. That was the first time that I had heard that.
And I think that was the rationale for the bill to start a conversation. This is not the end of the bill. This is the start of a conversation to highlight an issue about how it's worthy for a facility taking care of people who are vulnerable and taking a person who has endured trauma and putting them in the same place where the person who perpetrated the trauma. And I can't even imagine what that person had endured when that happened. And that's why my colleague felt it was important to bring this bill forward to highlight that issue. And I respect some of the other components of the gender aspects, and I respect that part. But I think it was just to get it on the record that we can do better as a state for individuals who are, we use the word trauma informed all the time, but in action, sometimes we are not trauma informed. And to put a person who was physically and sexually abused by somebody in the same place by the abuser was not cool. And this bill is saying that can't do that, DMHAS or anybody else. And worthy to check in and do an advanced check. So, but I completely hear and understand the part, and I wanted to give you the background why this bill came to be protective of one of the individuals.
And I think making sure that people have a safe place to go that doesn't perpetrate harm against other individuals is really important. So I am pleased to hear that this is only the beginning of a conversation. I do think, though, as written, the bill is very problematic and could potentially cause other potential problems.
Noted. Rep. Mara.
Thank you, Mr. Chair. Thank you for your testimony today. You mentioned we have 1% transgender of the people that are being admitted, I think 67 and 30 something. So I guess I'm just curious what your thoughts are when you're talking about treating patients, how you prioritize the treatment of one patient over the feelings of another patient.
I'm not a clinician. I'm a lawyer representing clients. So that in terms of how you do that clinically, I'm not the expert on that.
Okay. Well, I'm not the expert either, but I would like to venture to say that when we talk about, protecting the feelings of maybe the one person that's transgender that needs to be moved into another facility, when we prioritize that over the treatment of someone that is there because of mental health and they're traumatized by maybe sexual assault, I think that's definitely a conversation that we need to respectfully have, that we don't prioritize one person's feelings over treatments of other people. So I hope that we continue to have this conversation. I absolutely think that we can all do it very respectfully and with our eyes wide open, but there's clearly some issues here and we need to address them. Thank you, Mr. Chair.
Seeing no other question, I just wanted to thank you again for your time, and I hear you loud and clear.
Okay, thank you.
Thank you. With that, we move to the next person who is probably here in person, Andrea Contreras. Andrea, welcome. Can you press the button in front of you? Good.
Okay, great. Thank you. Senator Anwar, Representative McCarthy Behahe, and distinguished members of the Public Health Committee. I'm Andrea Contreras. I'm a board eligible obstetrician and gynecologist. I'm currently doing my fellowship in complex family planning, and I'm also pursuing my master's in public health and completing my practicum with Reproductive Equity now. Thank you for the opportunity to testify in strong support of House Bill 7213 and Act concerning access to reproductive health care. This legislation will strengthen young people's ability to consent to contraceptive care and pregnancy-related care, aligning with state statute with the medical standard of care. Given recent stories that we've heard of how young people's inability to consent affects your ability to access adequate pain control in labor, lab draws, or contraceptive, it is imperative for Connecticut to create explicit language that aligns with the longstanding state interpretation of current legislation. By reiterating a young person's right to consent to care relating to contraception and pregnancy-related care, this bill would prevent unnecessary delays in the provision of evidence-based care, diagnosis, and treatment. There are many reasons why a young person might find themselves within the healthcare system and be unaccompanied by a parent or legal guardian. But regardless of that reason, some of which include the inability to take time off work, conflicting medical appointments, logistical barriers, or desire for confidentiality, the acuity of the necessary care is not determined by providers, by the patient, or legal guardians. Labor and delivery is a time in which patients may feel their most vulnerable and out of control, and it is standard of care to offer laboring mothers some form of anesthesia, and it is my responsibility as an obstetrician to support their decision and provide that care. As a person who has seen both medicated and unmedicated deliveries, I cannot ethically force a person to undergo an unmedicated birth, just as much as I cannot ethically force someone to undergo an epidural. Delivery is a highly individualized experience, and our duty as physicians and representatives of the people is to ensure the safety of our patients and respect their bodily autonomy, regardless of age. I would never feel comfortable, as should all providers, having my anesthesia colleagues perform an epidural in a minor if they have explicitly expressed opposition to it, even if their parents have given consent. Just as I would feel uncomfortable denying a young person pain control when they have asked for it when their parents are declining. Not one more is ethical than the other. In both situations, show blatant disregard for their bodily autonomy, and in both situations, the patient's assent or dissent should be prioritized. As we move on to their ability to consent and access contraception, it is important to acknowledge that this can be an uncomfortable topic of conversation for both young people and adults alike, and we must praise our young people for being excited about adolescent health and medicine. Assured confidentiality means young people are more likely to disclose sensitive information, access, and obtain the care that they need. Currently,
Excuse me, Dr. Contreras, but you've reached your 3 minutes. Thank you.
Thanks.
Actually, if you want to finish your sentence, you're welcome to do so.
I just strongly urge the Public Health Committee to support House Bill 7213. Thank you.
Thank you so much for your testimony. So you heard a lot of the conversation. You heard about us saying that there should be an opportunity for the minor to be able to have a conversation as long as it's safe.
Correct.
Do you think we can do a better job in training the clinicians to do that and maybe spend a little bit more time around that arena?
I think there is a place for education and training for clinicians, for minors, as well as for parents on how to approach these topics of conversation.
And currently, do we do a good enough job, you think?
I am not very familiar with the sex ed in Connecticut, but as in my personal experience as a Texas resident, it is not.
You're a Texas resident?
I am from Texas. Mhm.
I missed that. Welcome.
Thanks.
I'm so glad you're here.
Me too.
Seeing no other questions, I could have asked you about Texas, but I think we have a lot of other things to do here. So
yeah.
I hope it's warm there. Seeing no other questions, I appreciate you being here. Welcome.
Thank you.
Thank you. Next is a person online, Tunisia Singor. Welcome. You're on.
Hi, everybody. Thanks for having me. Good evening, Senator Anwar, Representative McCarthy-Vahey, and esteemed members of the committee. My name's Tanisha Signor. I'm the Policy Director at She Leads Justice. We're formerly known as 12, and we're a statewide nonprofit that advocates for under-resourced and marginalized women and girls in the state. Today, I wanted to testify in support of HB 7213 and HB 7214. In regard to HB 7213, we believe that it will bring Connecticut statutes in line with the medical standard of care and allow young people to consent to contraceptive and pregnancy-related care. We already have numerous statutes which allow minors to consent to things like treatment regarding sexually transmitted diseases, abortion, mental health, and substance use counseling. We also allow minors who have children to consent to the medical, dental, hospital, and healthcare of their children. We consider ourselves a leader in reproductive healthcare and access, and accomplishing this status requires us to institute legislation which expands and safeguards all of our individuals' ability to access contraceptive and pregnancy-related care. It is critical that we connect young people with information, resources, and support regarding their health. Ensuring confidentiality is a critical component of that work. There is nothing in this bill that would prevent young people from disclosing their care or decisions or pregnancy status with their parents or guardians. However, it does safeguard confidentiality for those who do not have family situations which foster understanding, acceptance, and honest communication. Concerns for their confidentiality is the leading reason for young people refusing to seek out necessary medical care. As far as HB 7214, we stand in coalition with the Hispanic Health Council in their fight to establish a hospital report card for hospitals and freestanding birth centers in Connecticut. The United States leads all other high-income nations in maternal mortality. However, Black women in the United States experience this reality in an overwhelming rate, over 2.5 times the rate of white women. Connecticut is not an exception to these rates. Although Black individuals represent only 13% of live births in our state, they account for 27% of pregnancy-associated deaths. We believe that these rates are unacceptable, embarrassing, and largely preventable. Maternal mortality rates are impacted by things like discrimination and bias, increased rates of cesarean sections, age disparities, insurance status, income, and more. We believe establishing this report card, sorry, that's my daughter's a little bit of a tea kettle. We believe establishing this report card is a critical step in our state to addressing healthcare crisis. When hospitals and freestanding birth centers report their findings, they can begin to reflect on their standards and collaborate to improve conditions and practices.
So
I'm going to mute
actually,
myself so you guys don't have to listen to her.
why don't we have questions for you, Tanisha, if you want to go take care of the immediate needs.
She's okay. No, she's okay. She's with her dad. She got mad because he
Dad is not in control.
maybe didn't let her. She might have not been able to chew on an electrical cord. She's been going after those lately. She's okay.
All right, good.
Go ahead. Sorry.
As Public Health Committee, we are relieved. So my co-chair has a question.
I just want to say, I don't feel relieved. I was never in doubt about what was happening there. And we love hearing the sound of your children in the background. So,
Oh yes,
thank you.
she's always there. My little tea kettle lately. That's the
Thank you
sound.
very much for taking the time to testify before us today. We appreciate it.
Thank you. We appreciate your testimony on both the bills, and I think we value your time, and we've taken note of this. Thank you.
Thank you.
No questions or comments, we'll move to the next person on our list who was here in person, Claire Circus. Welcome. Thank you for being with us today.
Alrighty. Hello, everybody. Senator Anwar, Representative McCarthy Vahey, and distinguished members of the Public Health Committee. My name is Claire Serkis. I grew up and currently live in Farmington. I'm also lucky enough to currently be a third-year medical student where I have the honor and privilege of learning to take care of patients. Before medical school, I also spent years working at a sexual and reproductive health clinic where I still volunteer to this day. I want to thank you for the opportunity to testify in strong support of HB 7213, an act concerning access to reproductive health care. This legislation will strengthen young people's ability to consent to contraceptive and pregnancy-related care. And I want to emphasize this, aligning the state statute with the medical standard of care. First, I'd like to share a couple of situations with you. A 16-year-old on labor and delivery, she has the support of her partner's parents. At the moment, her parents had to step out and take care of her younger siblings. The pain is becoming unbearable, and she wants an epidural. By Connecticut state statute, this patient's right to consent to pain relief measures while giving birth is not explicitly protected. There's a delay in getting consent from her parents, and she continues to labor in unimaginable pain. Once her child is born, she's able to consent to all of the care of her newborn, but is not able to consent to birth control for herself. Next situation, a 17-year-old who just moved to Connecticut for college. She becomes pregnant unexpectedly and decides that this is not the right time, place, or person. She plans to have an abortion, which she decides to do after having in-depth conversations with her mom, who is thousands of miles away. Under Connecticut state statute, she's able to consent to this procedure as someone under the age of 18. After her procedure, she decides that she wants an IUD, a very effective form of birth control, so she does not have to go through this experience again. By Connecticut state statute, this patient's right to consent for her own birth control is not explicitly protected. Next situation, a 15-year-old comes to a sexual and reproductive health clinic. She's recently become sexually active and wants to ensure she is utilizing safe sex practices. She confides in the clinic staff that she does not feel safe at home and that under no circumstance could she tell her parents about this. She is worried that they would kick her out as they've threatened to do before. Under Connecticut state statute, this patient's right to consent to contraceptive care is not explicitly protected. In my time as a medical assistant and as a medical student, I've seen variations of these situations many times. Selfishly, I would like to first talk about how much it pains me to see my patients suffer, to see them unable to get the care that they need due to unnecessary barriers. The truth is, if patients are old enough to become pregnant and give birth, they are old enough to be in control of deciding what kind of pain control they want during their labor process or anything else surrounding their birthing experience. If the patient is old enough to decide that they no longer want to be pregnant, they are old enough to consent to this birth control. And the reality is, and I know this to be true throughout my years as a medical assistant and now as a medical student, as clinicians and staff, we always encourage our younger patients to involve a parent or trusted adult in these decisions. Data tells us that the majority of young people voluntarily disclose these issues to a parent, and when they do not feel safe in doing so, disclose it to another trusted adult. In a perfect world, every young patient would have a trusted and supporting legal guardian to support them through every moment. But this is not our reality. Our reality leaves far too many of our patients stuck, unable to consent to contraceptive and pregnancy-related care in times of great need. This bill would look out for those patients and remove unnecessary and unsafe barriers to care for thousands of young people in this state, as is the standard of care by all relevant governing medical associations and governing bodies.
Excuse me, Ms. Sergis, but your 3 minutes is up. Thank you.
Thank you, Ms. Serkis. You just missed your 3-minute mark by a few seconds. But this was great testimony. Thank you for bringing true actual cases for us to look at and recognize the value of the bill. Do you feel that the bill, the way it's written right now, that would be able to address all the cases that you have highlighted?
I do.
Is it going to miss anyone? At least the ones that you've come across?
In my experience, this bill addresses a much needed need in the state to explicitly enforce their right to access this care. So I think the bill addresses those things.
So if let's say somebody says that this bill is not necessarily even needed, we are doing pretty good job, but your testimony suggests that there is a vacuum, there is a gap.
Yes.
And you have come across these cases yourself.
Yes.
Okay, this is very helpful because we've heard about these cases. We've talked to clinicians, other clinicians about these cases, and they are quite concerning. And we want to make sure that those aspects are corrected and addressed. So good. Anything else you would like to add? You've been here with us all day, so if you want to add anything else around this bill or the bills that you support.
Yeah, I just again want to thank you for the time to speak on this matter. And I think it's important that we consider the medical standards of care and also consider the partnership that exists between healthcare providers and families. You know, it's a really important aspect of the care that we provide. And also the critical nature of the autonomy of our patients. So I think this bill does an excellent job addressing those needs.
Thank you. Thank you for being here, and seeing no other questions. We'll move to the next person on our list. I appreciate you. Next person is Juan. I do not see Juan Fonseca Tapia. Oh, I thought you were going to be on the computer online. You have your computer. I love it. Yeah. Yes. Welcome, Juan. Mucho gusto. You're on.
Thank you. Chairs and members of the Public Health Committee, my name is Juan Fonseca Tapia, and I am a resident of Danbury, Connecticut. I am testifying in support of HB 7214, an act concerning maternal health. HB 7214 aims to tackle the racial disparities in maternal health care. Unfortunately, as many of you know, many women of color face higher health risks during childbirth. This bill establishes that Connecticut Maternal Health Report Card, a system designed to assess and publicly report on maternity care at hospitals and birth facilities. This data will be made public, assist hospitals in addressing inequities, improve transparency, and ensure high-quality maternity care in our state. The one thing that I want to share is I worked in an ICU for 4 years. I am a medical technician and I served in the Air Force for 9 years. I have many friends who worked in labor and delivery as nurses. And the one thing that they have shared with me is that they have seen constantly how is it that Black and brown women are treated differently, especially when they are expressing their needs to medical providers. In 2021, the state declared racism as a public health crisis. One of the things that I want to name is that Connecticut at times is really good at making changes, right, that are performative. I think that passing this law is connected to that declaration in 2021 of racism being a public health crisis. We know that racism shows in internalized or impersonal and interpersonal racism, institutional racism, and data continues to show us that Black and brown people, especially Black and brown women, experience lower rates of care when they are being treated. As I said, I saw this myself in an ICU. I saw when Black women and people of color asked for pain meds, and the way that physicians responded was different when white patients responded. So I encourage this committee to listen to the experts on this topic and pass this bill. I think that, as I said, the committee has the opportunity to ensure that HB 7214 is a way of taking action on that declaration of racism being a public health crisis in the state. Thank you.
Thank you so much for your testimony, Juan, and thank you for being here on computer and in person at the same time. Seeing no questions or comments, we appreciate you being here, and that brings us to the next person on our list, which is Iana Liles, doctor. I hope I pronounced your last name correctly. You can correct me if I'm inaccurate, but welcome. And thank you for being here with us in person.
All right, well, good evening, Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. My name is Dr. Iana Liles, and I'm a board-certified OBGYN physician in Connecticut for the last 10 years. And I am here requesting support for HB 7213 and HB 7214. I have submitted written testimony that goes into detail, but I'm here to publicly provide my support for one of the bills that I've been developing since 2019. And as you can see, I've provided care at OB hospitals in Hartford, Waterbury, and in New Haven. I'm a member of ACOG, and I'm a member of the Connecticut Maternal Mortality Review Committee. One of my goals as a physician is to encourage shared decision-making between the patient, their parent or guardian, and myself to optimize the minor patient's medical care and encourage safe, trusting relationships. But unfortunately, I've seen firsthand when that isn't the case. And in those situations, that's where confidential and autonomous care for the adolescent is important to encourage access. In my written testimony, I provided you 2 of the many patient encounters that I've had over the 10 years in Connecticut, where adolescent pregnant patients were denied care in pregnancy because they were a minor and their parent was either not present or refused care. The first case I want to highlight involves a patient I've named Stacy to protect her name. She was a 16-year-old Black pregnant person who came with her mom for induction of labor. And during her labor course, she requested an epidural and her mom said no. At one point, her mom even said, "You brought yourself into this mess and you will get yourself out of it." I went to her bedside personally and pleaded with the mom and tried to help Stacy, and the anesthesia team refused to provide her the epidural because of the state statute that they interpreted as the patient's parent had to consent. And this jeopardized her labor course, which also stalled her labor and put her at risk of having a maternal complication. After 4 hours, the patient's mom did consent for her to have an epidural, and she was able to have a safe and healthy delivery after progressing. The other case that I provided is a 17-year-old I named Rena to protect her identity, who was a 17-year-old Latina living with her 17-year-old boyfriend. I know my testimony says 117. Sorry, it is 17 years old. She was kicked out by her parent. Yeah, she was kicked out by her parents because she was pregnant, came in labor at 2 a.m., wanted an epidural, and we could not reach her parent. And even after I left my shift, they were finally able to get a hold of her parent to get her the epidural that she needed. These are 2 of the many encounters that I have personally had with patients who have not been able to get the care. This bill would clarify that so that people can get what they need, because as we see on labor and delivery, every minute matters. Also, this will allow minors to be able to consent to contraceptive counseling. I also take care of adolescents in my office, and I have the parents step out, and they're able to have the freedom to ask questions that they may not want to do in front of their parent. And while I encourage them to talk with their parents, I'm also there to provide them accurate medical and evidence-based care. As a member of the Connecticut Maternal Mortality Review Committee since 2019, I review the death of every pregnant person and postpartum person in our state and provide
Excuse me,
recommendations.
Dr. Lyles, but your 3 minutes is up. Thank you.
Thank you.
Dr. Lilas, I was waiting all day to hear you, so please finish your testimony.
Okay, thank you. It'll be very brief. So I help to review deaths to determine how they occur and to make recommendations so that we can improve the care patients have in our state. In my written testimony, I provided you our most recent report and recommendations from the committee. And you saw that 42% of deaths in Connecticut are due to mental health conditions, including substance use disorders. And we know that majority of these deaths are preventable. HB 7214 would align with a lot of our recommendations to develop the task force to look at perinatal mood disorders and to hopefully help decrease the number of pregnant and postpartum people who die in our state, improve access to doulas, and evaluate birthing centers throughout the state. We need to invest in protecting birthing and postpartum people at all stages, and this task force is a great step in that direction. And so for all those reasons, I respectfully ask you to consider supporting HB 7213 and HB 7214. Thank you for your time.
Thank you so much for your testimony. So I'll start with 7214. Right now, as a state, we are not doing good enough. We are better than most of the other states around, but compared to what Connecticut should be, we are not good enough. Help me understand what can we do better and in a policy arena, because this is a failed policy or lack of enough intervention and investment to see the results that we are seeing, that we are like a underdeveloped world with respect to Black and brown women's outcomes.
Yes, I think this bill helps to address one of those arenas. As a committee, we review all deaths and make recommendations on all levels. But given the high rate of people with mental health disorders and substance use disorders in our state, having a task force that's dedicated to perinatal mood disorders from prenatal care to postpartum care, I think is a great way to look at what additional recommendations we need in terms of counseling, in terms of treatment, in terms of outpatient facilities that the state is lacking. That's one place that we as a committee don't have access to. And so I think that this would be a great step. And then looking at the racial disparities and the health inequities, we do see that Black and brown people in our state also have a higher risk of death. And so looking at birthing centers, looking at doulas, because that is a great way to help decrease maternal complications in pregnancy and postpartum, is another great investment for our state. So I think this is a good stepping grounds as we continue to delve into this and to look at ways that we can improve with the great amount of resources we have in our state.
And we had a conversation with Access Health, and there was clear conversation that they just have 40 hours of clinicians available for support system. So the question is that enough, and do enough people know about that resource?
No, it's not enough. I think we know about the resources. We have a hotline that clinicians can even call. So the resources is out there, but there's also a shortage of clinicians. So investing in having more clinicians is another opportunity. But no, we need more people.
So within this bill, we are looking at areas of opportunity as well, and that would be one clear low-hanging fruit, if you will, to be able to address that and see what we can do there. So I think we will need a lot more help, because I look at this maternal health disparity in our state as a multi-session effort to start to put things on track, to change things where they are and not accept the status quo and the current direction. So we'll have to put the right amount of resources and also have a long-term strategy for that. I'll come back to the first bill that you supported, but I see one of my colleagues says, I'll take Senator Marks and then I'll take you. Is that okay? I have Senator Marks online, and then Representative Mara after that. Senator Marks, you're on.
Thank you, Mr. Chair. Thank you so much. Your testimony, it was wonderful. I've been charting all day. I'm a nurse, so I'm finally done with work and I can start participating in this. I've been listening though. So as far as the maternal health bill goes, do you have a little fear in you, as I do, with what is happening now at the federal level, that we're not going to be able to study or to address that there is actual disparity and inequity with women of color? And my second question to you with that is, I just always get a little frustrated at work and at everything, that I think the simplest way to start all of this is for staff to check their biases and to have truly safe conversations in rooms with coworkers about biases. And if that's not the very first thing we do, then I don't see how we're going to get really fix things moving forward. So those are two pretty heavy questions. So if you could just, offer a little insight if you think about this often as I do.
Yes, thank you for your comments. Yes, there's certainly fear. I think I don't let fear control what I do, though. It fuels me to continue the work. There are ways to use different language to accomplish the same goal. So yes, looking politically, federally, but Connecticut is a state that does what it needs to do for its citizens. And I would encourage anyone who has fear to remember that we are given the right as a state to choose what's best for the citizens in our state, and knowing that we still have a high rate of Black and brown people who don't get the same care as other people is a fact. It's in our MMRC report. And so I would hang on that and then still make the policies, because you can also help to change federal policies based on what they're seeing in the states and the progress that we're making. And I also agree with you that, yes, checking each person's implicit or unconscious bias is important for all of us to do. And that's something that, we as a MMRC have talked about. And certainly, I think it's in one of the recommendations, if I remember correctly. There's a lot in there. And so looking at policies that encourage all levels of healthcare, workers, not just nurses and doctors, but the people who interact with patients from the check-in to the food of not making judgments. And we shouldn't judge any person, but certainly be aware of what biases we have before we go in the room and constantly reevaluate who we are as people.
Yeah, thank you. Mr. Chair, may I ask one more question?
Please do.
Okay, thank you. So I'm the daughter of an OBGYN who was very progressive. I was holding a pink sign saying, don't take away my birth control from, I was age 10, I think, at my first rally. And very open family. And then my father started the sex education classes when I was in middle school, at my middle school. I think I still have a little scarred by all of that. But he was a pretty wonderful man. And when I needed birth control, though, I could not go to my father. I didn't care. I wasn't going to go to my father. My mother had died, and I couldn't get birth control back in those days. So I used the lovely sponge, which there's a great Seinfeld episode about the sponge, and it didn't work. And I got pregnant and I had an abortion, and I'm fine about that. I'll talk about it. No problem. I'm not, I don't feel any stigma. I made the absolute right decision for myself. But I think there's been a lot of talk on this, as I've been listening all day, thinking that it's only from bad families or not good families where people can't go to the parents to ask for birth control. And I think that is an awful stigma, because I think every family has their own different uniqueness about it, and they're all good families. What's good for one family is not good for another family. So just your 2 cents about that. I like saying my little story because I think it's important for everybody in leadership to say their story. This is a very large committee, and I think there's many, many people here that could give their own stories, and we don't have to just make it sound like it's always the poor or the people that have a parent that's, with substance abuse, that this kind of thing happens to. So it's not really a question, doctor, but it's just, I would love for you to really agree with me that it's all different families that this happens to.
Well, thank you for sharing your story. It's always important for us to share the story of a person because we're putting names to stories. We're putting faces to these people. And you're right. Like my patient, Stacy, she and her mom had a good relationship. I don't know all of the background because I met them on labor and delivery. And so you're right. Some of that is the biases that we carry into a room and assume on families. And so we don't know their family situation. We don't know the stresses that are going on, and we all have our own stresses. So I agree with you. It's not just poor people, rich people. I've encountered it in well-to-do families that just disagree with their parents. And I think that that's okay. My goal, again, is to provide evidence-based, accurate, and medical care to them as a trusted individual. And so meeting them at that level is what I try to do and what I would encourage anyone to do.
Thank you. Your patients are lucky they have you.
Thank you, Senator Marks. Your patients are lucky to have you too. Thank you, Senator Marks. With that, Representative Mara.
Thank you, Mr. Chair. Thank you so much for your testimony. I think you may be the second or third person that's come in and talked about pain relief during childbirth, and I think that's really shocking. So, is this an issue in all hospitals? And I'm curious, like, we haven't changed anything in the laws recently that I'm aware of that is a problem here. So why is this an issue now and it wasn't an issue before?
Oh, no, it wasn't. See, I've been in Connecticut for 10 years.
Okay.
I've seen it over 10 years. And so you're right. Legislation hasn't changed. It's just the interpretation by the people in the hospital that I'm questioning and asking for clarity. So you're right. It wasn't just something of 2025 or 24. I saw this. I joined Connecticut in 2014. So I've seen it from then up until now.
Okay. So, and just to clarify, you've seen that minors were denied pain relief.
Correct.
So I guess I'm really shocked that we're hearing about this now, because that's pretty awful.
Oh, no. See, like I said, I've been developing this bill since 2019. It's just a pandemic happened and we had a lot of other priorities to try to
Yeah.
keep the world from dying. So no, I really have been trying to sound the bell, and we finally had an opportunity to bring it up. But no, you're right. And I've seen it in several different hospitals. It wasn't just one. Again, I provided care up in the Hartford area mainly, so I've seen it up here the most. But I think some of the testimony from different clinicians across the state highlight that this wasn't just a regional issue, it is a statewide issue.
Okay, thank you so much. Thank you for highlighting that and bringing it forward. This bill is definitely something I want to get behind. I'm hoping, as I've said before, it doesn't change after it leaves committee into something that it is not at the present time, but I really appreciate your testimony. Thank you.
Thank you.
Rep. Zupkus.
Thank you, Mr. Chair. Thank you for coming, and thank you for serving Waterbury because they need you. Waterbury's in a little bit of trouble right now, so I hope you're spending more time there. I agree with Representative Mara about the pain. Like, to me, it is, whether I agree with everything else or not, in the moment and someone's in pain, they need to be relieved. So I do hope that this bill takes on something different than I'm hoping the path that it's not going down. But anyway, with that being said, I want to talk about the other bill. And you mentioned about women of color not getting the care. And I've heard it before, and I know you're telling the truth. My question is, when that happens, like, oh, I don't know. We had somebody here. When that happens, and maybe it would be you or not you, but doesn't someone go to the hospital? And I'm assuming this is in hospital. I don't know where this is happening. So if it's happening in a hospital, I used to work at a hospital. I would expect, or I would be the one right up to administration saying, this is a problem. This person is not getting the care, no matter what color they are. But if people are not getting the care that they are in the hospital to get, that's a problem. And to me, doctors take the Hippocratic oath. We have doctors in this room, and if there were doctors that are not doing what they are supposed to be doing to help someone, that's a major problem. So my question in all of that is, you seem pretty forward. Would you go to the administration of the hospital or to somebody and say, hey, this patient's not getting what they need?
I think it's a great question. So I'll answer your question, but I'll give you the benefit of being an MMRC. When we're talking about Black and brown people not getting care, it's not just at the hospital. So majority of the deaths in Connecticut actually happen postpartum. So they're out of the hospital. So it's not getting recommended for services by whomever. It's someone not following up. It's structural racism and discrimination. It's not just about explicit care in the hospital. It is just the whole system. To answer your question directly, sometimes when you're in the hospital, you don't see that the person didn't get the right care until afterwards when you go to review it. So we have the benefit of being a committee that now gets to review it and compare it to what we think the standard of care should have been. And so to answer your question, oh yeah, I have done that before. I have brought it up, and I do the fight when I can explicitly see it. But as someone who's been in the hospital that, you said you were, sometimes with the hustle and bustle and, you have a patient load of 15 people, unfortunately, you can't look at all 15 at the same time. But if you have the opportunity to sit there and realize something is wrong, what is wrong? This is a Black and brown person. Why didn't they get the same thing as other people? Yes, it is incumbent upon us as healthcare workers to go and to speak up. And I find that people do that. And so the MMRC cases that we review, it's not that someone didn't speak up. It was just cracks that had built up, sort of that Swiss cheese model, we like to say, where a lot of different things happened. And we know that certain people are more vulnerable to those Swiss cheese scenarios than others.
Thank you, because yes, I understand I was not in direct patient care, but ERs and all of that, and that's another issue we talk about in here. And the caseload that nurses and doctors have is a lot. I just, if I ever saw it happening, I would march right up to the top head doctor or administration and say, and even reviewing afterwards. And if you're finding things that aren't right, I would hope we're reporting those to whoever that is not following up on their end. But thank you.
Thank you. Seeing no other questions, I have more. So I wanted to speak a little bit more about the access point. Do you see were you in the room when you had the conversation about how the Planned Parenthood relationship has been historically with African American community?
No, I was not. I was operating all day, so I apologize, but I am familiar with the history. That's part of the reason I became an OBGYN.
Yeah. So with your background, I want to hear your perspective and what would be the way forward, because a lot of the community members, I was going to say our community, which to me it is all of our community, there is a concern about the historical situation that is making people think that there is agendas beyond what's on the face.
Yeah, I mean, I acknowledge the history. OBGYN has its own history with Dr. Sims and enslaved Black women. So yes, history is history. You cannot change history. The goal, the way I like to think about it is, how do I move forward? How do I make community health decisions that are in the best interest of a patient? And so for me, yes, it's acknowledging what has happened, not only in OBGYN, but in Planned Parenthood in the 60s and the 50s, 60s, 70s, all back then. But how do I move forward? How do I take into consideration that history, the mistrust that Black and brown people have regarding their reproductive justice? Personally, as someone who's been invested in this bill for a very long time, the agenda was to make sure that people get access to care, that they're not lost, and that we're not discriminating based on what hospital you happen to be in the state of Connecticut, because Black and brown people tend to be in different communities than other people. And so for me, at least there wasn't a hidden agenda in getting this performed. I'm a Black woman, as you all can see. And so this is something that will benefit a minority community. And I think that if people have concerns, I'm happy to talk with them about it personally. But this wasn't meant to single out people and to continue to force them to do things against their will. That is not why I went into medicine. I know that's not why a lot of my colleagues went into medicine. We want you to have the autonomy to make decisions with evidence-based medicine. And that's the safest thing that we can utilize to be able to allow them to make decisions for their bodies according to whatever their goals are.
The school-based healthcare centers that have been in Connecticut, they're providing care right in the school systems. And around this building, we have this conversation that we need to have them in the rural parts of the state, because the access is poor there as well. Because of funding limitations, we have not been able to achieve that goal fully yet. But we do see school-based healthcare centers in the urban parts of our state. And with this bill, the clarity of access will be more in the urban part of the state, where the population is more the Black and brown young boys and girls. So in this situation, if somebody says, well, this is again a targeting of a bill which is going to have clarity on the issue, where the access is going to be more to Black and brown girls for contraception, how do you respond to that?
I think developing trusting relationships with healthcare providers wherever they are is our task. If they happen to be in a Black and brown community, that's great access, because that means that they don't have access to it. They would have an undue burden to travel to a place that they may not know. And so what I would say to whoever has that opinion is, it is a good thing. We have hospitals in Black and brown communities. We have other access points in different places. And so it's not targeting because of the color of someone's skin. It happens to be targeting because, unfortunately, they live in an area that is a desert, so to speak. Yeah. And so we're trying to help reduce the burden that is undue on patients because they live in a certain place due to whatever their circumstance may be.
Yeah. Offline, I would love to have a conversation with you about before the community comes to the hospital and after they leave, because that's where a significant proportion of the problems lie. And we will have to have more of those conversations and policies around that as well. But my co-chair has a question as well.
Thank you, Senator Anwar, and thank you, Doctor, for being here with us today. And you've been with us before in the past, and we're grateful for your ongoing advocacy. Just as a follow-up to a question from Senator Anwar, we've talked a lot about the school-based health clinics today, but this bill is not limited to school-based health clinics. Is that correct?
Yes.
So this is for providers all over the state and in multiple different settings.
Correct.
Okay, and I think that's important because I think while I think that the questions center on more, the questions he is asking are important. And it's important that we are, respecting and understanding where people are coming from with this. But I just want to make sure that everyone is aware that this is for all healthcare settings.
Correct.
Okay, thank you. Thank you, Senator.
Rep. Carpino, did you? No, okay, good. Seeing no other questions or comments, thank you so much for your testimony. We appreciate you coming here.
Thank you for your time, everyone.
Thank you. I had seen Gemma earlier online. Gemma Kavarusias. Well, you dropped off. So next is Edmund Gadomski. Welcome.
Welcome. Good evening, members of the Public Health Committee. My name is Ed Gadomski, and I serve as the Executive Secretary of CHCA District 1199 Nucci. As part of my job, I am assigned to represent the registered and licensed practical nurses and the technical employees at Waterbury Hospital. It is in this capacity that I testify today in support of SB 1507. Our members at Waterbury Hospital have been vocal since well before 2022 about the nightmare that they have been living daily, a nightmare that continues today. It's still hard to believe how a company with such a track record of flouting oversight and regulation and an exposed desire to repeatedly put profits over patients was approved by the state to assume ownership of Waterbury Hospital. It's obvious that the state did not conduct an extensive evaluation that included diligent research when Prospect applied to purchase 3 Connecticut hospitals back in 2015, despite testimony submitted on the dangers of private equity and the documented record of negligence of Prospect Medical Holdings. The public outcry over Prospect's excessive profits and critical understaffing overlooks an even more alarming reality. Hospital staff are being abandoned in increasingly dangerous working conditions. Security personnel shortages have forced healthcare workers to fend for themselves amid escalating patient and visitor violence against nurses and bedside staff. With mental health admissions surging dramatically, the hospital's failure to provide adequate protection puts employees at severe and imminent risk of physical harm. This isn't just about poor management. It's about willful negligence that leaves vulnerable healthcare workers exposed to assault on a daily basis. SB 1507 is a necessary step in the right direction. The bill's primary purpose is to prohibit private equity ownership, and that is simply common sense, especially since we are still living in the nightmare that private equity-owned hospitals has brought us. Allowing the state a way to step in before a hospital experiences catastrophic financial failure by monitoring triggers and having the option to put the facility into receivership will only help protect patients, employees, and communities. One of CHCA's concerns as we move forward through the bankruptcy process is that we may be left once again with another private equity-backed owner. This is unacceptable. Right now, we don't know who the owner will be, but SB 1507 gives the state a long overdue tool in its toolbox to ensure that whoever it is, the state will be prepared. We cannot let the greed of an out-of-state owner impact the lives of so many Connecticut residents. We cannot make that mistake again. I urge this committee to pass SB 1507 without hesitation. The future of Connecticut's healthcare systems and the nearly 1 million residents who use Waterbury Hospital, ECHN, and Rockville General Hospital for their medical needs depends on it. Thank you.
Thank you so much, Ed. You become a pro right on 3 minutes. Thank you for your passion. Thank you for being an advocate, and thank you for being a part of the healthcare team and in speaking for people in Waterbury. I see no questions or comments. Again, thank you for being with us today.
Great, thank you.
Thank you. That brings us to the next person on our list, which is, I'm Gretchen, come on over. Welcome.
I'll go home.
Welcome, Gretchen.
Good evening, Senator Anwar, Representative McCarthy Vahey, and honorable members of the Public Health Committee. Thank you for sticking with us. My name is Gretchen Raffa, Chief Policy and Advocacy Officer with Planned Parenthood of Southern New England, testifying in strong support of House Bill 7214, an act concerning maternal health. As the state's largest provider of sexual and reproductive health care, serving nearly 50,000 patients at 14 health centers across the state last year, we believe all people should have access to quality, affordable, and compassionate health care as a fundamental human right, regardless of who you are, where you live, your income, if you have health insurance, or your immigration status. As advocates for reproductive freedom, we believe every individual has the right to full bodily autonomy and the ability to make personal decisions about their body, life, and future, including if and when to start a family. It's our responsibility as a reproductive healthcare provider and advocate that our work must be inclusive to ensure that people not only have equitable access to contraceptive care and abortion care, but also ensure people have equitable access to fertility health care, prenatal pregnancy, and postpartum care. Our maternity care system is failing communities who are most impacted by the burden of structural inequities due to this country's legacy of racism and other forms of discrimination. The United States continues to have the highest rate of maternal deaths of any high-income nation, despite a decline since the COVID-19 pandemic. Most of these deaths, over 80%, are likely preventable. Racial disparities of pregnancy-related deaths show that across all income and education levels, Black women in the United States are at higher risk for poor outcomes than white women and are 3 to 4 times more likely to die from pregnancy-related causes. We are proud to support Public Act 147 and other laws passed in recent years that have prioritized maternal health in our state. House Bill 7214 is a necessary and urgent next step for the important work our state has already done to improve maternal and infant health outcomes, with a focus on prevention interventions. We want to thank the administration, this committee, the legislature, and the Black Maternal and Infant Health Caucus for continuing to prioritize maternal health policies this session. By establishing the maternity care report card, this bill will create a system which will assist in improving transparency, addressing inequities, and is an important accountability measure that would include specific recommendations to improve maternity care at hospitals and birthing centers throughout the state. It'll also help to reduce barriers for doulas and birthing people and expand on our state's policies by identifying and establishing best practice for doula collaboration and doula-friendly policies. Increasing equitable access to doula care services, especially in under-resourced communities, has been shown to improve outcomes for both mothers and newborns. And by establishing a much-needed perinatal mental health task force to study and make recommendations regarding improvement of perinatal maternal health and mental health services, this bill will also address crucial aspects of maternal health and well-being. This is overdue and a crucial next step to improve maternal health outcomes in our state. Planned Parenthood of Southern New England has long fought for a person's right to control their reproductive lives, which includes planning their family, having a healthy pregnancy, giving birth to a healthy child, and raising their family in safe and healthy communities.
Excuse me, Ms. Raffer. Oh, go ahead.
We urge the committee to support House Bill 7214 and take another crucial step in addressing health inequities in maternal health and prioritizing improving maternal health outcomes and ensuring every birthing person and their family in our state has a positive birth outcome. Thank you for your time and consideration.
Thank you so much. Which bill were you supporting again? 7214?
7214, an act concerning maternal health.
Okay, thank you. And 7213 too? 7213 as well?
Yes, you heard from my colleague, Dr. Nancy Stanley,
Yeah.
earlier today, but
Yeah.
I'm happy to answer questions.
Yes, Representative Carpino.
Thank you, Mr. Chairman. Thank you for the offer to answer some questions. I do have some questions on 7213. And I did have the opportunity to listen to your colleague's testimony remotely. Did you have any input into drafting of the proposal that's before us today?
Yes, Planned Parenthood did.
Sure. And which particular provisions did you have input into?
I can't remember each section. But we've been working with the Department of Public Health. If you're referring to the repealing of the statute, I'm not sure what section. I can pull up the bill though, just to make sure I'm answering your questions.
No, and take your time. I'd rather you be confident in your answer. I'm not trying to play gotcha. And I'm not asking about a particular section. I'm truly asking which parts of the proposal you had influence in.
We've been working with our policy council, Center for Children's Advocacy, Connecticut's School-Based Association of School-Based Health Centers, who am I forgetting? I think I'm forgetting other folks that have weighed in, and other reproductive health advocates on the drafting and proposal in front of you.
Sure. And my question was, were there particular provisions that you advocated for in this draft?
All of them. I got it in front of me, Representative, sorry.
It's okay.
Yes,
I'm a
all
paper
sections.
person. I brought
Yep.
I brought it in front of me as well. Okay.
All sections we are supportive of.
Thank you. And I didn't want to, I asked you that because I didn't want to ask you questions about provisions you may not have had any influence to. So I'm just going to take them one at a time. Section 2, mandating the Secretary of State to update the regs not later than October 1st. Could you offer me some insight into that particular provision? Through you, Mr. Chairman, sorry.
So we've been working since the Reproductive Freedom Defense Act was passed in 2022, which, why am I forgetting the Public Act reference that is? But I think folks are familiar with that law that modified our abortion statute. We've been working with the Department of Public Health and the legislature to update the abortion regs to be aligned with the statutory requirements.
And thank you, and I'm well aware of that process serving on the Regulation Review Committee. I'm just trying to understand the significance and the impetus behind forcing the Secretary of State to update the regs by October 1st. So if you could help me understand.
At this time, we're advocating for an update in the regs because abortion in our state is already overregulated, and there's simply no reason to overregulate abortion. So at this time, we would like to see the state of Connecticut to work towards improving the regulations. And you can look back at Planned Parenthood of Southern New England's public comment. We offered public comment in August of 2023 and August of 2024. I'm trying to remember the timeline in front of the Department of Public Health. And one of the provisions, or one of the parts of our comments said we would recommend the department repeal the regulations altogether, which is what you are seeing before you today in this particular piece of legislation.
Sure, and this is my concern on this particular provision at the very least is that I don't like to draft laws for things that could be addressed outside of a law. So I'm having a hard time understanding why we're attempting to force a constitutional officer to put forward regulations when there is a statutory committee already on the books that is charged with regs. That's why I'm asking to truly try and understand what the intent is here.
The intent is to repeal the statute that requires regulation of outpatient clinics that provide abortion care.
Sure, and I recognize that not everybody on this committee happens to sit on that other committee. So based on my recollection, there has been an attempt to bring regulations through the Reg Review Committee. Can you just perhaps help some of the other members of the committee understand why we're trying to force a constitutional officer's hand here with this particular bill that's actually in public health and arguably should probably go to GAE if this gets out of here, as opposed to following the traditional process?
I think from an advocate's, and I won't speak, I want to be clear, I'm not an attorney, so I don't want to speak to why it was drafted, exactly how it was drafted. I can't speak to that, but I'm happy to get back to you with an answer to that particular question regarding the drafting of that section. As an advocate, there are no abortion specific regulations that are required to ensure that abortions are provided safely and in a medically appropriate manner. So I think from an advocate's perspective, we are at a point where this is now almost this is going to be 3 years after the law was passed, and this process has been delayed multiple times. And we are hoping that the legislature will do everything they can to bring Connecticut in line with other states. We are lagging behind. In particular, we overregulate compared to our neighboring states. There's no medically necessary reason, again, to over-regulate abortion care. So the advocate, on behalf of Planned Parenthood of Southern New England, I don't want to speak for other advocates, they can speak for themselves. We are advocating for the repeal of the statute that mandates outpatient clinics because it only impacts the regulations as written only impact outpatient clinics. So it's not forcing, the removal of these regs does not force anyone to provide abortion care. It does not force nothing changes. Again, it is just removing outdated, medically unnecessary restrictions that are in regulations.
And thank you. And I appreciate that not everybody we ask a question to has all of the information at their fingertips. So if you don't mind following up on that particular provision and why Section 2 is drafted the way it is, I'd appreciate that. And then to sections 3 and 4 of the bill, where they address, I want to be very specific because I know the question came up earlier, 19A-116-1, the regulation asking to be repealed. And is that the entire regulation in its entirety that you were advocating to be repealed?
Yes.
Okay, so that just for those who may be at home, so that entire regulation addresses informed consent, consent requirements, staff qualifications, risk management, and emergency preparedness. And while we could go through every line here and argue about whether some of these items may or may not be covered in other places in the regs or the statute, I think it is important to recognize that when an organization or organizations are advocating for an entire regulation on such an important topic to be repealed, that we look at the entire regulation. I appreciate you answering all of my questions and always being available to answer my questions. I'm a little dismayed to say that this seems to be nothing more than an end round around a fully functioning committee that also sits in this building, one that also happens to be bipartisan for those who are not aware. Thank you.
Thank you for your questions. So Ms. Rafa, thank you for your testimony today, but also staying with us the entire day and afternoon and evening. And I know my colleagues have more questions. We'll get to you guys in a second. I just wanted to put this in perspective that your testimony was on a different bill, right?
Yes, it was.
And that was for maternal health, and that's the one that you're speaking on. But of course, you're an advocate for 7213 as well, and
Yes.
that's why we are. Some of us are asking the questions because you're an advocate and recognized and respected advocate on this issue. So that's I wanted to put this in perspective, that why we are asking the questions of you on a bill that you have not testified on.
I understand. Thank you.
And so with that, Representative Zupkus.
Thank you, Mr. Chair. Obviously, my question is not on the bill that you testified on, Gretchen, but I do want to kind of continue down the path that Representative Carpino was talking about. In the repeal, as I see it, there are, they want to repeal: no person shall be required to participate in any phase of an abortion that violates his or her judgment, philosophical, moral, or religious beliefs. Is that part of what you want to repeal?
Yes, we are advocating for the repeal of the regulations that outpatient clinics that provide abortion care have to adhere to. And while I respect the questions, I also know that freedom of religion is important. So I've heard you ask the question a couple of times, and it's one of our nation's fundamental values. That's why it's already protected by the First Amendment. So nothing that we are doing is going to, again, force people against their religion, or their constitutionally protected freedom of religion to not participate in something that they are religiously or morally opposed to.
But if we repeal that piece, it does. So
No,
would that
it doesn't.
mean St. Mary's Hospital would have to do abortion?
No, St. Mary's Hospital doesn't do abortions, Representative. These regulations are for regulations of outpatient clinics in the state of Connecticut. So these regulations don't impact St. Mary's or any of the Catholic institutions in our state. So I just want to clarify that, especially for people watching at home. These regulations were put into place in the early 90s when this state with a bipartisan effort, codified the right to abortion in state law, just like we updated it in 2022. These regulations are outdated. They're medically unnecessary. They're not aligned with the medical standard of care. I'm not a doctor, so I'm not going to play one on TV. There will be doctors that come after me that can speak to the medical aspect. But all this is doing is all we are advocating for is that these unnecessary, medically outdated regulations are repealed. It doesn't take away someone's freedom of religion. I promise you that. Planned Parenthood is not trying to remove people's religious freedom. And there's already federal conscience laws that protect providers who are religiously opposed. There's longstanding federal protections.
I thank you for recognizing freedom of religion, right? And people's religion. I'm not convinced yet removing that would, so I would be willing for further discussion on that.
Yeah.
The second one is if a newborn shows signs of life following an abortion, that the measures used to support life in a premature infant shall be employed. And you're asking for that to be removed also, correct?
We are.
And so does that mean if somebody goes in for an abortion, the baby's delivered still breathing, then at that time they could perform the same procedure of an abortion on a live baby breathing?
That's simply not how abortion care works. Medical professionals have a legal, professional, and ethical obligation to help their patients in distress. So when we're equating abortion to what you're describing, that's just
I'm
not.
just reading what it says.
I know, and I will say that when that was written in the early 90s, again, that is language that is inflammatory. It is not how the provision of abortion care happens. Again, I'm not a medical provider, so I'm going to ask some of my friends that will be coming after me to speak to that, but medical professionals already have, and I will ask Dr. Anwar if he wants to weigh in too. I know I'm not supposed to ask you questions, but they already have a legal, professional, and ethical obligation to intervene. So whether it is a newborn 10 seconds after being born, or a 60-year-old. So I think it's a false comparison because that's just simply not how abortion works.
Okay. Again, just reading what this says, and to be repealed says that if a baby's born showing signs of life, then what? So
I think, again, that's where this is a medical decision that needs to be made between a medical provider and the patient. No laws or regulations should be interfering with people's ability to access the medical care that they need.
Okay. So if they said, then basically kill the baby, they could do that if this is repealed.
That's inflammatory, like I said,
well,
Representative. I think you're
really
trying to be well-intentioned, but I'm just
really
saying
am.
that is not how abortion care works. So even saying that is actually not aligned with how abortion later in pregnancy works. And again, I'm not a provider and I should probably stop commenting at that point because that's just not how abortion care works.
Okay.
And honestly, I work with plenty of medical providers and I know providers, it's almost deeply offensive to assume medical providers wouldn't intervene in a way that is aligned with their, with their oath as providers and
I would
medical.
completely agree with you.
Okay.
So that's
Great.
why I'm
Yeah.
concerned. Well, that's why I'm concerned about this being removed. So, and then,
But there's no reason that that has to be in an abortion specific regulation. There's no other medical procedure that is regulated, over-regulated like this, that tells a doctor how to intervene in cases of emergency.
so, and I just have one more
Thank
after
you.
this, but I'll just say, everything in this state is overregulated. So if you sit on any other committee, everything is overregulated in this state. My last one, if I may, Mr. Chair, it's about the third trimester of pregnancy. Abortion may be performed only when necessary to preserve the life or health of the expected mother, which I agree with. And I know that even in Catholic hospitals, if a woman is pregnant and has complications, that will happen. Again, concerned about why repealing this, because by repealing this says in the third trimester, you can have an abortion.
No, unfortunately, that's not true, because in the state of Connecticut, there is already statutory limitations to when a patient can access abortion. There is a statute, I'm going to forget the statute, 19A-603, I think, that has we have a post-viability ban in the state of Connecticut. It is on the books. It limits people's access, patients' access to abortion care when they need it later in pregnancy, which we are also deeply troubled by. That means that patients later in pregnancy need to travel out of state to access the medically necessary health care they need because of our statute that, again, was passed in the early 90s, which has forced pregnant people to leave the state when they need abortion care later in pregnancy because of the statutory requirement. And the regulation itself is actually inconsistent with the statute. So it's actually not written in consistency with the statute.
Thank you. Thank you for your answers. And by what you just said, people traveling out of state, all I hear is people traveling to Connecticut to get abortions. But, we can agree to disagree. And I just am not convinced that the repealing of these, especially these three pieces, which are the big concern, is any way, shape, or form over regulating or a burden on anyone. But I do thank you for your answers.
Thank you.
Thank you, Mr.
Yes, I
Chair.
appreciate it.
Thank you. I just want to put things in perspective for a second. So we are looking at for the reproductive rights bill number 7213 LCO 5865. There's nothing in this bill which is talking about a abortion where a child is breathing. There's nothing in this bill which is repealing anything. There's nothing in this bill that is repealing a third trimester abortion or taking away the ability to save a woman's life. There's nothing in this bill that is repealing any regulation that is going to have an impact on that. I think there's this regulation 19-13 D54 is not part of this bill. So I just want people to understand that. And let's back up a little bit. Why is this bill talking about removing some of the regs? And I think the perspective is, and that's something somebody had spoken earlier, was that you do not have coronary artery bypass graft regulated. You do not have laparoscopy regulated. You do not have appendicectomy regulated. You do not have corneal transplant regulated. You do not have surgical procedures regulated. One of the only thing that's regulated is abortion in the state, because we were probably ahead of the curve for the rest of the country to write a bill way back when we did. Thankfully, we did that, but it was done in a manner where it was regulated, and we have now come to a point that we do not need the regulation. The idea is to deregulate it, but at the same time, if any of the regulations are going to do something that is not compliant with the values that we have, that can be put in a statute. So that I know it's causing anxiety. There's a lack of trust that have on the two sides of the equation. The first and foremost thing is that the minors who are going through pain during a delivery, that needs to be addressed. The minors who are seeking contraception, that should be addressed. There are regulatory parts of this history of the state of Connecticut that needs to be repealed, so it's not a regulated procedure. But at the same time, if there's a regulation that is going to make the protections weaker, I would, as an individual, I would say we should put that into statute so that we can have protections in place, so that we do not deregulate the valuable things that were regulated way back in 1991 when we did those. And then that's how I would level the conversation so that our fears are somewhat decreased about the whole issue. That's what I wanted to just mention for everybody's benefit, because we will go around in circles. I hear your anxieties and concern about the deregulation, and I respect those. And I do feel that it needs to still be deregulated, but do it in a manner where we are not deregulating the things that should be in statutes. Representative Zupkus, back to you again.
Thank you, Mr. Chair. So I take it, I understand those are not in the bill, the things I discussed, and that they won't be.
Well, I can tell you they're not in this right now. I'm not planning to put them in the bill, but
Great.
who am I right now, right?
Thank you.
Thank you.
Senator, can I just clarify though? I want to be, I want full transparency with everyone. And so
Yeah.
I will follow up with the committee and send our public comment from the DPH hearing. We are advising that both regulations are repealed. So I just want to make that clear too. And I, again, want to make sure I'm answering honestly to all of the representatives that have asked that question. Both of those regulations are medically unnecessary, and you just captured why, because there is no need to overregulate abortion care and exceptionalize it outside of any other kind of healthcare in the state. And I just want to reiterate that abortion providers and facilities already have other laws in place to ensure the safety of patients and the care they get. And I will say over and over again, our patients' safety is our #1 priority at Planned Parenthood of Southern New England. And I think, most medical providers would say that too.
So Gretchen, on the same note, so let's say you want to add more regulations that needs to be deregulated. But if there are parts of those regulations that are very important, for example, some of the things that people are touching on, would the advocates be very open to looking at addressing them in the form of a statute?
Well, I will, I don't remember our entire public comment, to be quite honest with you, and I can pull it up and answer questions. I'll stick around for after the hearing. Beyond, when we went in front of DPH in the public hearing, we asked for a full repeal. We outlined, if the department was not going to move towards a full repeal, we outlined what we think is the most appropriate based on the medical standard of care for abortion care and for outpatient clinics.
Okay. In other words, there's a conversation that's possible.
Absolutely. I love conversations.
Good. All right.
Very open to conversations.
Good. Anybody else wants to have more conversations? Yeah, Representative Mara, please, you're on.
Thank you so much, Mr. Chair. Thank you, Gretchen. Really appreciate your comments. And I think it's helpful for you to outline what happened with DPH. I guess, obviously, I've asked those questions several times throughout the day because I know that you all have wanted to repeal them, even though they're not in this bill. And if they don't go into statute, I will have real issues with that, which is so upsetting because I think that there's so many good things in this bill that I would like to see. One of the things that we touched on earlier was the thoughtful words, especially with our school-based health centers, on how to talk to kids with conversations with their parents. And throughout that conversation, we're talking about maybe adding in some sort of training aspect. What are your thoughts there for training aspect to healthcare providers when they're dealing with minors, either around abortion care or pregnancy care or contraception?
Just so I'm understanding the question, Reb, are you suggesting that we add a component to that in the bill
Yes,
for training providers
yes.
on how?
I'm asking your thoughts on whether you think adding training into healthcare providers that deal particularly with minors would be a good idea.
I think additional training and education is always ideal, and I trust our medical providers. Again, I don't want to speak for other providers across the state, but our medical providers and our clinical care team go through extensive training, including everything that we do is through informed consent and modeled after informed consent. I know the quality and the high level of education and training that goes, that happens at Planned Parenthood of Southern New England with our providers and our frontline clinical staff. I would be happy to talk to you more about what that could look like and include our medical experts and educators that could help inform that as well.
And certainly, and I believe that you would have really good conversations with minors at Planned Parenthood. That's your jam. And the school-based learning, I think that's also their jam. I'm talking about providers that may not see minors as much, maybe in hospitals. Particularly, the reason why this came up is because I read testimony from a young doctor. I think they were a resident or something, and they used the word that their patient was coerced by their parent, which to me is horrifying to think as a parent, I coerce my child. And if I have a healthcare provider that's speaking to my child and warning them not to be coerced by me, that causes problems. And we don't want that divide. We want to bring us all together. So that's one of the reasons why I'm thinking that maybe more training around this could be a good thing.
Yes.
Okay. I'm going to leave it at that, and I look forward to future conversations. Like I said, I want to get behind this bill, but if there is any sort of action on repealing those particular areas, I will have real problems with it. Thank you very much, Mr. Chair.
Representative Claire Teacher.
Thank you, Mr. Chair. Thank you, Gretchen, for having rapid fire today.
This is fun.
And I
This is fun.
appreciate it. So on the same subject of not what you're here to testify for, and I've heard the conversation. So for the regulation 19-13-D54, the abortion reg, you as Planned Parenthood wants that regulation repealed.
Yes.
Okay. And that's what we were told. And what was your conversation with DPH about repealing that reg?
Oh, let me go back in the Wayback Machine. We've been talking to them for the last couple of years. We shared, I would have to again pull up the comments that they replied to our public comment. Because I don't want to misspeak on what they responded to in terms of our comments about that particular regulation. But we have their responses, and I'm happy to follow up one-on-one. They know where our position is. We've been talking about this for now 3 years. So they know what our position is, and we've been working closely in partnership with them on ensuring that the most recent proposal, which was that went for a public hearing, I think it was August of 2024, that they took into account the comments that we had put in August 2023, and actually really grateful for the department to listening to the medical providers that weighed in August 2023 about the need to update the regs. And they took into account, not just from Planned Parenthood, there were other medical associations that provided comment, and DPH was very responsive to those.
Okay, thank you. Thank you for your responses. And I know you could tell today by this side that there's concerns about repealing this entire reg. And we just want to make sure that maybe some things that could be repealed, that it's not a blanket statement, and that there are things that really need to stay in regulation that we don't
inadvertently or on purposely get rid of them
Mhm.
and for public safety issues and, consent issues. But I appreciate you being here today and
Thank you, Rep.
dealing with this rapid fire perfectly. Thank you, Mr. Chair.
Thank you. I just want to look online because I don't want people online not to have this opportunity. And for the people who, the people who are going to testify, just know that the Public Health Committee is going to ask any question about any of the bills, so better start reading every bill. Seeing no other question or comment, thank you, Gretchen.
Thank you very much. I appreciate it.
Oh, wait.
I just want to say thank you, Gretchen. I want to thank you for your willingness to be in constant conversation. And I know we'll all keep talking about this. And as you know, we work together with our ranking members to try and come forward with the best possible solution. So thank you so much.
Absolutely.
Thank you, Mr.
Thank
Chair.
you. Appreciate the committee.
Thank you. That brings us to the next person, number 47, Rachel DeMarco. Welcome, Ms. DeMarco. You're on. Thank you for your patience with us today. Actually, for some reason, we can't hear you. I know you're unmuted, but you got to change your mic to your headphones. Or no, we still can't hear you. We'll give you a couple of minutes and we'll come back to you in a second. We'll take you for sure. Don't worry. Let's figure out your mic. I think you may need to take your headphones off and then maybe use the other direct one. Still can't hear you. Meanwhile, if Dr. Shah, if you want to come up, number 48. Okay, I think you're on now. Wait. Yeah, Rachel, say something. Yeah.
You can hear me now?
Very well.
Okay. My apologies for that. I guess I don't know how to use technology. My name is Rachel DeMarco. I am a family nurse practitioner. I've worked in Connecticut for 18 years as a family nurse practitioner with the past 9 years in school-based health. So I come to you as a school-based healthcare provider and also a parent with 3 children in Connecticut. I'm coming to you in support of Act 7213 concerning reproductive health. State law is not clear around the ability of minors to obtain reproductive health without their parents' permission, and this leaves providers to interpret the law and judicial rulings. Similarly, providers are seeking clarity around the billings and statements sent home to parents. Generally, this law would seek to codify what is already practice. CT law allows minors to receive emergency medical care, treatment for HIV, certain mental health conditions, abortions, and tests for STDs without parental consent. However, Connecticut law does not explicitly permit minors to access contraceptives or consent to pregnancy testing. The Supreme Court has extended the right of privacy to include a minor's decision to obtain contraceptives. So arguably the same logic would apply to a minor's decision to a pregnancy test. The lack of clarity can cause conflict, and there's no explicit state law allowing this type of care. SBHC clinics have a unique role in developing strong relationships, especially with adolescent populations in high schools. We can develop those relationships with kids where we're a trusted healthcare provider and they have direct access to us through their school. According to the AAP policy statement on contraception for adolescents, nearly half of U.S. high school students report ever having sexual intercourse. Each year, 750,000 adolescents become pregnant, with more than 80% of those unplanned. So basically, a minor is legally permitted to receive these services without a parent's consent, and the minor alone can receive them. So when hearing it talk about should we give counseling, yes, we always talk to our patients and encourage them to talk to their parent or their legal guardian regarding these things. But sometimes it's not safe to do so. I can tell you personally and professionally of experiences of minors coming in pregnant and then helping them disclose to their parents and develop that relationship and explain things. And being that safe space for them to come to matters. Thank you for your time.
Thank you very much. Thank you for figuring out your technology. I'm glad we were able to hear your testimony. Can you tell us that percentage of young people who you said are having sex?
Yeah, it is. Nearly half of US high school students report ever having sexual intercourse. And that's taken from the contraception for adolescents policy statement that was reaffirmed by the American Academy of Pediatrics in March of 2021.
Thank you. You actually anticipated my next question, which was, could you name your data or source data? And I appreciate you sharing that. That's a
Yes.
significant number and certainly an argument in favor of making sure that we have free and clear access to contraception for young people. So thank you for your work and for being here with us today.
You're welcome. I wanted to make sure you heard the 750,000 adolescents who become pregnant, with more
Yes,
than 80% of those unplanned.
Yes, I did. I actually wrote that number down, but I believe Connecticut is third or fourth in terms of lowest number of teen pregnancies. I heard an earlier testimony today. I'm not asking you to quote that but that is hopefully a sign of success of the availability of contraception for our young people. Thank you for being here today.
Thank
the
you.
next number of people are here with us in person, and Dr. Shaw, you are actually up now. We're happy to see you and have you here. Thanks for being with us.
Great. Good evening, members of the Public Health Committee. My name is Ashka Shah, and I am a resident physician at Yale and a researcher on private equity in healthcare, and recently published an opinion piece in the CT Mirror on the impact of private equity on hospitals. I am here to voice my support for Senate Bill 1507 to prohibit private equity ownership of healthcare facilities and target the undue control of healthcare provider clinical judgment. Here are my key reasons for supporting the bill. First, most states, including Connecticut, have corporate practice of medicine laws, which prohibit corporate entities from practicing medicine and require that medical practices be controlled by healthcare providers. However, a lack of enforcement as well as loopholes in legislation, including naming physicians as practice owners while having a parent company control finances, allows private equity firms to continue to control the decision-making of healthcare providers across the country. Second, when I surveyed healthcare providers working within these systems and asked them what the most common challenges they faced were, their responses included not having enough time with patients, feeling pressure to increase utilization to turn out more profits, and meeting productivity quotas, among others. When asked whether they brought up their concerns to management, 80% of respondents stated yes. However, responses from supervisors included dismissing concerns or worse, reprimanding employees for coming forward and even terminating employment. I also conducted several stakeholder interviews where one provider stated, and I quote, "There is a substantial decline in appropriate patient care due to unsafe staffing levels and criminal overpricing of services with no knowledge or control over what is being billed under my name." Another provider was forced to leave the state after signing a non-compete within a 50-mile radius. These responses are further corroborated by national research, which shows higher clinician replacement rates at private equity-owned practices and an increase in physician moral injury and burnout due to widespread non-compete clauses, non-disclosure agreements, and a lack of whistleblower protections. Lastly, this bill mentions the appointment of a receiver over financially distressed hospitals. As I mentioned at a prior hearing, there are many red flags prior to a private equity-owned hospital pursuing bankruptcy, including net operating profit margins in the negatives and participation in a sale-leaseback agreement. This bill offers the chance for the government to intercept and seize hospitals, as was done in Massachusetts with the downfall of Steward Health. Compared to House Bill 6873, Senate Bill 1507 would be a definitive step in prohibiting private equity ownership and allow Connecticut to be a trailblazer nationally when it comes to private equity-related legislation. Thank you for your time and consideration.
Thank you very much for being here and for being here with us previously as well. We heard previous testimony. I'm not sure if you were here earlier in the day from one of the folks testifying with respect to those outcomes, those patient outcomes. Can you speak a little bit more specifically about some of the studies that you've seen and what the results of those studies are? And specifically, if it's clearly through those studies, there's been causation determined.
Certainly. So last year in JAMA, there was a national study looking at the incidence of central line associated bloodstream infections in private equity owned hospitals and their nonprofit counterparts. And there was a statistically significant increase in central line associated bloodstream infections. And that's just one metric involved in the Medicare Star Quality Rating that I mentioned previously. I specifically also looked at specific metrics like 30-day readmission rates, all-cause mortality, time to being seen in the emergency room, as certain metrics that are part of that Star Quality Rating. And again, did notice differences and statistically significant differences in both private equity hospitals compared to their nonprofit counterparts.
And again, you were looking primarily at hospitals.
Hospitals, correct? Yeah.
Yes.
Yeah.
Geographically, my understanding is that there are certainly some places in the country that have a lot more, a higher concentration. I believe Texas, for example, is one. Are there other places in the country that have a higher concentration and where you have been able to look at data specifically?
A higher concentration of private equity owned hospitals.
Yes.
Yes. So I specifically chose the 3 states with some of the highest proportions, and that's New Mexico, North Carolina, and Texas.
Thank you for that. That's helpful. Are there other questions, comments? Seeing and hearing none, we appreciate your time with us. And I believe, as we said before, may well be reaching out to you again in the future. Thank you, Dr. Shaw. Next, we have Dr. Dante Britis. Welcome.
Thank you. Thank you. Good evening. Good evening.
Good evening.
Representative McCarthy Valle and the esteemed members of our Public Health Committee. My name is Dr. Dante Britis. I'm the president of the Connecticut Orthopedic Society, a practicing orthopedic surgeon in Fairfield, have been for close to 30 years. On behalf of the Connecticut Orthopedic Society and the 240 orthopedic surgeons that I represent, I appreciate the opportunity to submit testimony regarding Senate Bill 1507, the act prohibiting private equity ownership and control of certain healthcare institutions and some of the guidelines associated with that bill. There are 2 provisions in Bill 1507 that I'd like to highlight in addition to our written testimony. The first of those is the practice guidelines. Physicians, particularly those in private practice, are always concerned about intrusions of outside administration in clinical care. Every year, we're here fighting against insurance companies and hospital administrators that want to basically insert their claws into the exam room and tell us how to do things and try to be profitable or try to be in some way financially responsible by the things that they decide. The private equity is no different. We will not support and do not support intrusion of private equity companies into the clinical exam room. We will support well thought out guardrails that preserve any entity from influence for monetary reasons on clinical care in the exam room from anyone. That said, the total ban produced or proposed in this legislation is a major threat to private practices and ambulatory surgical centers in our state. Private practice is under attack. We have a negative federal policy as it relates to private physician reimbursement. Insurance companies are continually nibbling and biting away at our ability to provide care at a reasonable cost. And the hospital systems in our state continue to take a very, very aggressive posture, buying up private practices because we're under pressure and because of the financial pressures associated with this. Private practices provide excellent, cost-efficient care. For private practice, private equity platforms provide IT and tech support in a complicated world. They provide operational expertise that 30 to 40 years ago wasn't necessary, but today is. And probably very importantly in our state, they provide dollars to bring in new doctors I'm afraid that a ban on private equity will further drive healthcare into the employed hospital models with an increased cost of the system.
Excuse me, Dr. Britis, but you've reached your 3 minutes. Thank you.
If you could sum up, that would be great.
Very quickly. I am providing you a white paper that actually summarizes a care done by private practices with private equity support, hospital systems, and corporate medicine. Please look through it. It highlights that private practice with private equity provides by Medicare in a Medicare cohort the most efficient, cost-effective, and effective care in a large segment of our population. I hope that you'll look at this bill and recognize the difference between the hospital issues with private equity that are being addressed very effectively and discussed appropriately, and the complete ban as it affects private practice and the ambulatory surgical centers who are already striving to provide great care at a cost-effective method. Thank you.
Dr. Britis, thank you. Thank you for being here with us in person. And I'm quite familiar with your practice, having broken my ankle, as everyone here knows. So say hi to Dr. Probasco for me.
I will.
But I also wanted to take a moment to acknowledge for this committee and for you and your colleagues in the orthopedic surgery field, the loss of a treasured colleague, Dr. Michael Arno. And I just want to, on behalf of the members of the Public Health Committee, offer our condolences to you and to his family and to all who have had the pleasure of working with him. He was a tremendous gift to this committee and offered so much of his time and talent to help us come up with solutions. And we were devastated to hear of his loss. So
I thank you for that. Those comments, they're very well taken. I will convey them directly to his family. Our organization is at a loss, and we're going to have to double down and replace somebody who's basically not replaceable.
yeah, thank you. Thank you for that. And I can't say enough, but I do also have a couple questions and follow-up for you.
That'd be great.
In your testimony, you're very clearly speaking about private practice, and you referenced, but I just want to clarify that the issues around hospitals and the funding of hospitals are could be a different situation than what you're facing as independent private practices and ambulatory surgery centers.
100%. The hospital, the forces that drive hospital economics are completely different than those that drive private practice. And just the mention of what I said, federal Medicare policy on how physicians are reimbursed, not linked to any inflationary index for 20 years, has left us at a tremendous disadvantage. Every hospital reimbursement is based on that. They also have money. They act as a private equity bank themselves. They can put physicians in at higher rates. Did you know that for a simple knee scope, 65% higher cost in the hospital than we deliver in our surgical centers? And that goes across the board. Office visits, surgeries, physical therapy, all are delivered at a more effective rate through our centers. We look at them, we look at our care, our patient care, and we are cost effective, but caring and expert.
Thank you for that. And final question from me is, you mentioned a white paper. Did you submit that with your testimony as well?
It's being transmitted to you. And I gave Senator Anwar in passing this morning a copy of it, but I have 2 more copies that I'll leave with you, and you're going to get a PDF of it as well.
Wonderful. And if that can be sent to our amazing administrator, Beverly Henry, and I see a thumbs up in the background, and that way we can also share that with all the members of the committee. That's wonderful.
It's a really interesting paper.
Great. Thank you. And we have a question from Representative Clara DeStitria.
Thank you, Madam. Thank you, Madam Chair. Thank you for being here today, Doctor. I also want to send my condolences to Dr. Arno's family. We had many hours of heated debate over the past year, and I encouraged it, and it was sometimes frustrating, but it was always coming from a right place, something that he was passionate about and he felt strongly about, and it was, I'm I know he was happy to see we finally came to some sort of compromise, because that's what happens up here in this building. Compromise is a good day. So I just want to give my condolences to the family and to all his colleagues that knew him and loved him.
I can tell you that he articulated an appreciation for the diligence that you all the work that you all put in coming to that compromise. And it's been a long road, and we've all followed it peripherally, but thank you for all your work and all of your work in allowing this compromise to occur.
Thank you, Representative Clara DeStitra. Senator Almore, to be followed by Representative Carpino.
Thank you so much. I was listening to your testimony as I was breaking my fast. So now I have a little bit more energy. Hopefully, I'll be able to ask more questions. Thank you for your testimony and the work that you've been doing. And also, again, please accept my condolences for Dr. Arno, who's, just as we spoke earlier, an individual who I can tell that, and I give the example that if the aorta was bleeding, he would be cool and he would not sweat, and he would just focus on what's in front of him. So you could see that his could be a trauma surgeon, orthopedic surgeon at the level that needs a person who is calm in every situation. So what a loss for the state of Connecticut. Let's break down a little bit about the MSO agreements that are there. And in the past, we have had this conversation where we feel that while in the hospital side, we have enough experience to see how the hospitals have completely been eroded by private equity. But in the outpatient setting, as long as private equity is not in the driver's seat, we have an opportunity to work with them. Can you explore that with us for a little bit?
So historically, right now in Connecticut, there are 3 MSO or private equity platforms that orthopedic practices have linked to. Each of them have been able to recruit physicians. The longest lasting one, or the longest acting one, is about 5 years in. The doctors, I've talked to them all individually, continue to be supportive. There's been no leakage of doctors away from the practices, either at the time of the initial transfer or integration of the partnership, nor in the long term. And most effectively, they've been able to bring in new docs. The most recent one involved the group in Norwalk and Danbury, and they've already been successful at new recruitments, which, again, I can tell you from a private practitioner, bringing doctors into Connecticut is very difficult. And those that come in many times are seduced by what I would call high-level offers from the health systems that have monies that aren't reflected necessarily in private practice. And so the ability of these private practices to be able to recruit and to grow is a very, very positive portion of what we see as the MSO model to have some advantages for us.
For this MSO model, if there was a bill that would say that they always have to be in the minority share, how do you guys feel about that?
I've never seen a model where they wouldn't be. And I mean, personally, I can't answer for everyone. I would only think that's the only model that makes sense, because you're really looking for them not to get involved in clinical care. I need them to run the IT departments. I need them to work on AI applications for patient scheduling. Things that I don't have the time to do. And it's interesting, in 25 years of practice, at the beginning, I could do paper charts and I could do things that were not necessarily high tech. Today, the practice management platforms that we have to use require a really significant degree of sophistication to even make choices on. All the integrations and connection with data between hospitals and practices, all of that requires a much, much more integrated, deep understanding. And we don't have the expertise as docs to do that, or most of us don't.
Thank you so much. This was very helpful.
Thank you. Senator Almore, Representative Clara DeStitra.
I'm sorry, one more follow-up question. Do you think if this bill as written passed and MSOs were no longer able to work, that it would get rid of, we would no longer have any independent practices left in Connecticut?
I hate to make inclusive comments like that.
Just opinion.
My opinion is that it would be another nail in the coffin of private practice. And I think that private practice, from the perspective of myself and my partners and the large segments of the Connecticut Orthopedic Society, is crucial as an option for patient care. It's not to say that there's not a role for a university hospital or for an academic center, but the reality is that most care can be delivered better, more effectively, and cheaper in the private practice setting. And we're doing it already that way.
I agree. Thank you, Dr. Britta.
Thank you very much, Representative. Dr. Britta, thank you very much for sticking with us
I
today.
thank you for sticking with us.
Oh, it's our job and our pleasure as well. So thank you.
Thank you for your kind words on Dr. Arna. I will pass them on.
They're very genuine from all of us and very heartfelt. Thank you. Dr. Kapoor is up next. Welcome.
Dr. Kapoor, last time you came in, I said we put the bills in just to come in. You have come over here and we have a chat.
Absolutely.
So another one of the similar bills.
More than happy to be here. And Dr. Anwar, Representative McCarthy-Vehi, and members of the committee. My name is Dr. Dinesh Kapoor, and I'm here on behalf of my independent medical practice, Eastern Connecticut Hematology and Oncology Associates. And I'm writing to oppose Bill SB 1507. I have submitted my testimony 2 weeks ago on Bill 6873, and again write in opposition of Senate Bill 1507, a bill that I believe would be disastrous for healthcare delivery in the state of Connecticut. It's been my life's work over 28 years of serving patients to build a practice that delivers some of the best cancer care in Connecticut. 2 weeks ago, I testified to this committee about how my practice is the only private practice in the state infusing bispecific antibodies in a community setting, saving sick patients time traveling to tertiary care centers for similar treatments. We spoke about how my practice brought in groundbreaking clinical trials to Connecticut and enrolled the first patient in the world, not in Connecticut, not in the United States, but in the world, with a vaccine trial for lung cancer. All this was accomplished with our help and partnership with the Management Services Organization. So by placing a ban on external capital investment in healthcare, Senate Bill 1507 would tell my practice and many other practices in the state to stop bringing in cutting edge technology, stop bringing in new physicians who are fellowship trained, and stop the progress that we have made in reversing the consolidation of outpatient care by hospitals and health systems. In the hearing on House Bill 6873, I'll quote co-chair Representative McCarthy-Vehi, who wisely said we shouldn't throw the baby with the bathwater. And I totally agree with it. Section 1 of this bill threatens exactly that. My patients will be the ones who will suffer if this bill passes. I respect the effort this committee is making to address what happened because of Prospect, but SB 1507 legislates to the lowest common denominator. In the fallout from Prospect medical disaster, it is more important than ever for the state to take a responsible and more targeted approach. And I'm all for it, absolutely for it. During my testimony, I also responded to Representative Reddington Hughes, who asked me an important question regarding where I should, look to make sure that physicians and patients are protected from these bad actors. And my answer was then, and even now, it's the same. I believe that Section 2's provisions aimed at safeguarding physician autonomy are far more effective than the sledgehammer approach of Section 1. That would be prohibiting investment in medical practices like mine. Section 2 protections for clinical decisions like the time I spend with patients, the number of patients I see in a day, appropriate diagnostic tests that I order for my patients are decisions that should, without question, be reserved for licensed physicians to make.
Excuse me, Dr. Kapoor, but you've reached your 3 minutes. Thank you.
If you can finish.
I will finish. What I would like to do is I would like to say that some of the language of Section 2 is too broad and ambiguous and will leave physicians and management partners very confused. One example I will give you is when I sign off on final coding for my patients, those codes are entered into the medical record for my patients. I rely on professional coders then to be finishing off the project, even though I sign off on them. The language in this bill would make it's very confusing. It's very ambiguous. And I'm not sure if that would fly. Every practice would be at risk because there would be a conflict. So that would be one thing. I look forward to working with the committee to refine the language of Section 2, but to ensure protections of clinical decision-making. But I also urge the committee to revisit the proposed Section 1. And I really mean it when I say that Senate Bill 1507 needs to be amended at the very least to remove Section 1 and refine Section 2, because it'll be very detrimental to care in Connecticut. More than happy to answer any question that I can to help out with anything related to these issues.
Thank you. Some of the bills that we have right now, we have about 300 some bills, but we are working on a number of ways to have open conversations on these topics. This bill is targeted and focused to do something about private equity, but with the prime focus being the hospitals. That's where we are seeing the biggest damage that's been done. Outside of the hospitals, the other damage that was done in radiology world, where we actually had decimation of radiology by private equity. The minority share in MSO agreements is where we have seen this work. We had this conversation last year when we had the bill, and I made a statement that everybody's having a honeymoon period with private equity, and sooner or later, the physicians who are working with private equity, they'll see the reality. But it turns out the women's health in the state of Connecticut, the largest group, is managed by private equity. The oncology groups, the orthopedic groups are managed by private equity. But as long as it's a minority share, that's where they are not interfering with the medical care. I have at least heard from individuals like you that it does work. But for the hospital side and for radiology, it has been a disaster for our state. It's almost traumatic to even talk about. If you can speak about the radiology part, because that's also ownership model.
Well, I totally agree with you. I think, in our case, the reason private equity has worked, and we've been at it now for almost 6 years. If anything, we've expanded our services in the state. We've hired new doctors in the state. It took me, I'm in southeastern Connecticut, and we could not hire doctors. We've not been able to hire doctors for probably 6-7 years. We've been able to hire 2 doctors last year. So as far as ownership model is concerned, if it's a total ownership model, it becomes an issue. But once you have, just like you mentioned, the minority stakeholder model, and the private equity has aligned vision in delivering cutting edge care in the community, expanding care, I think you'll never go wrong, as long as the decision making, again, is done at the local level by the physicians. You cannot have a third party dictating anything like that. But without private equity backed MSO or our MSO that we have, we would be in trouble, I would say, during COVID. We would have been in trouble with our health insurance rates skyrocketing. We would be in trouble with the supplies. We could not get supplies during COVID if we were on our own. So I think when you think about each and every one of these models, you have to really look at it that we should not really lump all of them together. We have to really refine this model approach. And somebody was mentioning about doctors having to see X number of patients and doing this. I welcome anybody to come to my practice. Talk to anybody, any of the doctors, any of the APRNs, or anyone that we have who's in clinical capacity. And you'll see we have none of these things. So I don't know where those things are coming from, number one. Having said that, I've heard that in hospital systems, more so than anywhere else. So we need to really look at each and every aspect of these bills closely and carefully and refine them. The worst thing we can do is we cause such a havoc of delivery of care in Connecticut by putting so many constraints on private practices that we are not able to deliver care. and we have to go to one of the networks, further escalating cost of care. And I think that will be terrible.
Thank you so much, Representative Claire DeCitro.
Thank you, Mr. Chair. Thank you for being here today, and thank you for doing what you do in your practice. And I apologize if somebody already asked you this question while I ran outside. As far as your MSO model, how can you compare it? How is it different from what we heard about what happened with Prospect?
It's very different. Prospect model was a full ownership model, as I understand it. Our model is not an ownership model. Our practice is still independent private practice. We have a management services organization that provides us with the business, technology, buying infrastructure that we would not have as a small practice. So that's the big difference. All the decision-making, clinical decision-making is all made at a local level by our practice. Physicians are still in charge. The private equity based MSO is not in charge of our practice.
Okay, thank you. And then my second question, and then how does your practice compare to the services that you could get at a hospital?
That's a great question. I'm the only, we have a hospital practice, hospital-based practice in Norwich. That does not do all the things that my practice does, which is doing cutting-edge clinical trials, including doing these bispecific antibodies, etc. And that is a hospital-based practice. And we were the first ones in the world, like I said, opening up a clinical trial on a vaccine for lung cancer, and we'll keep on opening them. So I don't want to be stopped in doing what I do. I just want refinement in what is being suggested.
Yes, thank you for those answers, and I appreciate you being here today and answering my questions.
Thank you very much.
Thank you, Mr. Chair.
Thank you.
Thank you.
Non-small cell, small cell,
This is for non-small cell.
non-small cell.
This one is for non-small cell.
Adeno?
This is for adeno and squamous both. The vaccine is tailor-made for the patient.
Yeah.
And then it is infused into the patient.
Thank you so much for your testimony. Just need to get a little clinical tidbit here.
Absolutely. Anytime. Thank you very much.
All right. Thank you for your testimony. Next person is Cara Delaney. Welcome. Thank you for being here with us during the morning and the afternoon and the evening and night as well.
It's been great.
Thank you. Welcome.
All right. Senator Anwar, Representative McCarthy-Vahey, and distinguished members of the Public Health Committee. I am Dr. Cara Delaney and a board-certified OBGYN working in Farmington, Connecticut. I am here to represent both the American College of Obstetricians and Gynecologists, which is ACOG, and to share my own story in strong support of HB 7213, an act concerning access to reproductive health care. Thank you for the opportunity. ACOG recognizes the unique healthcare needs of adolescents and the importance of fostering their health and well-being during this amazing and critical development period. OBGYNs play a vital role in promoting practices that protect adolescents' vulnerability and support their development of autonomy. ACOG strongly advises that adolescents receive confidential care. Confidentiality encourages adolescents to access necessary care and promotes open communication about sensitive topics and behaviors that can substantially affect their health. ACOG aims to foster shared decision-making among adolescent patients, their parents or guardians, and physicians. ACOG recognizes the importance of teens having safe, trusting relationships with their parents and guardians. However, it is also acknowledged that this is not always the reality. Even when a parent or a guardian is involved in the decision-making process, ACOG recommends that OBGYNs emphasize the importance of confidentiality with their patients. To reflect ACOG's stance, I want to share the story of Sarah, which is a pseudonym, a 16-year-old who came into my clinic. She was nervous and scared, and at first she was very evasive. But I spoke to her about the confidential treatment that she could receive, and she ended up sharing that she was sexually active with her boyfriend and wanted to talk about birth control. She lived with her parents, but didn't want to tell them that she was starting to have sex because she was a little bit scared of how they would react. And I spoke to her about testing, about consent, about safety around sex. I encouraged her to communicate with her parents and even talked about how that could happen. Before starting birth control pills, I discussed the risk benefits, how to take them, when to call the office for questions. And I had really close follow-up with her. And 6 months later, she spoke to her parents about starting the birth control pills to prevent pregnancy. And her mom came with her to a future visit to support her. And Sarah's story highlights the importance of creating trust between adolescents and their healthcare providers to provide the best care. ACOG is committed to being a trusted partner to young patients as they navigate their reproductive healthcare needs. And ACOG strongly supports legislative efforts aimed at promoting optimal healthcare for adolescents, including the ability of adolescents to consent to the full scope of critical pregnancy care and contraceptive care. So we applaud and encourage the passage of HB 7213. And thank you for your time.
Thank you so much, Dr. Delaney, for your testimony and being with us. So you heard our conversation. You've been here listening to a lot of aspects. We do not have any OBGYN in any of those school-based healthcare centers. And you're dependent on perhaps a pediatrician or an APRN or a social worker in the picture who are interacting with our students. How can those interactions be in such a manner where we are providing them the care that they need, but giving them the opportunity to explore communication with their family members?
I think really it's the part about creating a trusting relationship with any adult. And that could be the person in the health center. It could also be a guidance counselor or a teacher. And one of the things that I personally talk to my teenage patients about is who are those trusted people around them. Because frankly, I see 30 patients a day. And so I do, and people share with me things that they have never told anyone. And it may not be the first time that I meet them that happens. It may be the third time, but that's because of the environment that is created. And I think that in these trusted adults, including parents too, and that's like a focus that I talk to my young patients about. That having that type of environment allows adolescents to share things in their lives that they might feel, embarrassed or shamed about, or also there might be a lot of like cultural stigma about, and just keeping an open mind and a listening ear is really important.
That's helpful. Of course, I'd like to believe that the OBGYN in this arena have far more training and understanding to be able to have those communications. We were just having this conversation earlier about how can we make sure that some of these places with the pressure of time are just not writing prescriptions, but actually doing a little bit more than that, talking about sexually transmitted diseases, because they may be the first point of contact for the young person who's seeking healthcare. And we don't even know if they may have underlying other medical issues. So while we want to have their confidentiality protected, we want to have an opportunity to look at the rest of their health, rest of the risks associated with various exposures, sexually transmitted diseases, and also communication with the family. So that's one of the areas that we're just exploring to see if we have an opportunity to do better as collective, as we do more support to our children.
Yeah, and I want to make a comment around that. Is that I'm an obstetrician gynecologist, and so I do have that expertise. But people who work in student-based health centers also have an expertise in working with adolescents, and so in a lot of ways they see and work with adolescents way more than I do, and so understand, feeling, feeling like, more training could be had. And I'm always, and I am always for that. I went into medicine because of the opportunities for lifelong learning. And many people do. And I have many close colleagues that are in adolescent medicine, and they do some of the strongest and hardest work. And so I find that, I would trust people who go to student health centers and who get care there.
Thank you. Seeing no other questions or comments, we want to thank you for being here. Thank you for your testimony.
Thank you
And
so
thank you
much.
for the work you do. That brings us to Joan Cruz. Is Joan Cruz here?
Yes, I'm right here.
Oh,
Sorry if
good.
my camera is not working.
Welcome. Please go ahead.
Thank you. Good evening, Chair and members of the Public Health Committee. My name is Joan Cruz. I am a resident of the city of Hartford. I'm also a staff member of the Hispanic Health Council, which is the largest Hispanic Latino organization in the state of Connecticut. For over 40 years, the Hispanic Health Council has been a pillar in serving communities through various programs, including maternal and child health services, to ensure birthing people have access to quality health care services. I do appreciate the opportunity to allow me to testify in support of House Bill 7214, an act concerning maternal health. As you have heard throughout the day, many people of color face disproportionately high health risks during childbirth. To address this, HB 7214 introduces the Connecticut Maternal Health Report Card, a system that will track and report maternity care outcomes at hospitals and birthing centers. The collected data will be made available to the public, and this will help hospitals identify disparities, improve care practices, and promote transparency in maternal health. Although I had a fair labor and delivery experience, it would have been better or good for me to have access to a report card back in the days, just to see what the hospital performance was at that time. But that was many years ago, and we have made a good progress thus far. Fast forward to today, that I have the opportunity to testify, I want to do so for the benefit of the current and future generations, and as a future grandmother, and as a community member who wants the best for the community. I do believe that just as we read reviews before purchasing a product, visiting a restaurant, or booking a vacation destination, it would be invaluable for birthing individuals to have access to a report card. This would empower them to make informed decisions about their childbirth experience. This bill is a vital step toward reducing maternal mortality and childbirth complications. It holds hospitals and healthcare providers accountable for ensuring that all birthing individuals, regardless of race, receive high-quality trauma-free care during childbirth. By requiring healthcare facilities to assess and adjust their policies and practices, the bill aims to eliminate unnecessary risk and ensure that people can give birth safely and return home with their newborns. I believe that we all can work together to enable birthing individuals to thrive in Connecticut and give their children their life they deserve. Therefore, I urge this committee to vote for HB 7214. Thank you.
Thank you so much for your testimony. And
You're welcome.
seeing no questions or comments, thank you again. And we'll go to Lisa Freeman. Sorry we missed you, Lisa. Sorry about that. Thank you for being with us all morning, afternoon, evening, and night.
I wouldn't have missed it.
Thank you.
Senator Anwar, members of the committee, my name is Lisa Freeman. I'm the Executive Director of the Connecticut Center for Patient Safety. I want to start with what are medical records? They're notes, films, diagnostic studies, everything, and they're created to enhance communication, to create transparency, and to memorialize patient care. Patient records of their health care, created by medical professionals for medical professionals. They are in a language that is foreign to patients and known excuse me, known to healthcare professionals. When a patient requests copies of their medical records, they're often not all-inclusive. As patients, we are not certain what we are to expect in the deliverable, and there's often a trust that healthcare and patients have the same purpose in mind. Patients don't know what they don't know. It's often appropriate and necessary to have an attorney request the records on behalf of their client, who's the patient. They are acting, these attorneys, as an extension of the patient. They're not a third party. They are specifically looking at something for a purpose that the patient has asked them to do. When the outcome of care has not been what was expected, patients may look to a more knowledgeable, qualified person than themselves to review the records for answers, the why, the how. This may be an attorney or other hired professional. They are a direct extension of the patient, and any fee that they are charged will be passed on to their client. Charging a higher fee only interferes with patient access and understanding to and of their medical records. That should not be the end goal. I want to mention that in New Hampshire, they just passed a medical records bill where there is a $50 cap on medical records and 30 cents a page after 50 pages. My husband experienced very serious medical harm. Our requests of the medical records were often incomplete, and it was frustrating. Even our attorneys had difficulty getting a complete copy of everything, and they knew what they were doing and what they were looking for. I too have received partial records of my healthcare in another instance, and records are sometimes blocked by a paywall that the patients can't afford. So as the executive director of the Connecticut Center for Patient Safety, I have spoken to numerous people around Connecticut who tell me of these same obstacles and delays in obtaining their records. This is not what should be happening. Systems don't have the right to claim that they are patient-centered if they are not doing everything in their power to give patients the information that they need to fully engage in their care. Complete and reasonably priced medical records, following the lead of HIPAA at the federal level, is a fundamental piece of that.
Excuse me, Ms. Freeman, but you've reached your 3 minutes. Thank you.
You're quite welcome. I was just about to thank you for listening to what I had to say.
Thank you. Thank you for being here with us. A quick question. So what you're saying and proposing is that, if somebody's in the ICU for a week, you can easily have about 3,000 pages of documents. So you're saying that for 3,000 pages of those documents, $50 is the cap, 50?
That's what I have been led to understand, yes.
That would be interesting situation.
It's also a difference of, I remember at one point I was going for some physical therapy care, and I asked for a copy of the medical records. And, a few days later, they gave me an envelope with pages of paper in it, and I was being charged, I believe, 65 cents a page at that point. Some of the pages only had 2 inches of writing on them, because when we're using electronic data collection for the medical records, I have to guess that each item prints out as its own page. So it's not like in the old days when a page just went on and on and on. Each entry might very well create a page. So I don't think that the pages are necessarily calculated the same way as they were. But the point is that, the federal law says that it should be based upon the true cost. And that's, I guess, reasonable, but the cost of a disc is $5 and change. So, and it can't include the cost of time, because that's built into other things.
Thank you, Representative Carpino.
Thank you, Mr. Chairman. I have a few questions. I've been on both sides of this. I've requested these records professionally, and as a patient, I've needed to access records. So I want to dive a little bit deeper to understand. I've heard this conversation a few times over the years. And I guess I keep hoping that we can find a fair way for a patient and their advocates to get these records. And I don't think we've seen one here in this building yet. Otherwise, probably would have passed the bill. So is there just a couple of follow-ups though to what you said? Do you think there's a difference when accessing records that might still be in paper? Because many of our providers, if you have, seen a provider for years over time, paper files still exist. Do you think there should be a difference if you're accessing paper files versus electronic files? That's my first question.
No. I think that my understanding is though that the providers, the clinicians are being given a lot of encouragement in terms of the rulings and everything else to go on electric health records. Patients are entitled now to have portals that they can access. That's at least the beginning of it. It's certainly not a complete record, but I think we're in a day and age where I can say of all the physicians that I see, that my family members see, one was still connected with paper. And I would think that the total that I'm talking about is probably in the 20s.
And I think, and I think that's fair. And I'm not a medical provider, but I know for some of us who have long medical histories, we might have treated with a provider that kept paper files at one point. And I don't know if everything has been transitioned to electronic files, which is why I asked.
Yeah,
Somebody could have a significant file that has not been digitized. And I know at least as recently as last month, my physical therapist asked me to come in and circle those little numbers. How are you feeling today? What is your activity level? And that's a piece of paper.
But those papers do, I believe, get scanned in now.
Sure.
So it is more computerized. And, I think we're going to have exceptions in terms of paper records or electronic records, but we are clearly moving into a period where all information everywhere is becoming electronic. And what, I owned a computer store years and years ago. It's in my previous life. And I remember telling people, yeah, it takes a long time to enter the information, but when you need to retrieve it, it's a whole lot faster because you can create queries and everything else. That is the case. So while there's always going to be time involved, I can't imagine that it's not significantly less time than it used to be. And I think some of the other arguments that were put forward earlier didn't seem to weigh in as anything significant for my thinking.
I don't disagree with you. I think we're going to see less and less paper files,
Yeah.
but when we pass laws in this building, it's sometimes some of those exceptions get lost and it's our job to flush them out before we pass the law. So my other question to you is, do you think there should be a difference when somebody is asking for the same records multiple times?
It depends who the somebody is.
So specifically, if a patient asks for it multiple times, or the options being the patient asks and then their lawyer or their multiple lawyers ask for the same records, how do you think those should be handled?
Okay, I think that the patient should always have access to their records, and life interferes with things sometimes. So I mean, like the dog ate the kid's homework.
So the dog really does eat my papers, so that is
Okay,
valid.
I was just gonna say, my dog
She's a
really
puppy.
did. Yeah, my dog really did eat some important papers once. So, I mean, there have to be allowances. I'm sure that's not the vast majority of the situation. As far as professionals, I mean, I don't believe that my husband's situation did lead to a medical malpractice situation, and it was a complex one. I don't believe that the professionals and the attorneys who were requesting the information asked more than once. They had to go back a few times to get the records because they weren't complete for them also. But it was one complete volume that they obtained ultimately.
Sure, and that sounds very reasonably. I'm asking again, because when we pass a bill, we really do try to explore all the options. So if, I don't want to jinx any of us, but something happens to one of us on their way home, there's extensive medical records, somebody obtains counsel to grab those records, it's addressed. 5 years later, something else happens. Those same records need to be retrieved by a different attorney representing the same party. That same doctor who admittedly is overworked and underpaid, at least in the state of Connecticut, has to provide those records again. How should we handle that second request for those same records by this coming from the same physician's office?
I think that in that case, I would have to say that each situation is separate. If I'm hiring an attorney to represent me, then just to make sure that the records are as pure or as original as possible and everything else, it's necessary to get the original copy from the source. I would not expect them to take a copy of records from even another, attorney or even the same attorney from years before, because things happen over time. So, and you couldn't necessarily trust the completeness of the records 5 years later, 10 years later. I think you have to allow for things like that.
No, and I thank you, and I thank you for answering my questions. I think the reasonable cost is a good bit of legislation that came out of Washington. Some of their other legislation as of late, I won't comment on. But the reasonable cost, I think, changes over time. A reasonable cost also takes into account, at least by my perspective, is the equipment needed to do so, as well as the staffing needed to generate that. So I appreciate you talking me through some of these, because like I said, when we pass a bill, it is for all situations, and we just want to make sure that we explore them all. Thank you very much.
I just want to say, I do think that the time that the entity that is putting together the records, the person's time is not allowed to be billed for, is my understanding.
I understand that. As we're talking about reasonable costs and the demands on the providers, I just want to make sure that we recognize that. I thank you for your patience, and Mr. Chairman, I thank you for letting me explore those scenarios.
Thank you so much. Seeing no other questions or comments, we thank you for being here with us today.
Thank you very much.
Next person on our list is number 54, Arissa Marshall, on the computer as Rai Marshall. Hey, Ray, how are you, Ray? Good to see you.
Hi, everyone. Can you hear me okay?
Very well.
Okay, wonderful. Dear Co-Chair Senator Anwar and Representative McCarthy-Vahey and esteemed members of the Public Health Committee, my name is Ray Marshall and I live in New Haven. As a graduate student at the Yale Schools of Public Health and Management, I study health policy and research community health centers as crucial entry points to healthcare for underserved populations. I'm here today in strong support of HB 1507, which prohibits private equity ownership of certain healthcare institutions and interference in clinical decision making. Additionally, like others who've testified today, I propose the inclusion of an amendment banning non-compete clauses for physicians in Section 2D. Private equity plays a role in many industries, bringing investment and operational efficiency. However, its financial model, which is focused on maximizing returns within a short time frame, often conflicts with the long-term stability and patient-centered mission of healthcare institutions. By nature, private equity firms prioritize financial gains, often through leveraged buyouts, dividend extractions, and underinvestment in critical clinical infrastructure. This can lead to a decline in the quality of care and jeopardize patient safety. As we know, Prospect Medical Holdings acquired Manchester Memorial, Rockville General, and Waterbury Hospital in 2016, and within 1 year, staffed beds at Manchester and Rockville dropped from 354 to 181. At Waterbury, physician staffing declined by nearly 20% over 5 years, and according to an HHS report, these cuts led to longer wait times, fewer services, and worse health outcomes for patients. The decline in care was compounded by serious safety violations, with federal and state inspectors citing multiple condition-level deficiencies. In 2018, for example, Manchester Memorial received an immediate jeopardy citation, the highest level of violation after failing to provide adequate care. Rockville General and Waterbury Hospital also face citations for not meeting basic operational and safety standards. Connecticut is not alone in facing the risks of private equity in healthcare, and other states are taking action to increase oversight. Massachusetts House Bill 5159, which was signed into law in January 2024, which I know others have mentioned today, expands healthcare transaction notice requirements, mandates greater financial transparency for private equity firms, and strengthens regulatory oversight. A critical amendment to HB 1507 is needed to prohibit restrictive non-compete agreements in private equity-owned healthcare settings. When physicians leave workplaces due to unsustainable conditions or ethical concerns, they're often barred from practicing in the same region, therefore disrupting continuity of care and worsening provider shortages. Eliminating non-compete clauses will protect physician autonomy, prevent private equity firms from using legal loopholes to control the workforce, and ensure patients can continue seeing the doctors that they trust. Private equity brings a financial model that often conflicts with the core mission of healthcare. Hospitals and physician groups are not typical businesses. They're essential services where cost-cutting and short-term financial strategies can have direct consequences for patients.
Excuse me, Ms. Marshall, but you've reached your 3 minutes. Thank you.
Thank you.
Thank you, Ray. Do you want to finish your sentence?
I had one sentence left, and it was really just to thank you and say that 1507 is necessary to ensure that medical decision-making is guided by expertise and community needs.
Thank you. In your research, have you seen the situation where the model that we were talking about for the outpatient setting with the MSO model, were you able to look into that?
I have done a little bit of research on it. There's a lot less research that compared to hospitals, but I have that in the Just Facts section of my written testimony, which I submitted 20 minutes ago, so I'm not sure is up online yet.
Okay, we'll check on this and we'll talk offline too. Thank you so much for
Sounds
your
great.
testimony and your work.
Thank you.
That brings us to number 56, Dr. Marian McDonald. Welcome. Thank you for being with us during the day and the evening and night. If you can press the button in front of you, the other one, there, and you can turn the other one off. Perfect. You're on.
All right, great. Thank you. Thank you. Thank you, Senator Anwar and Representative McCarthy-Vahey, and the members of the Committee of Public Health. And I wish to speak to you today in support of House Bill 7213. As an OBGYN in practice in Connecticut for more than 30 years, I know very well the importance of being able to obtain timely and comprehensive consent to care in ensuring the best possible outcomes for my pregnant patients. This includes teen pregnant patients. According to the American College of Obstetricians and Gynecologists, confidential care for adolescents is important because it encourages access to care and increases discussions about sensitive topics and behaviors that may substantially affect their health and well-being. As of 2022, Connecticut is one of only 12 states that does not have a law addressing minors' consent for prenatal care. I would like to share 2 patient stories that exemplify the need for pregnant teens to be able to give their own consent. The first is a patient who, although she had the support of her parents, she was not always able to bring them with her to all of her appointments or to the lab when she went for routine lab testing. Since a parent was not able to sign for consent at the lab, she ended up not being able to have the very important routine prenatal lab testing done. These labs are important to screen for and prevent significant complications to the pregnant person and their neonate, including diabetes of pregnancy, anemia, and congenital syphilis, to name but a few. ACOG advocates for privacy and the ability of adolescents to consent to healthcare procedures. While most young people involve their parents in their healthcare decisions, government mandates are ill-advised and can stigmatize and deter young women from seeking safe care. The second patient presented bleeding and in pain in early pregnancy, not having yet told her parents that she was sexually active. She was found to have an ectopic, also known as a tubal pregnancy. In the case of this patient, she needed emergency surgery to treat this condition to save her life. However, she could not sign the consent for anesthesia to have the surgery without getting consent from her parent. In an emergency, during a pregnancy especially, every moment counts. Adolescents in these situations must be able to consent to critical pregnancy care. For these and other patients, I respectfully request that you pass HB 7213. Thank you.
Thank you so much, Dr. McDonald. Thank you for the work that you do every day as well. And so in the scenario that you've talked about, just for the sake of argument, if it's an emergency and the parents are not available, one would operate in any case.
I believe the situation was that it wasn't at that moment life-threatening, and so the anesthesiologist felt that they couldn't go ahead. Yes, if it had been she was in extremis or something like that, I'm sure there wouldn't have been a delay. But she was stable, but she needed to have the surgery.
Right. And you've looked at the different arguments that many of us have been making back and forth on this issue. Anything else you want to add to your testimony?
I'm not sure what the question is.
It's an open-ended question. Anything else you
Okay.
want to add?
Not at the moment. Thank you.
Okay. Well, thank you so much for all that you do and appreciate your insight. We really look forward to working with you and ACOG about some of the things going forward.
Thank you.
Thank you. And that brings us to next person on our list, Dr. Joseph Kappa. Welcome. It's like all these doctors you have to wait for months to get an appointment are waiting for us. It's just like, that's why we are taking
Yes,
our time.
I'm feeling like a little regular here but thank you again for allowing me to come in and testify on this bill, SB 1507. Good evening. My name is Dr. Joe Kappa. It's good to be with you again. I'm a board certified gastroenterologist, caring for patients in our great state since 1993. I'm chairman of my practice, Connecticut GI, where we take care of tens of thousands of patients each year. We are an independent physician practice, and our patients extend throughout the entire state in all four corners. I'm testifying today against SB 1507 because this bill, more than any bill that I've seen in the last 2 years, really poses an existential threat to the continued existence of independent practices like mine. Section 1 would place a moratorium on private and public investment in healthcare, which will ultimately result in less access to patients for patients and higher healthcare costs. The overly expansive definition of private equity in Section 1 would prohibit most forms of outside capital in healthcare. The moratorium on future investment would ultimately lead to independent practices selling to hospitals, and this is exactly opposite of what the state needs. Many independent practices face insurmountable financial challenges due to high overhead costs and declining reimbursements. And these external investments really help stabilize these practices and prevent closures, especially in rural and low-income areas where access to healthcare is limited. Section 1's blanket moratorium on private and public company investment would sacrifice opportunities to expand access to high-quality, lower-cost care centers for patients. I agree, we need to prevent disasters like Prospect from happening again, but we need to take a more measured approach in letting healthcare providers access the capital needed to grow and maintain their practices. And Senator Anwar, you acknowledged at the last hearing in this committee that we don't want to slow down healthcare in our state, but Section 1's ban on these partnerships will accelerate consolidation by hospitals and lead to exactly what we're trying to avoid. At least HB 6873, even with its flaws, gave physicians the option to remain independent. This bill will just shut us down. But I'd like to comment briefly on Section 2 of SB 1507. It is important for you to know that we do not give up our clinical autonomy when partnering with an MSO. Our MSO partners have absolutely no say in the treatment decisions we make or in any other way we care for our patient. Those are our decisions alone. It's because of these MSO partnerships safeguard our clinical autonomy that I decided to stay in independent practice. And I agree with the Section 2 in concept, but there are parts that are vague and a little too broad. For example, we don't understand what it means to be, say, indirectly interfere or indirectly control clinical decision-making. But I hope that we can work together to make some limited but important revisions to Section 2 that will protect physicians' clinical autonomy without undermining appropriate appropriate business support for our practice. In closing, when I was with you 2 weeks ago, this committee spoke of a future in which partnerships like mine could be preserved. Section 1 of SB 1507 directly contradicts that vision. And if this bill passes as written, it will end up really reducing access to care at a time when the people of Connecticut really need non-hospital options more than ever. So please, we're urging to vote no on Bill 1507 unless Section 1 is removed and Section 2 is amended. Thank you.
Thank you so much for your testimony. We appreciate your insight as well. And as we had spoken about a couple of weeks ago, the more interactions we've had with many of the clinicians, we are looking at the hospitals requiring, at least I'm speaking for myself, requiring significant restrictions for private equity, but the outpatient settings and a minority role for MSO would still be appropriate and relatively safe at this point. So we hear you loud and clear, and many of your colleagues as well.
Right. I just returned yesterday from New Orleans, the American College of Gastroenterology Practice Management Committee. And over the last 25 years, I've served on the committee, and we've seen the shift of physicians moving away from private independent practices to hospitals. And just like you heard in the testimony today, many of these hospital systems are costly. They can't keep their doctors. Access is difficult, and it's leading to a lot of people that are leaving. And we're concerned with a bill like this. If we move more towards hospitals, people will leave private practice and either retire early or leave the state, which could generate some access issues that we're concerned about.
We hear you. I have one of my colleagues has a question. Representative Claridis Dietrich.
Thank you, Mr. Chair. Thank you for being here today with us. With your practice, if this bill got rid of MSOs and or practices like yours, can you just give us an example, if you can, the difference between the cost of being in an independent practice for a procedure going to a hospital?
Sure. Thank you for answering that question. And a little bit of a plug for the month of March, which is Colon Cancer Awareness Month. And it's a very important month that we're now realizing that younger and younger people are getting higher risk for colon cancer. And being able to offer these services in an outpatient facility in Putnam, Sharon, Connecticut, and in those areas where we're not bringing people to the main hospital systems. As I testified 2 weeks ago, the Alvalier study showed some of the difference in the Medicare population. But when it comes to an actual colonoscopy itself, and I've been a recipient of a few of them, and I've had to have, unfortunately, one at the hospital and one in an ambulatory center, and the price difference can be 2 or 3 times the cost. Not to say that the hospital systems may be necessary in certain cases, but if we really want to bring bring care to the common level of bringing people in, these ambulatory surgical centers or outpatient facilities offer a higher value, high quality, low cost system. So that's an example where I could use it.
Thank you. I appreciate it. And we know, and probably some of us have been to these ambulatory surgical centers. And if you fit the criteria, then you're fortunate enough to be able to save a lot of money going to an ambulatory surgery. I know I went to one when I had my hip replaced, and I was home that same day versus going to the hospital, where my mother, who at the time was 85 years old, had to stay in the hospital for 3 days because of her health concerns.
And we saw the example today clearly when it came to orthopedics or oncology or now even GI, the ability to work as physicians, do what we are most passionate about, delivering healthcare at the highest quality, lowest cost, but have a system outside where our administrative duties are being taken care of so we can function medicine in a way in the 21st century to kind of bring it forward.
Thank you. And I hope moving this bill forward, if it does go forward, that we're able to carve that out, because
thank you.
As you said, we will be restricting access to people in the state of Connecticut. And that's the opposite of what we want. We want to protect them, but we want to make sure we have plenty of access for everybody. Thank you.
Thank you,
Mr. Chair.
Thank you. So 45 years of age now for colon cancer screening.
Age 45, that is correct.
50 no longer exists, 45. Just saying.
45 is the new 50.
Yes. All right. We saved some lives just by this last sentence. Thank you so much. Thank you.
Thank you. Fine. Thank you very much.
Thank you. The next person on our list is Melanie Wildlane. Welcome. Thank you for being here with us. You're on.
Thank you so much. Senator Anwar, Representative McCarthy Vahey, and members of the Public Health Committee. My name is Melanie Wild Lane. I'm the Executive Director of the Connecticut Association of School-Based Health Centers. We're a statewide nonprofit sponsoring 343 school-based health centers throughout the state. We support them through advocacy, education, and networking opportunities. On behalf of CASBAC, we want to support part of this raised bill 7213 to ensure that the legal language surrounding youth reproductive health care is clarified under the current practice. Connecticut law explicitly allows minors to receive emergency medical treatment, HIV testing, mental health services, abortions, and STI testing without parental consent. Connecticut law does not expressly permit minors to access contraception or consent to pregnancy testing. However, because no Connecticut state statute explicitly permits minors to access these services, each provider must make a business decision as to whether it will provide minors access to such services without the consent of their parents. The lack of clarity can cause conflict. Minor consent in healthcare is crucial for empowering adolescents to take charge of their health and well-being. It ensures that young people have access to necessary medical services without fear of judgment or breach of confidentiality. This is vital for fostering open communication between healthcare providers and minors. By allowing minors to consent to their healthcare, we promote responsible decision-making and support their autonomy, ultimately leading to better health outcomes. Connecticut's medical providers deserve this legal clarification when providing contraception and pregnancy testing to adolescents. We need laws to support our providers in delivering quality health care for adolescents. School-based health centers empower adolescents to manage their health. This provision is critical as it allows youth to access preventative pregnancy measures in a safe environment provided by reliable and trustworthy providers. Young people in Connecticut often turn to our school-based health centers for information on these critical preventative services and counseling to reduce risky behaviors. We want to encourage our providers to continue delivering reproductive services and not hinder or question the legality of what they're currently doing. This bill will allow minors to receive reproductive health care, including pregnancy testing and contraception, with counseling in our healthcare organizations and our school-based health centers without parental permission. Another key piece of this bill is that it allows these visits to be labeled confidential. Therefore, insurance companies will not send an EOB home for these services. By ensuring confidentiality and removing parental consent, this bill could significantly increase minors' access to necessary reproductive health care services. Adolescents may feel more comfortable seeking medical advice and services knowing their privacy is protected. Furthermore, this bill will allow school-based health centers and healthcare organizations to make these visits non-billable, free. This places another layer of confidentiality in place. The EHR, electronic health record, will indicate that this is a confidential service. It won't be billed. There will be no EOB sent home.
Excuse me, Ms. Lane, but you've reached your 3 minutes. Thank you.
Sure. So in summary, the minor consent law already allows access to sexual and reproductive health in other areas. In this case, we need to enable students to receive all reproductive services and counseling to protect students from potential pregnancies. So I'll stop there.
Thank you so much for your testimony. Thank you for being with us. You're about talking about the EOB. So the EOB would be a blank EOB that would come to the parents?
It would not be there would not be an EOB because that service at the school, at least at the school-based health center, and Tricia will talk a little bit about what happens at the sponsoring healthcare agencies, will be marked confidential. And so no EOB will go home. Currently Medicaid, as you know, there's no EOB sent home for any services. So this just levels the playing field.
But let's say if there's insurance, then somebody is going to see some money going somewhere. You guys will get paid.
This bill makes this service confidential and non-billable, like the other minor consent law does.
So it's free?
So it's free.
It is free. Can people in the community get it too?
I will not make a comment on that.
Sorry.
You can add that to this bill, I'm sure.
My co-chair has a question or comment.
Sure. Thank you, Mr. Chair. Melanie, thank you for being here with us and for sticking with this issue, which is admittedly a difficult conversation and has been throughout the course of the day, as you know. So I just want to talk a little bit about the conversations that we've had here that you've probably heard throughout the course of the day about what kinds of conversations happen in the healthcare setting with young people who are seeking these services and how that works in terms of training. I would imagine, I'll just, put out there, my sense as a social worker who previously practiced, that the range of experience and training and practice is all across the board. But what is the general practice, and what would you say the training is for having these kinds of conversations?
Yeah, so in the school-based health center world, our APRNs and our PAs are specifically chosen for this population, right? We know that there are no parents on site for the majority of the kids that we service. And some are difficult to get a hold of. And so there's that barrier. And so they follow all of the training guidelines as any pediatric provider would, but they are enhanced. So our oversight or our sponsoring organizations ensure that our school-based providers are trained in having those difficult conversations. An added layer to that is the association hosts lunch and learns, what we call think tanks, open discussions, as well as an annual conference. Part of those learning opportunities are trainings for specifically those conversations. And so we'll have a November 11th conference. We'll have a series of lunch and learns. We have a think tank coming up on the topic. And so those are learning opportunities for our providers as well, to ensure that they have the most up-to-date training on having those difficult conversations, not just with the youth that they service, but also with their families, and then encouraging those students to have those difficult conversations. Sometimes that means lengthy, right, multiple meetings with that student in order to get them ready to have that conversation with the parents or their caregivers.
Thank you for that. I think I'm generalizing here, but as a practitioner in general, and this is what we heard earlier today, the hope is always to connect a young person first with their parent or guardian, if that's the right person, which the majority of the time, far and away, it is. And if not, with a trusted adult. So I think, I know that there will be more conversation around this issue, but I just want to take that opportunity to underscore that and to emphasize that is the best practice. That's literally the best practice and what the goal is in going forward.
Thank you for that. Yes, you're absolutely 100% right. And it also helps that many of our medical sites, almost all of 99% of our medical sites have a mental health clinician that's on site as well. And so it's a team effort, right? It's not just one person, but it's a team of professionals. So they're either meeting with that student and family or meeting together, doing case reviews and talking about what is the best way to handle these situations. What's the best practice here? And sometimes that involves the school staff as well. They know them, they see them 6 hours a day, 180 days a year. And with consent from the child, if that's the trusted adult, they pull those folks in as well. So it is a team effort. It's not a unilateral decision. And we're definitely not just saying, hey, we know that you're 14 years old and there's the potential for you being sexually active. Here's contraception, go out. That's not what happened. It is a long process. So kids just can't come in and say, I want contraception, and there's no conversation about it. There's absolutely 100% conversation, probably more than they want.
I'm sure, as the parent of 3 children.
Planned Parenthood knows as well, right?
Yes, and I think that's actually one of the other points I wanted to bring up. We were hearing earlier from one of the providers about how many students are sexually active during high school years in particular. And I guess I would ask you, in your experience, how many students do you find are comfortable having conversations about their sexual activity with their parents?
So I've had the privilege of working with Rachel DeMarco, who you did hear from. She gave some great data. Having a 22-year-old who lives at home, who just came home from college, we just had this conversation upstairs. I can say that there is a significant population, and I won't put a number on it, of students who are uncomfortable having the conversation of sexuality, of their sexual activity with their parents. And they may be more likely to talk to their medical provider who sees them, routinely, and it's a confidential space. The hope is always that it gets to the parent, right? Before the contraception's given, before anything medically is done. So I know firsthand as a parent, it is an awkward conversation for your child to have with you, and vice versa. So I would say that Rachel probably nailed it with the statistics.
Thank you for that. We haven't talked a lot about that today, but I think that's the reality. I think a lot of parents are very uncomfortable talking about the issue of sex and sexuality, sexual activity. It's a difficult subject.
Well, we talked earlier too, and I think probably Gretchen would agree. I don't want to speak for her, but sorry, I don't want to throw you under the bus, but I think I think Gretchen would agree that by the time these kids get to us, they're already thinking about it, if not doing it. And so we're giving them the tools to not have an unwanted pregnancy, to not have to decide whether or not they want to keep the pregnancy or not. We're doing the preventative measures, and I think that's really important.
Thank you. I appreciate you underscoring that piece of prevention. So that exactly, we don't get to the point where they're having to have other conversations. I appreciate that. Thank you, Mr. Chair.
Thank you. I just wanted to make a comment. I've been speaking for Gretchen all day today.
Poor Gretchen should have left a long time ago.
Representative Kennedy.
Thank you, Mr. Chairman, and welcome, and thanks for staying here until almost 8:30 at night. You just touched on something that I wonder, because I don't think I heard anything about this today during everyone's testimony. And you talk about some of the things when a student comes to you. Do you also talk about STDs and anything of that nature? Because I've heard that brought up. We've talked about pregnancy and the whole bit, and I know a good portion of this bill focused on that. But what about practicing safe sex if they are in fact having safe?
So that's
talking about that.
Yeah, thank you for that. That's the primary focus when a child comes in and says, I want birth control. And then it's let's talk about this. Why? What's going on in your life right now? We also want to make sure that if you do make these decisions, that you're doing it safely. And so that we're grateful for the minor consent law that was passed, and that allows us to be able to provide STD testing. So if a child comes in and is sexually active and wants to have STI testing, they can in our school-based health centers, and it's confidential. And then along with that also comes the counseling aspect. We do a lot more talking than we do prescribing. And I think that's the misnomer, right? People are under the impression, and I use the term people generally, but are under the impression that a child can just come in and get the birth control pill. And that is not the case. It's probably more difficult than anything else that we do in our school-based health center.
Thank you for that. And I just have one other follow-up question. Sure. And so also, I think one of my colleagues might have asked this earlier, if a student comes to you and they find out they're pregnant, what's the general, because that was asked to somebody else and they weren't sure.
Absolutely.
Do you try to involve the parent unless the child is adamant they don't want the parent involved? How do you guide them at that point? Because timing certainly can be a lot. So if you can answer that.
So school-based health centers do not provide prenatal care. We refer out. And so within their local area, given their barriers to transportation and other things, We provide them a resource list. We will counsel them. We will walk through the resource list with them. It's ultimately up to them where they want to go and what services they want outside of our school-based health center. We do a lot of role playing with the student. We'll sit with the student as they make the call, but mainly we encourage them to have the conversation with their parent and get their parent or caregiver involved because nobody wants a 14-year-old to go at this alone, right? Or to go to a potential visit by themselves. We want them to go with a trusted adult. And we hope that that would be the parent or the caregiver. In some cases, it's not. But we spend a lot of time working through that process. It's not just, here's the resource list, you're on your own. We sit down with them and we go through every pro and con. We let them ask questions. We let them research. Well, if you don't have a laptop, we do. Let's pull it up. We want you to do your homework. Ask as many questions as you can. This visit can take multiple visits, right? It does not just have to be this 30-minute visit where we found out you were pregnant. It could be weeks that we continue to have these conversations. So there is a lot that goes into it. It's just not one-stop shop.
And I appreciate hearing that. Thank you. Because, my first thought is, they find out, they talk to you, and you want to make sure that you're going to follow them. And as you were saying, it's not always a parent that's involved in the situation. It could be a grandmother or an aunt or something. So there always isn't that parental figure there. So it's always important. But I just want to make sure also, and I think you just said it, that you just follow through, that the person doesn't kind of dodge you from that point forward. And all of a sudden, they're 4, 5, 6 months pregnant and still not knowing what to do. So thank you so much for answering my questions. I really
And
appreciate
just
it.
to add to that, I'm sorry, just to add to that, once they do go out for follow-up care, we also follow them as well, right? We want to make sure that we're talking with their providers so that we know what course of treatment they're getting. We're at least in the know of what's happening at school. We may not be able to share that with the school, but we do as a medical provider understand what's happening so that if anything happens at school, we make sure that we're giving the best, highest quality care to that child.
I appreciate that. Thank you so much. Thank you, Mr. Chairman.
Thank you. Representative Zupkus.
Thank you, Mr. Chair. Thank you for coming in. I mean, listen, I know when I was growing up, my mother never had conversations with me, and that was the last thing I was going to do, to talk to my mother about. However, I do talk to my girls about it and have very open and honest conversations. And hopefully if anything ever happened, we encourage them to talk to us, and not everybody is in that situation, but I really appreciate you, excuse me, encouraging talking about, the parent involvement, because as a parent, if your child went and something medically happened or went wrong, how would you even know? And that's a whole nother issue. Or how are you, if you don't know as a parent, how are you able to help talk to your child after the fact, before the fact, any of those things? So I appreciate your encouraging parental involvement, even though it may not always work, but encouraging it. So as new hires come in or people come in, is there a training that y'all go through to talk about that and encourage and following the child? It's so good to hear that, you don't just send the child off and they come back when they come. I mean, when I was in class, I knew a girl, she was there, all of a sudden she disappeared for a long, and then she came back and we all knew what happened. But anyway, so do you provide training to your staff about talking and encouraging about parental involvement and all of those things?
So the association itself isn't a service provider, but our sponsoring organizations do provide a lengthy training for all of their providers. And that training looks different in every organization. But we as the association supplement that training through, like I said, our annual conference, our lunch and learns, our think tanks throughout the year. So as topics arise and providers are saying we need more training, or we hear from organizations that are partnering organizations that this may need to be happening, we as the association provide that supplemental training. Providers are always encouraged by their sponsoring organizations to seek training outside of what the sponsoring organization does. All providers need continuing education and have to meet a certain number of hours per year. Dr. Anwar can probably tell us what those hours are, but there is a process in place for that. Mhm.
Thank you. And I do appreciate your comment when you first walked up is you don't support all the bill, but you support parts of it because a lot of people don't understand everything in the bill. So I appreciate you knowing that.
We do have amended testimony because initially we put fully support the bill. And then as we were listening, said, oops, let's amend that testimony very quickly and put that in writing because those are items that we do not, as a school-based health center, as an association, we don't provide those services and therefore it would be inappropriate for us to comment on it.
Right. Great. Thank you so much. Thank you, Mr. Chair.
Thank you. Thank you for your testimony and staying with us. It was worth it for us.
Thank you so much.
Thank you. Moving to the next person on our list, which is online, Deborah Cruz. Thank you, Ms. Cruz, for staying with us for the past many hours. You're on.
Hello, good evening, everyone. My name is Deborah Cruz. Good evening, cheers.
We cannot see you if you want to turn your camera on.
Yeah, thank you so much. Okay, right there. Can you guys see me right now?
Yes, we do. Thank you.
Okay, perfect. So good evening, chairs. I'm a member of the Public Health Committee. My name is Deborah Cruz, Deputy Program Officer at the Hispanic Health Council. I'm resident of Windsor, Connecticut. I'm testifying in support of HB 7214, an act of concerning maternal health. HB 7214 aims to tackle racial disparities in maternal health care. I am registered nurse by trade who came from another country here to practice. So I have seen firsthand in United States how many women of colors are facing higher health risk during childbirth and postpartum period as a mother and a grandmother too. I would like to see more transparency from the hospitals regarding data that is collected and currently identified but not made public. In addition, I would like my daughters and many women in Connecticut have the opportunity to obtain doula services. That is part of the bill. Hold it a second. Okay. Every pregnancy, as you might know, every pregnancy and childbirth is a different experience. And this involves multiple aspects of the person and the family supporting that mother during the childbirth experience. For me, I had the opportunity to be present during the childbirth of my grandson. And I was lucky enough to advocate for my daughter when the baby's heart rate dropped significantly. And the clinical staff really responded well during that event. Also, I was lucky enough to have coworkers to support my daughter after the postpartum period, giving her advice, guiding her during the breastfeeding period. But this is not the case for many moms in Connecticut. This is not the case for many women that are underserved in the state. I honestly support the bill because it will give the pregnant women in Connecticut the tools they need to understand what services or what outcomes they see on every hospitals. For me, the Connecticut Mental Health Report will provide real data to the residents of Connecticut. And in addition, this will help to support and intervene with hospitals because we also have to look at the data and see how we could support a hospital or work with the hospital to improve, the outcomes. For this reason, I support the implementation of the act. Thank you.
Ms. Cruz, thank you so much for spending your time with us and for testifying in support of this bill. Seeing and hearing no questions, we will actually take a very brief recess. We need to deal with our Zoom.